or you have each of these as single failures. Then you have grade 2 where you have 2 organ failures, so grade 3 and then 3A, 3B. So this is almost like 6 types of different grades of organ failures. Here in Excel, you have simple 2, 3 or all 4 organ failures. They have written all 4, but there are 2 more which you can have circulatory or maybe metabolic. While in a puzzle, there is no organ failure and it is simply a dynamic grade which is 5 to 7, 8 to 10, 11 to 15. And what is the relevance of this? So organ failure, does it determine the outcome in ACLF? Way back in 2010, and this paper was shuttled by everybody till they got this concept. A puzzle was the first to give the concept of organ failure. So one organ failure, mortality is about 20 to 23% or so. 2 organ failures, it could be 60. 3 organ failures, it could be close to 80% or so. And nobody would survive if you have multi-organ failure. This was the very first paper on organ failure in ACLF. Subsequently, we have also shown that single organ failure to 3 or 4 organ failure, the 90-day survival, if you have 3 organ failures, the risk that you will not survive is almost 6 times. So organ failure produces a hazard. It is no doubt about it. But does it make sense for transplant? Let us look at the NACL, the North American Consortium. They actually have ICU. All patients are in ICU. So for kidney, there is a need for dialysis or RRT, HE grade 3 or 4, circulatory shock is there, and respiration need for mechanical. All are red lights. Let's look at the canonic study. Here, the single liver failure was only in 14%, kidney failure in 18%, while 3 or more organ failures were seen in 3/4 of the patients. So they also had people who had mainly extrahepatic organ failures. Liver was only 14% and they call it as ACLF. Let's look more closely to the scores developed in and based on the data of canonic study. The green means they are still okay. They are okay means here you can see creatinine is divided into 2, less than 1.5 or 1.5 to less than 0.2. Here there is a lot of controversy. The yellow or the color shows you this is not good. So they consider this and give just 1 point. Earlier it was in this area, now it has been brought here. All these red means this is not acceptable. They would not be good for transplant in one way or the other. So you create about 2 or you have a renal replacement therapy or so if somebody has a score of 7 or more, high mortality, obviously you can see that these will all have very high mortality. Or a cliff ACLF is more than 64 will have high mortality. The 2 circulation and respiration, which are not in Excel in one way, are extremely important. Now, what is the relevance of organ failure and outcome? Look at the ACLF1 mortality at 28 days based on 3 to 7 days after diagnosis. So if you have this score and you wait till 28 days, at 28 days, grade 2 has mortality of 34%. Grade 3A, which is 3 organ failure, is also 34%, which is double of ACLF1 at 28 days. Meaning thereby, if you just use organ failure, then based on organ failure, you will have 2/3 of the patients transplanted for no reason. You have ACLF2 transplant, ACLF3A transplant, while 67% can survive, but they will be transplanted because they may die. There is no difference between 2 and 3A, and this is very recent data from whole of Europe. Another publication which came a month ago If you are using the ACLF definitions, can you list them for DDLT? ACLF 1, only 64 concordance in 3 US liver transplant centers. ACLF 2, only half have concordance. They can't even classify patients. ACLF 3, 64% concordance. So the message I want to give you here is based on organ failure, you cannot even qualify a patient as ACLF 1, 2, or 3. And if you qualify, the outcomes may not change between 2 and 3. And this is 2 organ failure, this is 3 organ failure. So organs rarely fail in isolation. They fail concurrently. You can't have just a person who has got HE but has nothing else, or he may just have circulatory failure and nothing else. Therefore, in my opinion, for liver transplant, just organ failure is not good. You need to have a proper phenotype. In the recent publication by Just Bajaj in American Journal Gastro, which is this is a review and their guidelines, they have used the apostle, easel, and Naxalt and given what are the major ACLF definitions. Here you can see that in easel cliff, you have liver, you have kidney, HE, MAP and vasopressors, and PaO2. But what is more important, you are combining hepatic and extrahepatic organ failures. While in ARC, you just have portal hypertension, liver failure as its main criteria. Now, I'll just go through one more time for definitions and then I'll come to the organ failure part. So, normal liver, insult, ALF. Decompensated cirrhosis, insult, you will have a natural history which is different than ACLF, but they include it in ACLF. The person may have sepsis, bleed, AKI, HE. A simple CLD F3, F4 fibrosis. If he has jaundice followed by ascites, acute portal hypertension, or a compensated cirrhosis who has jaundice and ascites, this is the group that is classically as liver failure, acute on chronic. If this person has ascites, if person has HRS, kidney involvement, sepsis, respiratory, GI bleed, these are multiple variables. They should be out on a different platform. So ARC provides a homogeneous group of patients while CLIF and others provide many heterogeneous groups of patients. That is why they cannot qualify. They have put them into grades. The second question is the type or number of organ failure. This was the main topic assigned by Neeraj. So when you look at the ACLF, liver, in our opinion, is the driver. It is the index organ to fail. Jaundice, coagulopathy, encephalopathy, lactate, which is a part of liver failure, and the sister organ, creatinine. So let's look at the ARC score carefully. Bilirubin high, 22. HE is not there. INR is between 1.5 and 2.5. Lactate is around 2. And creatinine is between 1 and 1.5, not higher. Even this is given 2 points. This brings you to an ARC score of 10. So this patient at ARC score of 10 is stable. And this is given a liver failure grade, grade 2. 4 days later, this person now has create just above 1.5, let's say 1.7. Lactate has increased, INR has increased. All these are markers of liver failure. And now his score is 13. He has not gone in HE, but has coagulopathy and high lactate. So his score now is 13 and he is ACLF, ARC ACLF grade 3. What is the relevance? If you have 10, then this rise of 1 unit from 10 to 11, mortality may increase, may be much more. But if you have a score of 8 and you increase to 10 or 9, mortality increases just by 4 to 5% in 1 week. So up to 10 ARC score, which is a dynamic score, you are okay. But now you have 11 score. 1 unit increase and mortality increases by 20%. So this is a way of saying all organs matter, just not organ failure of one or two. This gives you a dynamic score. And when you compare this CRRT score with Cliff SOFA or MELD or SOFA, it scores much better. Now let's look at different studies globally. So this is a study where liver transplant, about 3,500 odd patients. There was a training and a validation cohort. They used the ACLF3 as the canonic study. What have they shown? They have given a TAM score. TAM score is arterial lactate is high, mechanical ventilation is present, age is above 53, and the patient has low leukocyte count. If somebody has a TAM score of 2 or more, maybe 3 or 4, you can see the mortality is high. This is also a dynamic score. What I want to stress here, it is not based on organ failure. It is based on multiple variables, and they use at least lactate, which is part of our liver failure score. Which patient liver transplant is futile? So I got into the details using ACLF3, whether we use ARC or whether we use NextCell or others. The 30-day mortality, if somebody has ACLF grade 3, is close to 80% or above. We did a survey, which we should have published, of 84 centers from Asia and all across the world. The reason for not transplanting, at least in half of them or more, was sepsis. And 2 or more organ failures was in 23 out of 84. This is just to tell you that when the stage comes of sepsis or organ failure, it is too late. So if your ARC score is around 9, 10, you should start listing, and by 11, you should be ready for transplant. Let's look at other data from the West. This European and American data says if you have a critically ill cirrhotic patient, which is in a way ACLF, what are the reasons where you will postpone a transplant? Fever, leukopenia, pneumonia, SBP, not treated well, prior infection. So infection and major organ failures will include respiratory, circulatory, metabolic failure. So in such patients, you will not be able to do transplant. Here you can see that PaO2 FiO2 ratio of less than 150, majority will not do, or a lactate which is about 12, out of question. A fair number will not even do if the lactate is above 9. If the person is in NORAD of more than 2 or has, patients would be on intensive care, they would not be taken into a transplant list. Here is a clear no to transplant. Severely frail, score is above 7. One of the following, which I've already listed out, including the PDR, and one of the following here includes a lactate of 9 or a norepinephrine of more than 1, or worsening clinical course, will not be transplanted. This is a very important slide just to tell you what Jonelle, Rebecca, and the whole Easel Cliff is saying. Relative contraindication for transplant. For alcoholic, uncontrolled psychiatric problem, their SALT score is more than 5. The infections are present and not treated for at least 48 hours, uncontrolled HIV, bleed, hemodynamic instability, PO2, FiO2 less than 150, and Cliff SOFA is above 64. What I want to stress upon these are almost futile transplants. So why should we go to that stage when we can't do much? In my opinion, therefore, I summarize this part, type of organ failure is more important than number. So putting into ACLF grade 1, 2, 3, at least for transplant, is not worthwhile. And to me, best score is a dynamic score, comprehensive whole body score rather than organ failure score. So the way I would like ACLF to be managed today is that when the patient comes on day 0, look for sepsis and try to optimize, prevent organ failure rather than wait for organ failure to define ACLF. Don't do that, it will be too late. If the MELD is above 30 or ARC score is above 10, then straight away transplant. If the ARC score by day 4 to day 7 improves, then you can manage medically. So let's say it was 10, it has come to 7 or 8, hold on. If it is increasing on day 4 to day 7 to 10, 11 or above, then emergency transplant like ALF. If the person has, using Cliff and other, has already 2 organ failures or more, then like he is ACLF grade 2 or 3, I would rather optimize him and stabilize him by artificial liver support or plasma exchange and then take up for an emergency transplant. It is very well known that if MELD is above 30, outcomes are poor. If he is not improving, supportive care. And of course, if the person has ACLF grade 3B, which is 4 or more organ failures, which they want to transplant, I would say do a supportive care. I therefore urge that despite our limited and zero financing, ARC and ARC Score and APSL Research Consortium is doing reasonable scientific work. So join hands and make this proud. Don't just follow what the West is saying. Thank you all for your kind attention.
Thank you very much, sir. And what you said seems to be very, very logical, because cardiorespiratory failure, even in EASL, they say it is a futile transplantation, and it is mainly one organ, and that will include the liver, basically, which will lead to transplantation. Any questions anybody has for Dr. Sareen? Talk is now open for discussion. And I don't see any questions in the chat box. So any question anybody has? Raki, I'm sure you are following the same system which Dr. Sareen has advocated. Yes. What about other units? Dr. Subhash?
Sir, what a pleasure to see you once again. Can you hear me?
Yes, I can hear you.
Yeah, I think we have a little difference with what Professor Sareen has said. The reason for the difference is that people who come to us expect them to be transplanted. I mean, there's been a major treatment bias in this country, which is strangely, although algorithms are good, but a person who's come to you, he knows the score, he knows what has happened to him. He knows that without transplant, he's not going to make it. So we get a different sort of perspective on things. I mean, and if we don't transplant them, you know, I know the results may be quite bad at times, but they have come to us very clearly. Our mandate is that we should transplant them. And so we are in a difficult situation. Of course, we can prolong them, we can sort of procrastinate, we can say it won't be helpful, but they will often make statements that, you know, even if there's 0% chance, we want to take it. So there's a little difference with, you know, algorithmic approach that Professor Sareen had.
If Dr. AC allows me, the question is not if you transplant, at least you give him a new lease of life by giving a new liver. It's no debate on that. The question here is, would you believe that you have to wait for an organ failure to be defined? And would you just say, okay, organ failures are required, and then we transplant? I mean, he may not have, it may be organ dysfunction only, and you would still transplant. Probably creatinine is not that high, but he has circulatory failure or he has other problems. So the question is, do organ failures are mandated to get transplant?
I think that is a later concept. I think somebody with cirrhosis, advanced cirrhosis, and who's had multiple whether if they have organ failure, the outcome is going to be worse. But cirrhosis itself is an indication for transplantation.
Dr. Subhash, what would be your criteria for calling futile transplant? A patient with cardiorespiratory failure or a patient with sepsis-induced organ failure?
Who's more than 3 mics per kg, but 3 mics per hour of NORAD, complete no-no. PaFiO2 less than 150, complete no-no. If there is infection from an organism, such as Candida auris, or a resistant that is just not sensitive to anything, although the patient may be well, we will not transplant him. And if they have mucosal bleeding, not varicose bleeding, mucosal GI bleeding that you see in sort of, advanced hypertensive patients with mucosal bleeding, which is different from varicose bleeding. We've discussed this point a number of times. We would not take them up for transplant. In them, it will be a complete futile exercise.
Dr. Narasimhan, Dr. Pamecha, would you like to make a comment?
Yes, sir. Thank you very much, Dr. Anand, for letting me ask Dr. Sareen. Sir, enjoyed the talk. Very nice, sir. Sir, one of the things with transplantation is availability of donor, basically whether you have the liver or not. Will your perspective change if you have a cadaveric liver available to you, although the patient is sick?
It's a very good question, Vinay. I then will become probably more careful and see that the organ doesn't go waste. I would definitely not use that organ in a person who is septic or who has poor lung or circulatory thing. In DDLT, it will be, although a bit biased, but if the relatives are still okay, you can say, look, the outcome of transplant in a person who has an ARC score of 13 or 14, maybe 50%, but at least he will survive 50%, and otherwise he would die totally. So this is the only thing, but I will be more cautious in a deceased donor rather than in a LDLT.
And Dr. Sareen, would age be a factor in your decision making? Age of the recipient?
I think the transplant surgeons never think biologically that way. Like you, I think you would take up to 70, 72. But yes, above 75, I would be very hesitant for a transplant. But I think we should extend all of us, at least I feel, from 65 to 70, up to 75.
Maybe nutritional status and performance status would probably decide. If the person is absolutely fit at 75, probably he can also be transplanted.
I agree.
We kept a ceiling of 65 because I think it becomes a bit ethical to have someone younger undergo major operation, someone that old. But But it has been done, isn't it? Twice we've broken the rule. One was the family member said that in our family they lived till the age of 95. All his brothers. But twice we've broken that rule.
There is a question from Jaipur by Dr. Prabhat Narayan Sharma. If there is a trolley after a post-PRBC transfusion, will it be considered organ failure or not?
Well, as long as the PO2 FiO2 ratios are maintained, I wouldn't bother that much. Although the risk may become high because it can evolve into a severe pneumonia later. But I think by that time you can manage this well. So I wouldn't bother as long as the ratios are okay.
There are a couple of more questions, but I think you have answered those questions in your talk. So I'm not asking that.
Yeah, I think we're probably the time is
overstepping the time.
Yeah. So
all right.
Thank you.
We'll move on.
We can move on to the next session, which is actually a debate. And debate is between Dr. Epan, who is going to speak against, and Dr. Subhash Gupta, who is going to speak for the topic. And the subject is therapeutic plasma exchange in ACLF is not curative and only a bridge to liver transplantation. So I'll first request Dr. Subhash Gupta to speak for the topic.
Thank you. Can I share my screen? Will you have, do I have the privileges to share my screen? I think somebody will have to allow me to share the screen. I think the organizers have to allow me to share my screen.
Sir, you are allowed to share your screen. No problem at all. You can do it from your side.
Is it better? uh, connections. So my job is to make a case for liver transplantation upfront. Am I right, Dr. Neeraj and Dr. Anand and Dr. Shweta, whom I can see, is to make a case for upfront transplantation in sick patients. That my brief to make a case for upfront liver transplant. Okay. So I'm going to speak that total therapeutic plasma exchange is not curative as only a bridge to liver transplantation. And my arguments for the motion are, and I'm quite aware that that Dr. Epan, whom I respect so much, the very sort of acclaimed hepatologist, and he's going to shred me into pieces. But yet, I will say that liver transplantation for ACLF is a highly successful treatment, and the same cannot be said for therapeutic plasma exchange. And if alcoholic steatohepatitis subset were removed from ACLF, the results of total therapeutic plasma exchange will be even worse. Plasma exchange is not curative, quite expensive, at least in our hospital, costs between 1.5 to 2 lakhs per session. Adverse reactions may delay transplantation by providing a false hope of recovery. And in patients who really would benefit from it, those with circulatory, respiratory, renal failure, do not tolerate plasmapheresis well. Now, if someone were to make an argument based on that Expertise for liver transplant not widely available in India. Liver transplant is very expensive. Donor morbidity and mortality is insignificant. Long-term results of liver transplant are poor. Then I have lost the debate. I will not. Then I think not only lost the debate, I've lost my life's mission. Spent 30 years in this country teaching, promoting, spreading the art and craft of liver transplantation. And yet, if we say that, these things are not possible, then of course, I've lost the debate with bowed humility. I will not discuss this any further. So we all know what happens in ACLF, that if you have a true diagnosis of ACLF, that by definition, 50% of people are dead by 3 months' time. So that's nature of ACLF, and this is from canonic study, the natural history of ACLF. And if you're on top of it, you have organ failure, then of course, mortality is worse. And the initial sort of results for liver transplantation for ACLF was also quite poor. At that time, we surgeons, we like operating on neat, clean patients so that we finish at 3, 4 p.m. in the afternoon, go home, have a drink and relax with the family. But you start transplanting sick patients, then you become like anesthetists. You are sort of struggling till late hours in the night. And initially, we didn't know how to transplant patients with organ failure, and the results were very poor. And in fact, this is taken from a German series, and the patients who were transplanted, who were on vasopressors or mechanical ventilation or renal replacement therapy, the great majority died. But those who survived had a shorter stay and lived longer. Later on, from Germany, a completely different experience emerged from France, which showed that ACLF3, and this was actually a result because with the M.I.C.E score, sicker and sicker patients were getting transplanted. So obviously people were getting comfortable transplanting very sick patients. And therefore ACLF3 were transplanted. And here, every patient post-operatively had a complication, but yet a 1-year survival of 83.6% was reported. And going across the pond to America, you find that they're even bolder than the European and the surgeons, that even with 5 organ failures, we had a decent success rate after transplantation. And what became clear that the organ failure had probably had more impact on outcome than the sodium scores. And in fact, if your sodium scores were less than 25, and you had organ failure, then you did worse than those who had higher scores, sodium scores, but no organ failure. Possibly because both the entities were completely different. In one, organ failure and infection was an integral part. At the same time, ACLF without transplantation had very high mortality, and therefore transplantation is getting popular for patients who have advanced ACLF. Those with DDLT data. What about living donor liver transplantation for ACLF? There are inherent problems with living donor liver transplantation, smaller graft, multiple anastomosis, myriad technical complications, and donors are not that abundant. You may think that in living-related transplant donor, but they are not. They may have fatty liver, they're unwilling, there's some legal clearances, many issues are there as well. And worst for a surgeon is to have in a sick patient that you sort of have an orphan graft. That means the graft has been taken out, but the recipient is dead. And so the living donor liver transplant, ACLF3, is still in its infancy in this country. And therefore, perhaps on this ground, it may be a justifiable case to persist with therapeutic plasma exchange. But if you look at the published report, because perhaps the negative reports don't get published that much, the positive reports are that Taiwan showed excellent results from liver transplantation for ACLF. Avisoin's group reported excellent outcome for liver transplantation for ACLF3. Similarly, Professor Lee, but interestingly, Professor Lee reports are slightly different from others. He actually showed that the ACLF group had a poor survival as compared to the non-ACLF group, which is a bit different from the other centers. With the Taiwan, CL Chen said that, the reports, the living donor liver transplant ACLF has excellent results. And if you look at the published data on ACLF, the earlier the transplant is done, the better the results. So even a delay by 1 day. So if you look at the white column, the sort of the lighter column suggests where those were done on the current level and those were delayed, and the outcomes were sort of, and this applied across the number of organ failures involved, and therefore there is a important case that they should be transplanted early. Similarly, across the DDLT groups, if the transplants are done within 2 weeks, ideally within a week, but if done within 2 weeks, again, you had good results. And even in the sort of worst case scenario with maximum organ failures, greater than 0.8% survival probability was there with liver transplantation. So now coming on to the sort of what is being made, it's a match between someone who's very well endowed versus someone with limited resources, and therapeutic plasma exchange is in that category. But the popularity for therapeutic plasma exchange came from this paper from Larson in 2016 for acute liver failure, showed that if you did therapeutic plasma exchange in patients with ALF, then you had better survival. Interestingly, there was no survival advantage by doing high volume plasma exchange in patients who underwent transplantation. So obviously transplantation is the first choice yet again. Now, what I've done is I've looked at all the sort of the published data on therapeutic plasma exchange for ACLF. And what I find interesting is they report outcomes at 4 weeks. Now, if transplant surgeons started reporting outcomes at 4 weeks, they would have 100% survival. No doubt about that. So much improvement has happened. But you look at survival 60. So the first one, Meng, said that survival at 4 weeks was 63% of people survived, died versus 82 at standard therapy. And many of these series actually did not have cirrhosis, which is again a sort of a point that I repeatedly make, that if you remove the alcoholic steatohepatitis from the true ACLFs, you'll find that the results of non-transplant treatments are much, much poorer if you remove the... In fact, in 2015, Zhao reported sort of results of plasmapheresis, and only half the patients had cirrhosis, as you can see here. And similarly, sort of umbilical cords, mesenchymal stem cells, only 61% had cirrhosis. And whereas, and in fact, out of these trials, only one had sort of Zhu in 2013 actually looked at it with liver transplant. And this is a meaningful trial because in this, liver transplantation was considered, and they showed that those with the sicker patients, if they underwent plasmapheresis and then went on to have transplant, they had better results. So in fact, this is the only sort of meaningful data that I've found after going through all the sort of published data on therapeutic plasma exchange for liver transplantation. The only sort of randomized trial, which used some Chinese criteria for ACLF, which was bilirubin was more than 10, and there are 234 patients, but yet at 4 weeks, 40% of patients in the pulmonary exchange group died, and 53% with the standard medical treatment died. But interestingly, they had a 5-year survival of 57% and 69%. Obviously, many of these patients did not have cirrhosis. And in fact, what they have said, that only 69% of these patients did not have cirrhosis. So obviously, the data for therapeutic plasma exchange for ACLF is far from providing any sort of hope for these patients of ACLF. Now, if you look at very sick patients in whom, even if you do plasmapheresis, then the survival is poor in very sick patients, who were suggesting that they probably benefit only from liver transplantation. So what are the pitfalls of the various studies that we've seen for ACLF? Different definitions have been used, different plasma exchange protocols were followed, and there's only one randomized controlled trial in which 69% of the patients actually did not have cirrhosis. And in all the studies excluded the option of liver transplantation, and almost all studies were conducted in Asia with hepatitis B as etiology. Now, therapeutic plasma exchange is not sort of a straightforward situation apart from the expense, the side effects, skin rash, hypotension, hyperkalemia, bacteremia. And these are a significant number. And whether these sick patients will tolerate these side effects is not known. And Professor Serene and others have talked about the ARC score and the Cliff SOFA score. And obviously, in these categories, when the patient is very sick, either you leave them alone, or liver transplant is the only thing that can give them some hope for survival. And the ARC group repeatedly said that once you're on grade 3, then perhaps you should be considered for liver transplantation from the published data. The question that was asked earlier, and I'll repeat again, in person who's in septic shock, BP is not recordable, obviously you cannot do transplantation, but we need to have some ceilings, and the ceilings that we've set and others have set is PaO2 FiO2 ratio less than 150, inotropes NORAD less than 3 milligram per hour, lactate greater than 5, and mucosal GI bleeding, not the varicose GI bleeding, and of the infection from an organism which is multi-drug resistant. And also share some ACLF data from our center. And these are patients who ACLF grade was considered at the time of transplantation, not patients who had improved their condition and become stable, but they're patients at the time of transplantation. So we had a total of 146 patients underwent transplantation. 19 had grade 1, 57 had grade 2, grade 3 was 64, and this was between 2017 2022. Majority were ethanol, some were viral, and we did other conditions. We lost 24% of these patients post-transplantation. The average CLIF-C score was 53, MEL score was 33, ICU stays were long. And if you looked at mortality based on grade, only 1 out of 19 we lost in grade 1, 8 out of 57 in grade 2, and 27 out of 64 in grade 3. I'm thankful to Dr. Shweta, who compiled this data for a group, and actually she's writing the paper on this, on ACLF, results of living donor liver transplantation with ACLF3 at the time of transplantation, not those whose condition was improved and then went on to have transplantation. So the non-ACLF group probably had the best survival, the ACLF1 similar survival, probably better than non-ACLF. And as the grade worsens, then outcomes worsen. And ACLF3 at the time of transplantation is only 52% survival. But yet, if this is the same information in a sort of graphic manner, and at the same time, patients who did not have transplantation, they did poorly. And if they had ACLF3 and if they didn't have transplant, they all died. So in the end, I would like to conclude that in ACLF, data on plasma exchange focuses on short-term survival, while data for liver transplantation looks at long-term survival. As I said earlier, if surgeons were to report 4-week survival, then we would have 100% results. In patients with lower MEL score, plasma exchange may offer some survival advantage. And in ACLF, patients with MEL more than 30, plasma exchange may act as a bridge without having an impact on outcomes. And I would request advocates of plasma exchange not to use arguments such as that the lack of liver transplant expertise, lack of donors, or costs of liver transplants are enormous, or liver transplantation long-term results are poor. Thank you very much for a patient hearing.
Thank you, Dr. Subhash. You made a very convincing case. And may I now request Dr. Rakhi Maiwal to invite the next speaker, conduct the rebuttal and the discussion. And Dr. Narasimhan can then invite the third speaker.
Yeah, it's a pleasure for me to invite my teacher and a very great human being, of course, Dr. Epan, who's the head of the Department of Hepatology at CMC Vellore. So, sir, we would like to hear from you, and I'm a proponent of plasma exchange, and I hope that we'll fight it out. Over to you, sir.
Thank you, Raghi. I always tremble a bit when I take on Dr. Subhash Gupta. So I'm not certain whether I'll do the job, but I'll have a go. Let me try share my screen. Okay, is my screen visible?
Sir, can you put it in a slide mode, please?
Thing is, on this particular computer I'm using, the slide mode doesn't move. So I'll request you to bear with me. I'll try to make up with the what I explained verbally. So after listening to Dr. Subhash Gupta, I must say I'm almost convinced of his point of view, but I beg to state that this is a spectrum of disease, and surely there must be patients who are earlier in the disease severity where we can salvage with less severe treatments or less expensive treatments. So I am batting to say that I disagree that PLEX, we call plasma exchange as PLEX. PLEX in ACLF is only a bridge and it is not curative. So I must start with the disclaimer. The disclaimer is in contrast to what Dr. Subhash Gupta said, my situation is the opposite. At CMC Vellore, we have a pure cadaveric liver transplant program. And in this year, we had 1 transplant per month. Now, this again reflects a large part of India. That's a reality. Now, so thereby, we are biased towards non-transplant treatments. And the patients who come here, somehow, at least those who are informed, would have worked out this as well. So maybe it is for that reason that in the last, from 2017 or so, now we have crossed 320 patients who underwent PLEX for liver failure, liver diseases, and almost 50-50 would be acute liver failure, acute liver injury, or ACLF. So the ratio of number of patients who undergo PLEX to liver transplant is very different for us. The attraction, I guess, with PLEX is if you find the correct slot, it's possible more and more centers in India can offer this therapy currently. So let me talk a bit more about PLEX, plasma exchange. It has 2 arms. One is removing the plasma, that is plasmapheresis, from a person who's in ill health and replacing the fluid in liver failure. Fresh frozen plasma is the preferred fluid replacement. These 2 arms together is called plasma exchange. In the adult, there is 5 liters of blood and about half is plasma to 2.5 liters is plasma. Currently, 3 types of volume replacements or volume exchanges have been described in plasma exchange. When Dr. Subhash Gupta referred to the Larsen paper, they used high volume plasma exchange in acute liver failure patients, where 4 times the plasma volume was exchanged per day. Raki, Professor Sareen and team have described the efficacy of standard volume plasma exchange, that is 1.5 to 2 times the plasma volume exchange per day in patients with acute liver failure in this paper. In these 2 papers, we have described our experience of using half volume plasma exchange, that is 0.5 times the plasma volume, which is often the volume used in different other conditions, for example, Guillain-Barré syndrome in neurological diseases. Now, this paper from ARC, Raki is the first author, the multinational database of APASL ACLF patients, majority of whom were alcohol and etiology. When they used a propensity risk score matching, there were 208 patients. They could show that plasma exchange and adsorptive treatment improved SARS, while plasma exchange scored over the adsorptive treatment and standard medical therapy in the number of deaths, as well as it improves the inflammation. So the paper concluded that PLEX appears to give a significant survival benefit over adsorptive therapy and could become a preferred modality of liver support in ACLF. Now, I find this article very informative. I really loved reading it. Again, it's Raki and Professor Sareen. It's very informative. This is proposing an algorithm of management of ACLF focusing on plasma exchange. And as Dr. Sareen mentioned, it talks about the number of organs fail. There can be no organ failure, single organ failure, or multi-organ failure. The paper also talks about the type of organ fail. And it says that renal and brain failure in a person with in ACLF could be considered organs of utility, in that there is a potential for survival either spontaneously or with liver transplantation. While circulatory and respiratory failure, I must say, it's a too provocative a term, but they use a term of organs of futility, where liver transplant is contraindicated in these patients. So, which are the futile sections? So, when a person with these organs of futility, if they fail, circulatory or respiratory, they say do not undertake liver transplant or such treatments. Or if there is more than 3 organ failure, which is not responding to supportive care, organ support, it's futile in therapy, is what this paper proposes. What about emergency liver transplantation? So in this paper, it says that if there is brain failure, encephalopathy, liver transplant is possible. If the multi-organ failure is less than 3 in number, or when there's no organ failure and the MELD is more than 30, they are proposed to go for emergency liver transplantation. What about plasma exchange? So the paper proposes that plasma exchange could be done in these organs of utility failure. That is, mainly they've talked about brain here, encephalopathy, bridge to liver transplant, while renal, they propose can happen, a spontaneous survival could happen without liver transplant. Or in no organ failure, if the MELD is less than 30, it says maybe there's no transplant, or more than 30 is transplant. So today's debate is really between these two categories, where in this diagram, PLEX as a bridge to liver transplant in a favorable or organ of utility failure, or no organ failure and severity of MELD. That's what, as per this diagram, that's what it will go. So now I come to my rebuttal. So I will start like this. We all know that alcohol is the commonest acute and chronic insult in ACLF. For example, this paper, Shalimar is the first author of more than 1,000 ACLF patients by APACL definition by the INACL group, had both acute and chronic. Commonest etiology was alcohol. 42% of patients died within the hospital stay of 8 days, and organ failures predicted death. So thereby, I am now focusing on alcoholic ACLF for my next rest of my rebuttal. So liver transplant is increasingly coming into vogue in ACLF, and it's a complex topic by itself, and Dr. Subhash Gupta has already touched upon it. So let me share some data from our experience at CMC of using PLEX to treat alcohol-related ACLF. Now, this paper has just come out in JCEH journal, where we have reported a preliminary experience of patients with alcohol-related ACLF who also met criteria for severe alcoholic hepatitis, and the time period of treatment was 2017 to 19. The patients were treated with low volume plasma exchange and a low dose steroid. So there were a total of 50 patients, 21 underwent plasma exchange and 29 standard medical therapy. The DF score shows that all of them had severe alcoholic hepatitis. This was low volume plasma exchange, and we gave 20 milligram prednisolone for a 1 month time period. Not very impressive, but over 1 year, it looks like the survival is starting to improve when we compared plasma exchange to standard medical therapy over a 1 year time period. And maybe at 90 days, it looked a little bit better. So we concluded that in this preliminary report, low volume plasma exchange and low dose steroid improved survival of 1 year compared to standard medical therapy in these patients. And of the 10 patients with renal dysfunction, 60% improved, the renal dysfunction improved with plasma exchange. But now further analysis of ongoing work here suggests that when we use centrifugal type of plasma exchange, the survival is better compared to membrane of filtration type of plasma exchange. So let me share this data. This is work in progress. However, Santosh Kumar has presented this at a presidential poster in the ISG Con this year. So now it's a 4-year time period of study. All patients met criteria of alcoholic ACLF bar severe alcoholic hepatitis. None opted for liver transplant. How did we choose between centrifugal versus membrane plasma exchange? Now, initially, on the day of the procedure, which machine was available was what was taken, really. But as it went along, from October 2020, as we started noticing better results, all patients are getting treated only with centrifugal plasma exchange. And the primary outcome has been then to compare survival between these two modalities, types of plasma exchange over 1 year. So again, when we combined the patients together, there were a total of 56 patients now who underwent plasma exchange, both the centrifugal and the membrane or the filtration type of plasma exchange versus standard medical therapy. There was again a marginal improvement in survival when you look at it over a 1 year time period. Please note that the standard medical treatment group did not receive steroids because that has been our protocol in patients with ACLF. But when we subclassify them and analyze them as per the different modalities, this is the standard medical therapy. Clearly, centrifugal type of plasma exchange, the survival is better. And in fact, in the membrane type, they actually seem to do worse than standard medical therapy. As you can see, the median survival now here, the centrifugal group is 392 days compared to 36 and 46 days here. This is show the same data analyzed in another manner. So in the centrifugal group, at the end of year 1, about 55% of patients are alive, compared to the membrane group where 5% of patients are alive. Now, this is not a randomized controlled trial. However, when we look at the different parameters, they seem to be not significantly different. There were a proportion of patients who had raised creatinine and encephalopathy more than grade 2. These are the reticuloendothelial parameters we are particularly interested in, of ferritin and von Willebrand's factor. They were elevated in these patients. Now, all of these patients had DF more than 32. So they all had severe alcoholic hepatitis. This is the MEL score. All of them met the APASL ACLF criteria. By the EASL ACLF score, in the centrifugal group, 42% did not have ACLF, compared to the membrane group, where 70% ACLF. Grade 3, which Dr. Gupta rightly so is pointing about liver transplant, is a smaller number here. Our focus seems to be that we are subselecting the patient with earlier or lesser severity of disease. This is survival analysis on univariate analysis and multivariate. With multivariate analysis, only 2 parameters independently predict survival. The type of plex, centrifugal plasma exchange, independent of the EASL CLIF score, predicted survival, as well as the EASL CLIF score grading per se predicted survival. Now, why is this so? Now, as I said, this is a work in progress, and these are just some initial thoughts that we have. When we compare the different technical parameters between the 2 treatment procedures, the amount of blood or plasma which is taken out and flows through the machine for the exchange procedure, the flow rate is much less in the patient with centrifugal plasma exchange compared to membrane. We believe that by taking out so much at this flow rate, it predisposes the patients to more hemodynamic fluxes, which may thereby cause the person to hypotense or need inotropes, and then upsets the whole physiology. Lastly, how does plex work in ACLF? We've been focusing on this very interesting molecule, von Willebrand factor. I will not go into details of it because that's not the mandate nor the time for this talk. But in multiple publications, we have shown that von Willebrand factor, VWF, is a MELD independent predictor of mortality in ACLF patients. It's a very potent predictor. Now, in this analysis I just now showed, when we start treating patients with plex and low dose steroids, VWF no longer predicts survival in these patients. So it's giving us a clue how this is one of the parameters which how the inflammation is reducing, acute inflammation is reducing in this group of patients, as I show it here. in the multivariate analysis, VWF no longer figures as a predictor of survival. So to conclude, this is my last slide. Let me declare Dr. Subhash Gupta has won. But he's won it in ACLF grade 3. But in the earlier, less severe disease, surely there is a case for plasma exchange where that's been our experience. Increasingly, we see people, whether the earlier patients now series now across 1 year, 2 years, 3 years, and who are alive and well. Okay, so it's bound to be that this group of patients are there with all of us as well. Thank you.
Thank you, sir, for that wonderful talk. And we can have rebuttal from Dr. Subhash.
I dare not rebut such a revered person, Professor Ipan, but he's actually said the things that I wanted to say very nicely. And in fact, we all, both of us speaking similar language, said that liver transplantation strangely is not, living donor particularly is not available throughout India. And, but I said that if that is the argument, then obviously, I've lost miserably in life. After 30 years, we haven't been able to spread the craft of liver transplantation. We've done very poorly. The second thing that he's very nicely highlighted, which I keep saying, that you must remove alcoholic steatohepatitis from ACLF. Because when you start including alcoholic steatohepatitis in ACLF, it completely confuses the picture. These are group of patients we all know do differently as the classical ACLF with cirrhosis and organ failure. But unfortunately, in every analysis, every report that I find, but Professor Ipan has been very nice to me. He's clearly said that many of his patients were alcoholic steatohepatitis, which we know are potentially reversible, and they'll go on to live many, many years. And finally, he has also highlighted a very important point that I made, that plasma exchange is not tolerated well. He's, of course, devised a method to deal with it by doing this centrifugal thing. And perhaps in the next meeting, when we also start using centrifugal, I may change my stance and say that it is a well-tolerated procedure and therefore should be used. But so far, I have not been using I would dare say my inadequacy. I wasn't using the centrifugal method of plasma exchange. But whenever we've used, and Dr. Shweta is here, we've had disaster with the sort of plasma exchange that has been reported by groups elsewhere, apart from the cost of money and the hope that comes to the family that the liver will recover, and then invariably delays what should have been done in the first instance. Thank you so much.
Thank you, sir. And we can have any other comments from the other?
We can have a couple of questions. I think we have a couple of minutes.
So one question in the chat box.
So there's a question about why were grade 1 patients with ACLF transplanted? I think so. It's to Dr. Subhash.
Oh, the answer to that is easy. I mean, you only have organ failure should you have transplant. If you have cirrhosis, you can't have transplant, is it? Is that the question, that only once you are dying close to there you have transplant? So patients cirrhosis should not have transplant. Is that the question?
I don't know, sir.
No, Raki, I'm asking you. You're all the brain behind all the sort of liver work. Only when you have organ failure should have transplant. Cirrhosis,
no, sir, not at all. I feel the timing of liver transplant, what you have already highlighted in your talk, I totally agree. It's not the dying patients. And I've seen a lot of people who the patient starts dying and then we start talking about transplant. That's not the right thing. The first thing is that the timing and the assessment for liver transplant and that thing should come into the picture. And then we need to see these patients, monitor them dynamically, whether we can improve them without a transplant. And if they're progressing, obviously the right time for liver transplant should be given. If the patient has already presented late, that's a second scenario. Then again, you reassess them whether they're improving or not. So transplant should not be kept as the last option. I do not agree with that at all.
Yeah, I think we can probably end this session and move on to the the third talk in this session. Dr. Gomati, would you?
Yes. Yes, next topic is on nutrition in the ICU. I think the sick patient we are talking about is one aspect which is very, very important, but sometimes missed out on the importance level of it. And I invite Dr. Pankaj Puri, Director of Gastroenterology and Hepatology at the Fortis Escorts Liver and Digestive Disease Institute, to enlighten us on nutrition in liver ICU.
So please unmute yourself.
Sorry.
Dr. Puri, please unmute.
Sorry. I apologize for that. I'll be speaking on nutritional care in the ICU. And it's important because patients who have liver disease are catabolic and they have high nutrition requirements. Hypoglycemia is common, and nutrition is often compromised due to several factors. They are kept nil-orally. For example, they have a GI bleed. They may have post-operative ileus or sepsis-related ileus. And they're often kept fasting for procedures like endoscopy, CT scan, etc. The effects of malnutrition in transplant candidates, in pre-transplant, this is associated with increased risk of decompensation and mortality. Post-transplant, it's also associated with poorer outcomes, longer hospitalization, longer ICU stay, and increased mortality, more infections, more wound problems, and poorer growth in children. The various issues which we need to cover today would be: what are the nutrition requirements in critically ill patients with cirrhosis? Nutrition in special situations like GI bleed, encephalopathy, alcoholic hepatitis, liver transplantation, acute liver failure. And what would be the role of branch-chain amino acids, which are often a fashion? How do you compare the routes of therapy, which one to choose? And what about enteric feeding formulas? And this is going to be the framework of my talk. If you look at the specific nutritional requirements in cirrhosis, they require about 35 to 40 kilocalories of energy per kilogram of dry body weights, and a protein requirement of 2 to 1.5 grams, the higher amount for malnourished patients. We would assess the body weight by pre-ascitic weight, post-paracentesis, or do empirical correction for ascites of 10 to 15% for ascites, depending on whether it's mild, moderate, or dense, and another additional 5% for pedal edema. Micronutrient deficiencies are important, and they need to be considered because it's quite common to have them in our patients, which would include the fat-soluble vitamins, especially in cholestatic liver diseases, and other vitamins as well. Hyponatremia is common, and often we would administer these empirically, or if we suspect their deficiency. Example is in alcoholics where thiamine deficiency is common, and this needs to be replaced. The next issue to cover is what is the nutrition in GI bleed. In GI bleed, when a patient comes to ICU, it's common practice to stop the oral or enteral feeding, or to not restart the feeding in the first place, either because we want to do endoscopy in the patient, or there is a risk, a perceived risk of increased portal pressure and very severe bleed. There are also concerns on placement of nasogastric tubes because of provoking GI bleed, but these tubes are not been shown to have any increased incidence of bleeding, and they are safe. This meta-analysis looked at the role of enteral nutrition, with early versus delayed enteral nutrition in patients with GI bleed, and they included 5 trials. And early enteral nutrition did not result in any increased risk of bleeding or mortality in these patients. This was a study by Dr. Sandeep Sidhu. Early feeding to delayed feeding, where early feeding liquid diet was given 1 hour after endoscopic variceal ligation, while delayed feeding they were kept nil-orally and liquid diet for 24 hours, and then slowly started on soft diet and regular diets. So they showed that early refeeding with regular solid diet in conscious patients after successful variceal ligation for esophageal varices is safe, provides better nutrition, and results in lower incidence of infections in bleeders versus delayed bleeding. If you look at the group with hepatic encephalopathy, there is the efficacy of nutrition therapy for patients with cirrhosis and hepatic encephalopathy has well been shown, and this was a study which was initially done in minimal hepatic encephalopathy. There has been a common tendency in the past to have protein restriction, and in the 1950s we felt that the lower protein diet improved hepatic encephalopathy, and this was followed on for decades. This changed with the study in 2004 by Koboda et al., who showed that normal proteins for episodic encephalopathy, this was a randomized study where they included 30 patients. In group A, they had low protein diet with progressive increments and a normal diet, protein diet in group B. And they compared the protein metabolism as well as the stages of hepatic encephalopathy, and they found no difference in portosystemic encephalopathy survival or ammonia levels and a better nitrogen balance in patients who were on regular protein diet. And this is one of the beginnings of changing of the protein recommendations in patients with cirrhosis, and there should be no protein restriction, and it would be detrimental. Alcoholic hepatitis, these patients have common nutritional deficiencies. They have a high energy requirements, and protein supplementation is important. But supplementation, nutrition supplementation alone may not be enough for recovery of alcoholic hepatitis, but it will help in improving hepatic encephalopathy, and covering for deficiencies will improve survival. Liver transplantation, most patients are malnourished, and protein energy malnutrition is associated with poorer outcome. And pre-transplant nutritional support is important in critically ill patients. Pre-transplant enteral nutrition has been shown to improve a trend towards improved survival in people who have undergone enteral feeding in this study. Similarly, immediately after transplantation, also feeding needs to be looked after more critically, and early feeding has been associated with reduced viral infections and a trend towards overall reduced infections as well. The post-transplant parenteral support was looked at, and this was shown of TPN versus oral feeding, and there has been a decreased ICU length of stay, improved nitrogen balance, and no difference between the type of amino acids. And enteral nutrition was associated with offset by the expense of the TPN. So post-transplant nutrition support has been recommended basically based on a lot of uncontrolled studies, and TPN should only be used if the gut is not usable and we cannot feed these patients orally. We should restart the enteral feeding within 12 to 24 hours or as early as possible to reduce infection, and consider parenteral nutrition if there's risk of aspiration, the airways are not protected and hepatic encephalopathy is there. The calorie requirement would be standard of about 35 kilocalories per day and a protein intake of 1.5 kilogram per day. Hyponatremia also should be slowly corrected. So the next is acute liver failure. These patients are catabolic, they have high energy requirement. Encephalopathy is there, which reduces their which compromises their oral intake. There's risk of aspiration. And with hyperammonemia, there has always been, as in the past, a concern of how much proteins you can give them. Hypoglycemia is common, and cerebral edema can be worsened by hypotonic fluids. So here again, oral and enteral nutrition are preferred over TPN. In the presence of encephalopathy and altered sensorium, nasogastric tube should be placed, and enteral feeding should be started early. There should be no protein restriction. The standard energy and protein requirements of 35 to 40 kilocalories per day and 1.2 to 1.5 gram per kg of proteins is recommended. The sugars should be maintained between 90 to 120. We should avoid 5% dextrose and consider 20 to 25% dextrose to avoid cerebral edema. If there is hypoglycemia, we should give a bolus of 50% glucose. Now, branch chain amino acids have always been popularized. These include leucine, isoleucine, and valine. In cirrhosis, the muscle becomes an important site of ammonia detoxification. And in the presence of increased ammonia, there are lower levels of branch chain amino acids because this is utilized by the muscles to form glutamine. Also, the cirrhotic patients cannot metabolize the aromatic amino acids, and this change in levels between branch chain amino acids and aromatic amino acids results in more false neurotransmitters that stimulates ammonia production. There are potential benefits of branch chain amino acids in liver disease, but the data has been looked at by a Cochrane review, which showed that branch chain amino acids had a beneficial effect in hepatic encephalopathy, but it did not improve mortality, quality of life, or nutrition status. While overall data may be not so conclusive, favoring branch chain amino acids, it may allow adequate protein intake in patients who are intolerant to higher doses of proteins. The other concern is the amount of calories which goes in with branch chain amino acids, and the amount of proteins and calories for it to get, we can only get the protein content if we land up giving higher amount of calories. So it can only be a supplement and it cannot replace the entire feed altogether. One of the last things to look at is how do you feed them, oral, enteral, or parenteral. Parenteral, as we have discussed, has increased cost, increased complications, and should be considered only for those patients who cannot tolerate enteral nutrition. Or we can only consider it perioperatively in very severely malnourished patients. Tube feedings have been associated and concerns have been there about the risk of bleeding, especially in patients who have varices and coagulopathy, though the former has not been shown to be conclusive. In patients with hepatic encephalopathy, there is a risk of aspiration. There is infection, and IBS may also be, we may not be able to give too much of tube feedings. Patient compliance and discomfort is often the reason why tube feeding cannot be continued. And there are no large RCTs on the issue, but the tube feeding should be considered. Now, this is a meta-analysis which has compared the type of feeding. This looked at 6 trials, 4 oral and 2 enteral feeding trials. And the pooled analysis showed that there was no difference in overall mortality, but a reduction in overall mortality was there in the oral therapy group rather than overall group. The enteral feeding was associated with pneumonias, variceal bleeding, encephalopathy, poor patient compliance, and nausea and vomiting. But however, it's very difficult to compare these studies because these head-to-head comparisons are not there. The patients enrolled were different between bleeding and encephalopathy. Some had bleeding, some had encephalopathy. The baseline nutritional status was different, and the calorie content of the feeds were different. So very difficult to compare these studies. And in the end, I'll just touch briefly on enteral feeding formulas. There are various types of formulas which are available. They can be polymeric formulas. They can be disease-specific formulas. These match a typical diet. They can be pre-digested and semi-elemental formulas, which are really for patients who have short bowel syndrome or who have inflammatory bowel disease or very critically ill. The issues with these formulas are osmotic diarrhea and a poor glycemic control. Most of these polymeric formulas have about 40 to 60% of carbohydrates, a protein content of 15 to 25%, and lipid content of 25 to 40%. To be able to give the nutritional requirements, we need to give about 1 to 1.5 liters of the standard formulas. Hepatic formulas have been touted for patients with hepatic encephalopathy and liver disease, but they have a lower protein content. They also have some additional components which are proposed to attenuate liver injury, like SAMI, and carnitine. But really, the hepatic formulas and lower proteins are only for patients who cannot tolerate standard formulas. As far as possible, if a patient has a functional GI tract, we should give oral, and only if we cannot give oral, we should consider parenteral. Most treatment should be based on polymeric formulas, and hepatic formulas are better avoided because of lower protein contents, and additional branch chain amino acids can be considered in people who do not tolerate higher protein intake. One of the most important things while prescribing a formula is you should know the contents of the formula. These are sort of notes in my diary, in my phone, as to what is the protein content. I just picked up some at random, which are there, which are commonly used in the ICU. And we look at the protein content and the calorie content. And we must have this, because if you look at the scoop sizes are different. The protein contents are different. Some is a 8-gram protein, some is a 12-gram protein scoop. The proteins are different, the calories are different, the scoop sizes are different. So we must know how much we are giving. To conclude, ladies and gentlemen, nutrition therapy can decrease the risk of complications and improve survival. Adequate proteins can safely be administered to patients with encephalopathy, and supplemental intake by enteral nutrition if inadequate oral intake is there. If we cannot give orally, then parenteral should be considered. In most cases, standard nutrition regimen are recommended. While data on branch chain amino acid is not conclusive, they can be used in case of protein intolerance to achieve the desired intake target of protein intake. Thank you.
Thank you very much, Dr. Pankaj Puri. Can I just kickstart with the question, and then we'll take a question from the chat also. I mean, we all agree that enteral is the best route, but very often we have sick patients, like you mentioned in the ICU, where enteral feeding would be interrupted a lot of times for either investigations, or they go on higher inotropes or bleed. So what would your threshold be to combine, let's say, partial parenteral and enteral, keeping the target nutrition as the main number to achieve?
Only if the patient is not tolerating a tube feed. Most of the time, if the patient is not able to take orally, we need to supplement with tube feedings. And that usually achieves our protein and nutritional requirements. If there is significant ILS, if the patient is not tolerating tube feeds, then we would look at supplemental nutrition needs. As I said, it's only a very severely malnourished patient who we will consider, and that's not so common. Most of them would be a tube feeding.
Okay, now I'm going to read out this question from Dr. Kalyan from Ahmedabad. What's your IV fluid of choice in immediate post-transplant period prior to extubation and enteral feeding?
Yeah, the standard plasma light, or it will also depend on what are the sodium, what are the potassium. So you can't give one blanket level for everybody. And I don't think the IV fluid is so important, because we would soon after extubation, they would go on to enteral feeding. And the amount of fluid duration for 6, 8 hours, 10 hours is not going to make a major difference. And this has to be balanced by the electrolytes.
And from Himanshu Sharma, yes, Dr. Asianand.
Pankaj, would it be a good idea that whenever we ask the patient to fast for an investigation, we should give IV, say, branch chain amino acids?
No, sir, no data. Very difficult to justify giving it this recommendation. And how often are we fasting for an investigation? We just need to make sure that if the endoscopy has to be done, we don't do the endoscopy at 4 in the evening. We do it at 9 in the morning.
Usually it happens with the radiological investigations, because there the timing is not in our hand, and the radiology department may want a patient to fast right since the morning till the time the slot is available.
So for most of our radiological investigations, our need for fasting is about 4 hours or so. And we have a rough idea in the morning what time we are feeding. Yes, if the appointment in the morning is deferred, so I know those are the reasons that I mentioned. Those are issues why they get nutritionally depleted. That is partly iatrogenic malnutrition.
So why not give them IV nutrition at that time?
Sir, IV nutrition is going to have its own side effects. Why do you want to add to the side effects of IV nutrition? And how much benefit is going to give by giving one little whack of branch chain amino acids? Either you're giving it on a long-term basis. For 6 hours of branch chain amino acids, not I think we need to look at the overall frame.
You can give a unit for each 2 hours of fasting.
Yeah.
Or 3 hours of fasting.
I think we have to sit down and calculate what are the protein and nutritional contents which go in this short, 2-hourly iconic. I don't think we can justify it as of now.
Okay.
I think we probably will end this session. I know there are a couple of more questions. Maybe Dr. Puri can answer them separately. We're already running a little behind time. My apologies for not introducing my co-hosts earlier. And Dr. Shweta, who's head and director of anesthesiology and critical care at M.I.C.E, and Dr. Charles Panikkal, who's senior hepatologist at Astra Medicity, Kochi. They will be co-hosting with me. And the next session is on intraoperative challenges. And I thank all the chairpersons for this session and all the speakers. And I hand over to Shweta to carry on the next session on intraoperative challenges. Shweta, are you there?
Yeah, sorry, I was muted and speaking. Okay, thanks, Neeraj. That was a wonderful session. And now we'll move on to the second session, which is on intraoperative challenges. And as I can see, all our chairpersons are already there. So we'll start. I would like to first of all invite Dr. Vijay Vora, who needs no introduction. He is the chairman and teacher of us all, and he's heading the anesthesia and critical care of Medanta Hospital, Gurgaon. Sir, Dr. Vijay Vora.
Shweta, thank you. Thank you very much.
Yes, sir. Good to see you, sir.
Yep, good to see you.
And we have Sameer.
Do we get started now?
Yes,
No.
sir. I'll
Okay.
just introduce all the chairpersons. We have Sam, Dr. Sameer Patel from King's College. He's a consultant in intensive care at King's College Hospital, London. Sam, hello.
Hi, Shweta. Thank you for the kind invitation. It's been a great program so far, and I'm very much looking forward to this session on intraoperative challenges and the various topics that are about to be presented. So thank you for the invitation to join.
Thanks for joining, Sam. Dr. Piyush Srivastav, Senior Consultant, Department of Anesthesiology, Fortis Hospital, Liver Transplant. Piyush, are you with us?
Hi, ma'am. Hello. Thank you. Thank you very much, ma'am, for inviting me.
Good to see you. Anandita, we have Anandita, Senior Consultant, HPB. Again, Anesthesiology, Apollo Hospitals, Bangalore.
Hi, Shweta.
Can we open the session, please?
So I would like to invite Dr. Shweta Singh for the first talk. She's the Director and Head of Anesthesia and Critical Care, CLBS. She is attached to M.I.C.E Super Specialty Hospital, Saket. So she is going to throw light about the perioperative management of hyponatremia. So this is a very important talk. Please go ahead, Shweta.
Thank you, Anandita. Can you see my screen?
Yes, we can.
Okay. All right. So I'm talking on the challenges in the perioperative management of hyponatremia. So first I will talk about how big a problem it is. Is it a problem, a magnitude of the problem in patients with cirrhosis, how we define it, what is the incidence and prevalence, how it impacts patients with chronic liver disease, and how we have these patients coming for liver transplant, and what is the impact of postoperative outcomes. And then the management, taking it through the pathophysiology, and then how we perioperatively manage these patients. So first of all, the magnitude of the problem. So hyponatremia is said to be present when you have sodium levels of less than 135 and classified as mild, moderate, severe in the general population. And if we look at it that way, in this prospective data collection, which was done by Paolo and published 2 decades ago, 50% of the patients with cirrhosis had sodium values of less than 135. So in patients with cirrhosis, we actually classify hyponatremia to be present when sodium concentrations are less than 130. And we further classify it as profound when concentrations are less than 125 and extreme when they are less than 120. And so looking at this data collected by Paolo from 28 centers, about 1,000 odd patients, where 1/5 of the patients did have values less than 130, and quite a few, about 5 to 6% of them had sodium values of less than 125. So the prevalence is quite a bit. And the severity has been classified into moderately severe depending upon the grade of symptoms. But if the onset is chronic, you do not very often see the symptoms like in the general population. Hyponatremia has been classified into hypotonic, isotonic, and hypertonic. And as per the volume status, most patients with CLD will have hypervolemic hypotonic, unless and until they have overdosed on lactulose and they're having a lot of diarrhea, or they have taken too much of diuretics. Then you may have hypovolemic hyponatremia. But otherwise, more commonly, you see hypervolemic hypotonic hyponatremia in patients with liver disease, and that is what we are here to discuss. So the impact, when we see it, in the same paper by Anjali et al., he said that not only are these patients having increased mortality, but also they are associated with more complications. So they have a lot more ascites, which is present. Along with that, the odds of having hepatic encephalopathy, hepatorenal syndrome, and spontaneous bacterial peritonitis are very much higher when the sodiums are less than 130. So the liver transplant mortality rates are much higher in patients having sodiums less than 130. And so serum sodium concentrations, which were incorporated by the UK Foundation as early as 2008, were incorporated into the MELD score in 2016. So there was addition of up to 11 points depending if the sodium levels were less than 130. Because the risk of death is substantially higher in patients having hyponatremia, and also the risk of having complications is very high in patients who are having hyponatremia, in patients with chronic liver disease. Now, coming to patients, in spite of all of this and all of this understanding, all of us are seeing patients with hyponatremia who come for liver transplant. And there is a lot of realization of the fact that the 90-day, 1 year, and 3 year mortality is much higher in patients who have sodiums less than 130. Also, the rate of complications, neurological complications are much higher. Infectious complications, as well as renal failure, is more commonly seen in patients who have hyponatremia at the time of transplant. Also, there is a fear of post-transplant osmotic demyelination in patients who undergo liver transplant and they have hyponatremia. But when we see this meta-analysis in which they have analyzed data of all patients and all series which were reporting osmotic demyelination between 1960 and 2013, they did find that the most common predisposing factor was hyponatremia in patients who develop osmotic demyelination syndrome. And the commonest presentation was encephalopathy. However, favorable recovery did occur in 50%, and death was seen in about 1/4. But on further deeper study of this same paper, you see that about only 4% of the patients who developed osmotic demyelination had serum sodiums of less than 120. And most of them had serum sodium between 120 and 135. In fact, some of them did have sodiums above 135 when they were undergoing a transplant. So this paper tells us that yes, sodiums are important, and sodiums are associated, especially low sodiums are associated with the development of osmotic demyelination, and maybe liver transplant patients are at higher risk of developing osmotic demyelination. However, there are certain traits which this paper also pointed out, like that patients with liver transplant recipients usually had male gender, and the demyelination was restricted to the area of pons. That's why we use the terminology of this CP, we call it cerebral pontine myelinosis. But in order to incorporate the other areas, we tend to call it ODS now. Presentation in patients who had liver transplant was more with encephalopathy and seizures. The onset was within 2 to 7 days after rapid sodium correction. But in this cohort of patients, as compared to the other cohort, which were non-transplant patients, hyponatremia alcohol abuse was less frequent in patients who were predisposed to develop ODS. So ODS does occur, and serum baseline sodiums do matter in patients who have liver disease. But this paper highlighted the fact that overcorrection of sodium within a short period of time, causing rapid flux, 10 to 12 milliequivalents over 24-hour period, was a more significant factor. And yes, all the patients who had liver transplant, the outcomes were a little poorer than those who did not have liver disease, who did not undergo liver transplant. They were different to the extent of 77 versus 44%, which was pretty significant. But yes, the outcomes have been improving, and it was found to have good recovery in more than 50% cases. Mortality has decreased with each passing decade, and more patients were recovering. There was less death as compared to the previous years. In the 1960s, there was 50% death, and now it was about 25%, and recovery was much more. So favorable prognosis is possible in patients with osmotic demyelination, even with severe neurological presentation. So in the post-MELD era, as more and more work was done in this and more observation was made, it was seen that there were many papers which showed that the mortality was not so different in patients who had hyponatremia at the time of transplant and those who did not have. Although morbidity in translating into longer hospital stays, longer ICU stays, and sometimes increased neurological impairments were available, but the picture is not so grim. In this paper, they found, in fact, that all this talk was being done about hyponatremia affecting outcomes in patients who have undergone liver transplant, but really there is a cap on the level of sodium at which centers are taking up sodium. So in parts of the countries where maybe they have a deceased donor program, in this survey of 20 moderate liver transplant programs in the United States, they found that 49 out of the 20 centers surveyed had a no transplant threshold. That less than 125, less than 120, they were not proceeding and they were not taking those patients for transplant. In fact, the percentage of patients undergoing liver transplant with sodium of less than 120 were very, very, very less, 0.5%. And this is from UNOS data, which said that over 99% of patients who underwent transplant between 2005 and 2014 had a serum sodium of more than 120. So there is a lot of hype, but actually we're really not, maybe we're managing them better. But then there was this paper which really made the difference, which said that there are patients who have hyponatremia at the time of transplant, and there are those who have resolved hyponatremia at the time of transplant. And you see that the outcomes of all morbidities and all complications were similar in those who had hyponatremia at some point in time, whether it was corrected or resolved or it wasn't. So patients who had hyponatremia at transplant and those who had a resolved hyponatremia at transplant had similar rates of delirium, renal failure, rejection, pneumonia, sepsis, as well as other complications. And even if you look at the number of patients who needed post-operative ventilation and prolonged ICU stay, those who had resolved hyponatremia and those who had hyponatremia at transplant. So if the patients had hyponatremia, does correction at the time of transplant help? That's another thought I leave you with. Now coming to management. And why do we need to manage? We've already talked about how it impacts the survival, how it can impact other things. So before we go into the perioperative management, I would like to talk a little bit about the physiology of hyponatremia in patients with liver disease. So we know that there is shrinkage and of the circulation. And because of this, there is activation of the renin-angiotensin system. There is activation of ADH, release of ADH, and all of those factors cause activation of receptors, which cause increased reabsorption of water and sodium, leading to hypervolemic hypotonic hyponatremia in these patients. And so we usually have hypervolemic hypotonic hyponatremia. But before we start to manage them, we need to know whether this onset of hyponatremia is chronic. That is, it has been there for a long time, especially exceeding more than 2 days, 48 hours, or is it acute? Because if the patient is having acute hyponatremia, he's likely to be more symptomatic. And there is really no problem in going all out. And in fact, one needs to correct it. But in chronic hyponatremia, the management is different and the patients are usually not so symptomatic. So initially we stop diuretics and restrict fluids. And the cap is at 1 liter or 1.5 liters per day, which is a little difficult for the patient to comply with, but we need to do that. And at the same time, it's good to correct the potassium levels and keep a tab on the sugar levels. At the same time, it needs to be seen whether the patient is taking a lot of lactulose or lactulose diuretics we have already stopped. And if this just persists despite about 48 hours of fluid restriction and diuretic withdrawal, then there is a potential of giving albumin for correction. There is a role of Vaptans, and some centers and patients, some might respond to hypertonic saline, which is something which we don't use very often. So coming to, so we need to stop the diuretics, we talked about that, and fluid restriction of 1 to 1.5 liters per day. And after that, we usually start giving albumin. But there is a role of correcting hypokalemia, and I'd like to dwell a bit on that. Because if you correct the potassium, then there is movement of potassium intracellular, which leads to movement of sodium outside the cell. And along with the movement of potassium inward, there is movement of chloride also within, and that improves the osmotic balance, and it encourages from the extracellular compartment to move intracellularly. And the hydrogen ion moves out to maintain the electrical neutrality and gets buffered by bicarbonate. And again, you have more water here, which can move back into the circulation, which can move back into the cell. So correction of potassium hypokalemia helps in correction of hyponatremia. So you need to see whether the two are coexisting. And then the role of albumin. So it was seen as early as 2007. Rajiv Jalan came up with this paper where in the small group of 24 patients, he advocated that when these patients were divided into two groups and they were given albumin after the patients did not respond to diuretic withdrawal and fluid restriction for 48 hours. And in those group of patients, it was seen that the incidence of complications was much lower in those who received albumin, and the 30-day mortality was very much reduced when albumin was supplemented to improve the hyponatremia. And this was a recent retrospective analysis by Bajaj from the North American Consortium of End-Stage Liver Disease, and he showed that hospitalized patients with cirrhosis and hyponatremia who received IV albumin had a higher rate of hyponatremia resolution. So concentrated albumin solutions do have a role as recommended by the current EASL clinical practice guidelines as well. The other drug which is used is Vaptans, out of which have a black box warning because it was seen that it led to increase in liver enzymes. But when further studies were done and further analysis, specifically in patients with liver disease in the form of SALT-1 and SALT-2 trials, tolvaptan was found to be not associated with rise in liver enzymes. But yes, it has been associated with rapid jumps. And so there is a lot of resistance and cautious resistance to the use of tolvaptan, which is available in the oral form. It acts specifically on the V2 receptor and helps increase the urine volume and free water excretion. So, so we start with low doses, but it has been seen that it is beneficial if it is given for a short duration of time, because within a week of withdrawal of Vaptans, it leads to rebound hyponatremia. So that is the other thing. So the patients do complain of increased thirst, increased urination, but all said and done, the patient's sodiums do improve, but sometimes there is a jump in the level of sodium, so there's a rapid rise. And so that is something we're all afraid of, even in patients who are sitting in the ward or maybe at home, because we would not want rapid fluxes of sodium in any of them. And once the drug is withdrawn, it leads to rebound hyponatremia. So that's a limitation. If your patient is planned for a transplant within 7 days or so, you could consider Vaptans with careful monitoring. Now, hypertonic saline is something which people use, but again, the rises can be very rapid and unpredictable. So we do not want an increase in sodium of more than 10 millimoles in about 24 hours. So carefully, especially maybe in symptomatic hyponatremia, it can be given. Although, again, as I said, I'm not a very big fan of that. Now, the intraoperative period, if we've corrected the sodium and if we're taking up the patient with hyponatremia, so there are certain things that we can do differently. Maybe we can select fluids which have low sodiums. But in addition to that, when we're managing the blood loss, we have to use viscoelastic monitoring to guide transfusion, because the blood products, whether it is FFPs or packed cells or cryoprecipitates, they all contain a very high quantity of sodium per bag. And when you give them, if you're not using factor concentrates, because factor concentrates have the advantage that you do not have very high levels of sodium in them, and when you're reconstituting, you do not need saline, you can use sterile water. So use of viscoelastic monitoring, use of clotting factor concentrates, and we have our own paper from Piyush here, who has shown that factor concentrates can be used, and there is no increased risk of thrombotic complications when they are used. So that can be a strategy to prevent rapid rise in sodium as bleeding and other things are managed during liver transplant. Then there is a role of administering some amount of dextrose solutions when you're giving FFP, because that in turn will cause reduction in whatever sodium increases have occurred. Then there is, I do not know, maybe Sam is having access to THAM, but whenever you have acidosis, you cannot pump the patient with sodium bicarbonate, because sodium bicarbonate will also cause very rapid fluxes in sodium, and at the end of the surgery, you will manage to raise the sodium to very high levels. So where they have access to THAM, THAM is the agent of choice in patients who are non-oliguric to correct acidosis instead of sodium bicarbonate. And CVVH has also been advocated, but it would require a special reconstituted low sodium dilysate, which needs to be used because standard dilysate solutions have high concentrations of sodium. In the post-operative management, we need to monitor the sodium levels, and we also need to keep an eye on the potassium and glucose levels. There is a role of desmopressin, which has been described. American and European guidelines are now endorsing therapeutic relowering of sodium. So if you happen to manage to increase the sodiums a lot during the intraoperative period, then there is a role of trying to reduce it by starting 5% dextrose-free water and maybe even desmopressin to help lower it, because it's not just the 24 hours, it's the 48-hour sodium correction should not be more than 12 milliequivalents per liter. So coming to our policy, at our center, I would say that we do not, like if we have a patient of sodiums between 120 and 125, actually we just stop the diuretics and restrict fluids and just about that, unless if the patient is, very like in the ICU and we get the opportunity to start IV albumin, but we're basically okay with taking up patients of sodium about 120. But if the sodium is less than 120, we do discuss giving IV albumin and Vaptans. We always kind of try to start at 6.5 milligram BD doses of Vaptans. But unless if the transplant is like really urgent, then IV albumin and 3% saline would only be reserved for those patients who are symptomatic. And this is our data, where this is our data of about 900 patients in which we encountered sodiums of less than 120 in about 19 patients, and our outcomes were we lost 2 of them. So with that, I would like to conclude and summarize by saying that about 1 in 5 patients with cirrhosis will have hyponatremia, which is a sodium of less than 130. This is associated with increased complications and mortality, especially patients who are waiting for transplant. And when such patients are undergoing transplant, also they are likely to have more complications and perhaps longer hospital stay. But it has been shown that those who have resolved hyponatremia may have a similar incidence of postoperative complications. As a result, do we really need to correct this? So the crux is not to allow sodium fluxes of more than 8 to 10 milliequivalents per liter in about 24 hours in patients who are suffering with chronic hyponatremia. And if there is a rapid flux, there is a role of relowering as well. So I'd like to conclude by saying that. Thank you very much.
Thank you, Shweta. That was wonderful. You covered probably all the spots which we thought we could ask you questions on. But tell me, in a living donor setup, cadaver is a totally different scene altogether. In a living donor setup where you do have time, what would be the sodium level which you would accept? Because you have time to prepare these patients. So is there a place for taking up any patient with gross hyponatremia?
So actually, if the patient has been on follow-up, and as like if we have time, then definitely they should work on increasing. But we very often have patients who are walking, talking, eating on OPD follow-up, and their sodiums are around 120, 100 or 25. So in those patients, really there doesn't seem to be any point asking them to start anything, because they're anyways walking, talking, eating, what we call.
So you will take any sodium the patient comes with. Is that what you're trying to say?
No, what I'm trying to say is, if there is a patient on OPD follow-up and we've seen reports that this patient is having a sodium of 120, 25 all the time, then I don't think there is any point trying to give him anything more to build him up, like giving albumin or giving hypertonic saline is out completely. Vaptans, we would not want them to do anything. So if you might, it's okay to say we want a better sodium, but if the patient is coming from his home and we know that he has been having low sodiums all along, we don't ask them to start correcting it, because I realize that I'm not going to admit this patient and give him albumin just because he's wanting to, we are planning to operate him. Because Vaptans is out of question. I would never ask them to give Vaptans and send him home and, okay, when he comes back after 7 days, we can operate him. So, and if a patient is admitted with us, that is the time when we can think of giving him, then we have to see whether he's volume overloaded, whether we can stop the fluids. Is there any potential of restricting fluids or giving IV albumin? So it depends on whether the patient is coming from home or is he an inpatient.
Thank you. We as a protocol don't do any patient with sodium elective patient, sodium less than 125. Let's say 122 will probably not do him. Really, I don't know what does everybody else. Sam, Piyush, Anandita, what protocols do you follow? I know Sam would be forced to take that patient in because they do mainly DDLT. But Piyush and Anandita, what do you feel?
About 125, sir, is our cutoff, sir.
Yeah.
It's
Piyush?
actually it's a timing of the transplant. If it's definitely elective case where we can definitely wait, definitely we'll not take any patient less than 125. But if there is an urgent, like Dr. Shweta already said, because timing of transplant is very important. So patients who are immediately going to OR, there is a very little time to correct. So probably you will take some urgent measures to correct the sodium, and we have taken the patients of sodium of 122 and 123, but definitely not the sodium of less than 120, irrespective whether it's emergency transplant, urgent transplant, or acute transplant.
Sam, sodium bothers you or it doesn't?
Hi, thank you. Yes, sodium is I think Shweta has nicely demonstrated the frequent, that this is a common occurrence in patients presenting for transplantation. And we are often vigilant for low sodium in our patients who present. I think the challenges in the United Kingdom are perhaps slightly different to those perhaps for the majority of programs in India. Obviously, we are predominantly or almost exclusively doing a deceased donor program. And obviously patients may present with an unexpectedly low sodium at time of presentation. And the way we have to manage those things will very much differ to some of the strategies that Shweta has highlighted. I think one of the questions I was going to ask Shweta was, what challenges or differences in management do you foresee in patients who are coming through as part of a deceased donor program? Because obviously you've nicely demonstrated that for living related programs, it's slightly easier. You have time to perhaps optimize them if you felt that was necessary. However, for disease programs, there are a very different set of challenges relating to the fact that the liver, when it comes up, you have a very short period of time to either accept or very quickly optimize your patient, but with the caveats as you've described of overcorrecting your sodium very quickly. So what challenges and differences do you see, Shweta, for those programs doing deceased donor programs in the other parts of India?
I would say that the difference is very apparent because no matter how, we would definitely have a couple of days, if not more. You in a deceased donor program would have less. So if the patient is in the ICU and on ventilator or something, maybe you have at least 2 or 3 days. You would still have maybe to optimize things. So that's the period of time where you can think of trying to increase. But then if your patient's sodium is about 110, you would want to increase it a little bit to maybe 120. So we would, at that point in time, we would start IV albumin, and that's about it if the patient is on ventilator. And if the patient is not on ventilator, so we would see whether the patient is on IV fluids. If the patient is not on IV fluids or anything, if the patient's transplant can be deferred, and if he is coming from home, I would definitely not ask them why they did not start baptism, because I realize that, and Neeraj, you correct me if I'm wrong, that there can be rapid fluxes in sodium. So you can't advise baptism and send the patient home and then tell him, okay, we've given you a date for next month and you can come that time. Would you be happy doing that?
No, I agree with you. I think, we cannot, I think the last thing you want is a rapid increase in sodium. It's better to go in with a slightly lower sodium as compared to having problems with a sudden increase.
But then
with your permission, can I make a quick comment?
Yes, sir. I don't know whose permission, but sir, you don't need any permission.
All right. So I think the question that all of us need to answer is, how confident are we that we'll be able to correct the sodium level in a cirrhotic? Whether it is in the UK or in the US or in India, the answer to that is a sad no, because we still do not clearly understand why people are so profoundly hyponatremic and still functional, as Shweta put it. So to say that you are very confident that somebody who comes with a sodium of 115 will be able to get him up to a sodium of 120, 125. Even this jargon about fluid restriction, it's more that is taught to the MBBS students than what we would practice in our day-to-day this thing. How do you give your food and nutrition to a given patient if you are going to restrict their calories? So where does that osmotic load get excreted? So I think this is something that one would be very, very difficult, find it extremely difficult to contend with. And the only strategy that probably works is to see that there is no infection, because this is something that we don't talk about. There is always an added ADH secretion when you have got an ongoing sepsis that pushes the sodium down. That apart, even the albumin story that is based on the Gibbs-Donnan effect, that is not a very profound effect. You will have only a very marginal increase in sodium if you give albumin to people, and then you run the risk of volume overloading them. And then apart from this, there is nothing that works except for the protocol of giving them free water if you have loaded them with salt containing solutions. So I think that would probably be what we would do in our practice. So we have transplanted someone with a sodium of less than 100. Probably that was the time when Professor Rela threw of it. This was a guy with 93 millimoles, and one was shocked that when the abdomen was opened, there were tubercles inside. So we really do not know what goes on to account for a very, very low sodium in a given patient. But I think none of us can say confidently that we can bring it up to a reasonable level. Thank you.
Shweta.
Thank you, Dharmesh. That was very enlightening. But I think we've got to move on now. Let's move on to the next case-based discussion. And for that, we invite Akila to moderate the case discussion. Akila, please.
Yeah. Hello, good evening. Can you hear me?
Yes, Akila.
Yeah.
So Akila is leading the program at Dr. Rela's Institute, and she has an eminent panel with her today. So Akila, are you ready with your case-based discussion?
Yeah, I have my slides. So you want to introduce the panel, Shweta?
Yes, absolutely. So I would like to invite Dr. Prem. Dr. Prem, are you there?
Yes,
I can see Dr. Okay, so Dr. Prem is heading the program at AIG Hospitals, Hyderabad. I would like to invite Dr. Lakshmi. Dr. Lakshmi?
Yeah, I'm on. I think you should see me. Yeah, nice to see you all, Shweta. Yeah, thank you for inviting me.
Ma'am, Dr. Lakshmi is professor and head at Amrita Institute of Medical Sciences, Kochi. I would like to invite Dr. Vivek Vij.
Thanks, Shweta, for invitation.
Yeah. So Dr. Vij is the chief transplant surgeon chairman at Fortis Group of Hospitals. And we have with us Selva. Selva, are you there? I can't see you. Selva is leading the program at Den Eagles, Chennai. I think Selva is not here. And Vandana, Dr. Vandana Saluja. Is it?
Yes, ma'am. Thank you, ma'am.
Hello, Vandana.
Hello,
She is managing liver transplant anesthesia and intensive care greatly at ILBS New Delhi. So over to you, Akila.
Good evening, Shweta. Thanks for having me here. Thanks to the organizers as well. I also take this opportunity to thank the panel to join me today for the discussion. This is a case which we did years ago, actually. I thought of bringing this case so that there will be interesting points to discuss on this. So this is, we had a 64-year-old gentleman with NASH-related end-stage liver disease since 2013. His MELD at that time was 15. He was kept on regular follow-up. He developed an episode of SBP in 2015. He was evaluated and then listed for DDLT end of 2015. His MELD at that time was 18. His comorbidities included well-controlled hypertension. He was also a diabetic on insulin. On evaluation, there was nothing remarkable actually. He had normal coronaries, his pulmonary reserve was normal. Fortunately or unfortunately, he got an offer within 3 months of listing. In March 2016, there was a DDLT offer. So I'll give you a bit of the donor details. Donor was a 69-year-old gentleman, again a male, who was in a hospital nearby within the city, which was an hour drive from our hospital. The cause of death was intracranial bleed. He was in the ICU for 8 days. He also underwent a craniotomy on day 2. After that, he didn't wake up. At the time the offer was made, his noradrenaline was at the range of 0.3 mics per kilogram per minute and vasopressin 2 units per hour. There was no episodes of cardiac arrest or inter-hospital transfer from the history that we got. But his liver and kidney function tests were essentially normal. Dr. Vich, do you want to comment on this donor? Is this a right match for our recipient in question?
Yeah, Akila, I don't see any problem upfront with this donor.
Yep.
69-year-old, but good liver function test, good kidney function test, very low inotropes, ICH. I think upfront looking at it, there should not be any problem. But definitely, as we go ahead and see the liver while retrieving the liver, then we might have some issues with the rejection of the donor.
Now, we are aware of a lot of scoring systems that the Western world use. To pick up this. Do you use anything in your practice? And what your favorite one?
So as far as DDLT goes, there's a very famous scoring system, DRI, that is Donor Risk Index, which has around 8 parameters in it. I think some of these parameters are missing here, which is cold ischemia time and certain other parameters. So I think DRI gives us a prognostication of PNF or how the graft will behave in the patient as far as donor is concerned. But as far as recipient goes, the outcomes of recipient, there are many scores. We personally don't use any score, but there is a latest P-soft score which calculates a lot of parameters of recipient as well as donor. And when we combine them together, it's a good predictive value for recipient outcomes also. Although personally, I don't use that.
Okay. Dr. Prem, any comments on this so far? Are you happy with
First of all, thanks to the organizers and thanks, Akila, including in this case discussion. Right. First of all, I want to say that it's a prerogative in India of surgeon to choose the donor and the recipient. Okay. So if the surgeon says we are going ahead, so we go ahead. Secondly, as he told regarding the donor risk index, in that the main factor which is there is the age of the donor. Right. So it has been said that if the donor age is less than 40 years, definitely the outcomes are much better. And as the donor grows older, and as we can see, it's almost 69 years. So in one of the studies, it was written that if the donor age is more than 70 years, there is a 65% higher risk of graft failure because of either fatty infiltration or fibrosis in the donor liver. And plus the vessels are also more atherosclerotic. So there might be problems in the hepatic artery, anastomosis and all. Secondly, the problem with this is that this donor has been in the ICU for last 8 days. Okay, so obviously he's on ventilator. So chances of infection are also there. Because I can't see any parameters regarding that. Definitely he's on double inotropes. But one good thing is that his liver and kidney function tests are normal. And generally, it is ideal to have a good donor and recipient match so that we have good outcomes post-transplant and we don't lose the organs for retransplant.
So, yes, we didn't
there are other scores also like the D-belt where the donor age is multiplied by the recipient preoperative MELD score, thereby predicting that if the score is more than 1600, it is futile for doing the transplant, thereby implicating that if the donor age is high, it is better to give to a lower MELD recipient. So as we can see here, the recipient is good enough with a MELD of 18. So I think we can go ahead with this.
Yeah. So, I mean, there were no signs of sepsis in this donor. As Dr. Vivek said, going by the PSOF score and the bar scores, probability of 1 year survival worked up to 88.6%. I mean, with whatever data we have so far, the ones they have provided. So we went ahead with the transplant. At retrieval, the liver was found to be good. Even a biopsy was performed, was less than 10% fat. So we went ahead with the retrieval and proceeded with a transplant. At induction, it was a standard induction. We placed a radial arterial line. CVP line was in the right IJB. We also put an 11 French sheath for volume. Stroke volume variation and pulse pressure variation were available on the monitor. Dr. Lakshmi, do you want to make a comment? Are you happy with the hemodynamic monitors that we have set up for this patient?
Right. So perhaps hemodynamic monitors would be dictated by the center's practice. Like I think in my center, almost certainly there would be a femoral arterial line. I don't know at this whether you normally do it or whether that practice came in later. And it's far more comforting to look at the femoral line than the radial when you're reperfusing, even though the mean pressures may match. The second one is, am I just happy with the stroke volume and pulse pressure variation? I know after so many years, I would probably be able to manage just as well in this patient whom you have categorically said has normal coronaries despite having a NASH. But for comfort's sake, I would use something that may give me the cardiac output and the SVR as well. Although optimally, if I had the comfort and the expertise, I would like a TE placed in the in maybe selected patients, not this patient. So I'll stay off this. I would probably like to have a monitor that would give me a cardiac output and an SVR and a femoral arterial line. The rest of it, I think, is acceptable for me.
Okay. I mean, if you had all the resources, you said you would place a TE. What do you think are the problems with it? We all know that it is getting to be the gold standard monitor.
Right. So I would believe the use of the TEE should be in select patients where you really think it may be indicated, like somebody who's had a documented coronary or somebody who may have high pressures or any evidence of any cardiac problem like LVOT obstruction or something like that. I think these patients' CTs should be looked very carefully for the presence of esophageal varices, and any one with evidence of more than grade 3 varices, I would be cautious, perhaps not use a TEE in that patient. And if the protocol would allow, I think practice of probably repeating the endoscope 3 weeks, 4 weeks before and allowing banding, I don't know if that can be established as a practice, which will give you the option of using a TE should the need arise.
I'm not sure if they would do that for this purpose.
Right.
Anybody from the panel would like to talk on this?
So I think the availability of the TEE and expertise in interpretation are the technical challenges right now. Having said that, I have had the privilege of using it in non-transplant and found it to be a very comforting situation that you can actually look at the heart without wondering if the thermodilution is working or the calibration is all right. So this is just a thought. I wish and hope in the next 5 years or so, we would move more towards it with safety.
Regarding TE, can I add a point here?
Yeah, Selva, go on.
Yeah. So basically, as Dr. Lakshmi said, it is quite useful, but my view is that I think the more we use TE, the more we will be comfortable. And if we selectively use only for high-risk patients, then the learning curve would be a bit delayed, and we may not actually pick up things. And second thing is, as long as we stick to mediasophageal, we use at 30-35 centimeters or less than that, we could probably avoid the injury to the varices if possible.
That was a good point. In the US, I mean, there are fellowships for TE, and you'll have to have completed your TE fellowship before you start transplant anesthesia fellowship in most of the centers. If you have the resources, would you do it routinely? I mean, anybody else from the panel would like to comment on that?
I think that if we have the resources, we should definitely utilize it, because it's definitely a very important tool. We have seen, as Selva had told, that if we do in select cases, we have found problems using it. Right, there were a few patients where the SVV and the PP were perfectly normal. The CVP was also normal, but the patient was on triple inotrodes. And once we called the cardiologist and just put the TE, and he said, just give 2 liters of fluid and everything will come back to normal. The heart was totally empty. Okay, so definitely it's a big help, but it's very dangerous also when we see the reperfusion. It appears as if there is a lot of air going into the heart and everywhere. So there's a big learning curve for this. And definitely, as you said, there should be fellowship courses in this, and everybody should get trained in this. And this is the future monitoring for all the liver transplant recipients.
Now, there was a review which came up in 2016. I don't remember the author's name, about TE use, and they've said the incidence of variceal bleeding with the use of TE in liver patients is very, very less. It was about less than 1%. But we have to take it with caution. Negative outcomes are not published all the time. So it has to be with the expertise that we have to do them, not in all patients though. And again, if you'll have to do it in at least a big number to pick up problems. Otherwise, I mean, I've lost my skills. I can only pick up clots in the heart if at all they happen. Looking into the chamber sizes might be difficult, but at least I think it is mandatory to have the resource available within your environment. Somebody else should be able to do it when a catastrophe strikes, is my view on this. PA catheter, Dr. Lakshmi, what do you think about its use? Most of us have moved.
I think, right, we've also moved away from PA catheters. We may use it for an occasional patient when, a TEE is not available, or he has evidence of PAH, or a poor LV, and again, a TEE is not available or otherwise contraindicated. So those are probably the very few indications when we use a PA catheter today for transplant.
Anybody else from the panel on use of PA catheters?
We have totally done away with the use of PA catheters except for cases of portopulmonary hypertension. Because in CAD cases, we have seen that arrhythmias occur and we are not able to judge that is because of ischemic changes or because of a pulmonary artery catheter.
Yeah. Okay, moving on. Intraoperative phase was fairly straightforward up till the first 3 hours. Dissection phase was uneventful. There was a very minimal blood loss, no pressure requirement at all, and no transfusion. The metabolic parameters were also within the acceptable range. Implantation phase was uneventful. It worked up to a cold ischemia time of 540 minutes. All good so far. At the release of clamps, there was significant PRS was noted, required adrenaline, calcium boluses, and then he started on infusion. Now the surgeon doesn't look happy. He says the liver is stiff and didn't appear uniformly perfused. And within the next few minutes, we see diffuse ooze everywhere, severe coagulopathy, and massive blood loss. The patient goes on to require triple vasopressors. Total transfusions in the next 1.5 hours worked up to 16 pack cells, 10 FFPs, 12 cryo, and 3 SDPs, which still didn't sort out the problem. So we had to administer prothrombin complex concentrate. He'd become anuric in the next few hours. Dr. Selva, what do you think is happening here? What is your differential diagnosis?
Yeah. So immediate post-reperfusion, significant hemodynamic instability. Most of the situations, it is the graft related. It's obviously a reperfusion injury due to poorly functioning graft, or maybe just a steatotic graft throwing away a lot of metabolites. The other rare DDs which would probably be considered is, sometimes the mobilization of thrombus, which comes in when the cramp is released, and then might be some missed bleed behind the cave or something like that. But the fact that the liver is stiff and didn't appear uniformly perfused basically solidifies the problem, or direction is towards the graft causing all this. So we should again probably focus on managing the reperfusion syndrome, and obviously still looking at the other DDs. The management, again, the primary issues we would be facing is mainly vasodilatation and the coagulopathy. Vasodilatation could be quite severe, could be having a severe vasoplegia, and obviously vasopressors and immediate volume replacements are the priorities. So maintaining hemodynamics would be the most acute challenge, and sometimes we have used, in addition to noradrenaline and vasopressin, there is a small amount of methylene group could be used to reverse the vasoplegia through the inducible nitric oxide synthase inhibition. Regarding the coagulopathy, many times it's empirical correction. Obviously, we can do rotam and teg side by side if it is available, but we couldn't actually wait for the results of either a conventional or a VM most of the times. So
I think this is the situation where we are not looking at rotam.
Yeah, rotam obviously will have a shorter time, maybe a minute or two. We can see the R time and the angle to some extent, A5 maybe. So the main pathophysiology, if you look at it, it's probably hyperfibrinolysis, which is probably leading to a DIC and the other synthetic dysfunctions. So obviously, if situation comes like this, first choice would be obviously giving a dose of tranexamic and then going with top-ups of fibrinogen and cryoprecipitate. So if it is very urgent, we have used the fibrinogen concentrates, because sometimes the cryo turnaround from the blood bank might take time. Obviously, informing the blood banks, if the PRC goes up, informing the blood bank and other logistic issues need to be considered. Yeah.
Dr. Prem, is there anything else which runs in your mind?
Actually, it is a graft-related issue, but the previous slide I saw that the cold ischemia time was quite long, almost 9 hours.
Yep.
Okay, you had said that the center is just 1 hour from your place and the city only. And what you call the dissection phase and the anapatic phase was totally uneventful. So what was the reason for such a long anapatic phase? And definitely that also goes in the donor risk index, as Dr. Vivek had told, that if the cold ischemia time is longer, definitely the graft-related issues are will be coming up. And which is what we are seeing is definitely there is coagulopathy, there is hemodynamic instability, there would be obviously metabolic acidosis, lactic acidosis also, and the patient has gone annual. So all whatever can occur has all happened in this case. So definitely it is related to the long ischemia time and ischemia reperfusion injury.
What is your experience with the use of coagulation concentrates?
Yeah.
I mean, we had to use it as a last resort when we were not able to control bleeding with all the products. Product availability was not a problem, but we were not able to control bleeding. That is when we started using it, because our we don't use him routinely as other centers. What is your experience and use of?
See, in these cases, if you do rotem or tag, it's going to be a straight line.
Flat line, yeah.
You will not find any angle or any K or any maximum amplitude also in these cases. So you are empirically trying to push in all the products as much as possible. And on the other hand, the patient is getting anuric, right? So you have pushing in everything, but nothing coming out except for the bleeding which is going on. So definitely there is a role for PCC. In one such patient, we had used it quite early on, rather than giving so many products and then going for this. Because one, it is easily available. Secondly, very low volume is required. Thirdly, and it doesn't turn over time, as you told, for cryoprecipitate and FFP is about 45 minutes to 50 minutes. The thawing has to occur and then only it comes. Whereas PCC can be readily prepared and it very fast corrects the iron. So definitely this PCC or fibrinogen concentrate have a role when there is bleeding going on. And I don't know whether after so much of bleeding, did you use factor 7A also? Because if it's not controlled at all, then the last thing we have in our armamentarium is factor 7A.
So I think this patient also received factor 7, yeah, at the end. So we didn't, I mean, this was 2015, I think, 2015 or 2016, like you said. We didn't have the fibrinogen concentrates. They've only come a couple of years ago. PCCs were just coming into Indian market at that time. So we took a time before we administered that. Fibrinogen concentrates, again, what is your experience? My experience hasn't been great with them. The dosage which is required to correct seems very high, and the cost seems to, out of reach compared to a unit of cryo. Elective use of fibrinogen concentrate. Selva, what is
no, we have not used.
Yeah, actually,
as you said, all the disadvantages you already mentioned.
So for efficacy wise, I don't think PCC or fibrinogen concentrate is in any way better than FFP or cryoprecipitate. It's only the volume and the immediate availability which is going to be an advantage. So if there is, as Dr. Prem was saying, there is a significant anuria which is happening and the turnaround time is a big issue, then it's probably useful. The rescue factor would be Novason, the activated factor 7, and not these two things. If we have cryo and FFP and if there is no oliguria, volume is slow, I would rather give the plasmas rather than cryos rather than fibrinogen concentrates.
Fibrinogen concentrates, I think to give 4 vials, it works to around 30K or something, which is far expensive compared to a cryo. So as you said, maybe in volume, if that is a problem, we could use. Lung injuries are not a concern anymore with the innovations which are happening in the blood bank, the way they're preparing. So moving on to our case, because of difficult hemostasis, bile duct anastomosis was deferred. He was quite acidotic. Peak and end of lactate was 14.1. Abdomen was packed and patient shifted to ICU on all the triple vasopressors. What next? I mean, this is something which it's a nightmare situation for the entire program. How do we handle this situation? What do you tell the family at this point? Dr. Vivek, would you like to comment on this?
Yeah, of course, Akila. I think somehow the cold ischemia time was very high. There are many factors, you try to achieve cold ischemia time less than 6 hours. But once you have this picture in operation theater with cold ischemia time of 9 hours, DRI of more than 2, then first thing which runs in your mind is PNF, of course, with the severe reperfusion syndrome. This can happen to anybody. So from then on, surgeon starts thinking how to convince, how to convey this to family, and then how to move forward. That's the key question. I think it's very important to be upfront with the patient and their families. They want truth. They don't want any, beating about the bush. So we have to tell them it's PNF. Don't waste time. Look for another donor. Yes. And this can happen. PNF is a real story. And of course, pre-operatively also, we do explain to the patient. And once we tell it in so many convincing words to the patient as early as possible, then the time lost will be much less. Yeah. So that's what we strategize at. We have to tell the family in so many words. We don't have to beat about the bush.
Yeah, agree. Dr. Vandana, what do you think would be our treatment goals next? Now, patients transferred to ICU. What are the targets and what is the plan for the patient for the next? few
Thank you,
hours.
Dr. Akila. So now since we made the diagnosis of PNF or poor graft function, so now we can consider that the patient is in a sort of a prolonged and hepatic phase with some amount of acute liver failure. So that would be the line of management, how we will go about for this patient. So challenges would be, one is, as we already challenge managing the coagulation. So again, coagulation and hemodynamics will be the first part, where we will try to correct the coagulation with factors and with blood products, of course, guided by our coagulation TEG or ROTEM, whichever is available at the institute. Then coming to the hemodynamics, it will be a combination of vasopressors and IV fluids. Targets would be, I think, modest targets of your hemoglobin of around 7 to 8, guided by the clinical coagulopathy, as well as the MAP targets will again be modest, around 60 to 65. We do not want to overperfuse or over-resuscitate the patient. The choice of the fluids will be, I would prefer crystalloids, again decided by the level of acidosis, the potassium levels, the risk of osmotic demyelination, the sodium levels. So all these will decide your choice of crystalloid or albumin with what you want to proceed. Then we come to management of the lactate levels, because the acidosis will again contribute to the hemodynamics or worsening of the hemodynamics. So management of the lactate, acidosis, hyperkalemia. So for that, patient might require some form of therapy, because correcting anuric patient, correcting acidosis and electrolyte abnormalities with soda bicarb, all these things will be dangerous for the patient. So we need some form of renal replacement therapy, and with triple vasopressors, then definitely patient goes on mainly CRRT. Then other goals would be management of hypoglycemia, avoiding, because patient is without a liver practically. Then temperature management and management of infections. So these parts we need to, these would be the goals while we are waiting for a new graft.
So basically we need to bridge the patient and see if he recovers or he needs a transplant, just keep him alive. So this is what we did. 12 hours later, patient was on ventilator, was still on ventilator. There was a drastic increase in liver enzymes and severe coagulopathy with renal shutdown. Continued to be on triple pressors. CRRT was initiated on arrival to ICU and it was continued. These were the labs. You can see that the AST was 8710, the INR of 2.25. After that, PCC that he received. Bilirubin doesn't carry much of a value on day 0. So after this, he was listed super urgently and after discussion with the family. Now, the role of CRRT here, we discussed about the role of TEA. What do you think is the role of CRRT? Do you think it's mandatory for all transplant centers to have CRRT facilities? Dr. Vandana, what do you think about this?
See, the metabolic abnormalities which we see in a liver during the surgery, during a liver transplant, the acidosis, the hyperkalemia, most of the time it is associated or with some kind of hemodynamic instability. So in such patients, apart from that, management of cerebral edema, particularly for our patients, there is a risk, though patient is a chronic liver disease, but because of, we can see the enzymes, I expect the ammonia levels will also shoot up. A very acutely high shooting up of ammonia levels can predispose the patient to cerebral edema. So this setting of so many metabolic derangements with anuria, with the risk of cerebral edema. So yes, I think CRRT is a good choice and should be there in patients who are in centers who are doing a liver, who have a liver transplant program, because you will also be having patients with acute liver failure. So for such patients, yes, I think it is a good modality and it is required.
TEE can be optional, but I think facilities for CRRT, either in-house or for procuring in an emergency like this, should be mandatory in most of the transplant centers. Dr. Prem, what do you think on this?
Yeah, definitely. CRRT is mandatory in any center doing liver transplants, because we have seen that renal dysfunction is a common complication even during the progression of liver disease, not in this patient I'm telling, but otherwise also. Okay, and having an incidence of about 15 to 30%, out of which about 10% will require dialysis or renal replacement therapy during, before or after the liver transplant. So one cannot imagine a liver transplant center without a CRRT facility.
Sure. Yes, we agreed on bridging this patient. How do we bridge the patient? Dr. Lakshmi, you want to comment on the role of TP in such patients?
I think there is an article in the year 2000 which says that therapeutic plasma exchange done in about 5 patients who had primary non-function. All of them completely recovered. Having said that, this article is nearly 20 years old, and I don't see more recent literature that supports a therapeutic plasma exchange in this situation. I would probably, I do not have too much experience, but I would think having a continuous renal replacement therapy and monitoring the patient till we get the final answer to a primary non-function, which is a retransplant, should be the way to go. I don't know if any of you have had more experience on a therapeutic plasma exchange in a primary non-function vis-a-vis an early allograft dysfunction. I think I would ask the other panelists for their opinion as well.
Anybody else would want to make a comment? Yeah.
Yeah, I agree with Dr. Lakshmi. Actually, in a PNF situation, I don't know how much TP might be helpful, but definitely EAD, there are studies, lots of studies which have shown that there's cholestasis and coagulopathy recovers, and with the milieu getting better. I think PNF is too acute for plasma exchange to be reversed, even though theoretically PNF should behave like ALF and there might be some role, but I don't think there are a lot of articles or studies in that.
I think it just decreases the numbers and makes you feel a bit comfortable if you do a plasma exchange, but the answer is retransplant only.
Having said that, we are talking about listing a patient for DDLT and how quickly do we get an organ. Do we not want to use all resources available? TP is the only thing which has shown some benefit in ALF. This is something like a fulminant liver failure, although not in a patient with a normal liver disease. Would you not want to try it out? I mean, we're not losing much. This patient is going to die if he doesn't get an organ on the wait list. Would anybody think in that direction, or you would
Akila, can I come in here?
Yes, Dr. Ora.
Yeah. You see, I mean, if you are really thinking of a retransplant here and you are genuinely think that the patient is suitable enough, not all primary non-function would be, they might have chest issues, multi-organ issues. Those guys are probably not great candidates for retransplant. So if yes, you think this guy is is suitable for retransplant, and you do have a donor which is coming up.
Yeah.
Probably a live donor, I would think. I think for DD, maybe if you are sitting in Kings, you might think of listing and then doing plasma exchange. Yes, but doing plasma exchange as it's not a therapeutic. It's probably a bridge. For a bridge, yes, one can think of. Not anymore.
Okay. Any other liver support systems would anybody want to use on this patient? We'd already listed this patient. Going by this patient scenario, we'd listed the patient. Would you want? We were speaking to the family about a live donation as well. In the meantime, is there any role for artificial liver support systems? Dr. Vandana, do you have any views on this?
Yes, I would just like to make a few comments. As Lakshmi ma'am has said that there are a few studies in therapeutic plasma exchange for PNF, as there are a few case reports on use of MARS as well. Yes. So, but again, it depends on the experience of the transplant center, and both the techniques are different. Both have their own pros and cons. So, MARS per se in this situation, we will not have much help with the coagulopathy correction part because the patient is bleeding. So in that case, as Dr. Vora suggested, maybe if we are thinking of a bridging therapy, then plasma exchange would be a better choice in this case. And with the hemodynamics,
because it's easily available and something which we are familiar with. But if you look at it, the FILMA study, they've included both fulminant liver failures and PNF as their subjects actually. So maybe they have to be grouped together when you look for evidence. Might have a role. In a style system, what do you think? Should you use it in such patients? Can it prevent PNF? Can it treat PNF?
Sorry, I beg your pardon.
Use of N-acetyl cysteine in such patients. Maybe Dr. Prem can comment on that. Do you think it will prevent PNF or decrease the incidence of PNF or
Yeah, there is,
PNF?
we routinely, I think most of the centers routinely.
Yes, we do.
Okay, in all the liver transplant recipients. Because as we know, it's an antioxidant and it decreases the liver injury and decreases the incidence of post-reperfusion syndrome also. And the peak serum ALT levels and the IL-4, IL-10 levels all have been shown to be decreased with the use of N-acetylcysteine. But there are varying dosages. Okay, some people use some 30 milligram per kg, some are using even 150 milligram per kg. So the dosage is not fixed. But there are many randomized controlled trials which have shown that definitely it is beneficial if used continuously during liver transplant. However, there are many randomized controlled trials on the contrary also showing that there is no benefit of N-acetylcysteine. So we don't know whether it's actually acting or not, but as a placebo, it seems to have a feel-good factor if N-acetylcysteine is going on.
The big systematic review has not shown any benefit, but there was one nice study from Italy. They've used it in donors before procurement, both systemically and also intraportal administration, and they have shown that this, with patients with marginal grafts, it decreases the incidence of EAD and PNF. So that might be interesting. That's something we can't do, especially if it comes from out of hospital. At least in India, we're too early to think about it, I guess. But that was a study which had positive outcomes. Prostaglandins, do you think it'll help, Dr. Selva?
Yeah, actually, personally, we haven't used prostaglandins. I think there are studies, prostaglandin I2, E1, they're supposed to improve the hepatic microcirculation, decrease ischemia reperfusion injuries. And there are case reports which say that the liver dysfunction is lesser in prostaglandins. But I think most of them are either for prophylaxis for PNF or treatment of EAD, not actually for treatment of PNF as such. So,
at this point, I don't think it might not be useful.
Yeah.
Now, immunosuppression, how do we handle this patient? Dr. Vich, what is your...
So, Akila, at this point of time, immunosuppression is least of our concern. I think it's not important with the renal shutdown. I think tacrolimus is no. We can give some small dose of steroids, as in all sepsis, like efcorlin or some solumetrol. That's it. So it's just about 1 or 2 days or 3 days. So anyways, the liver is gone.
Yep.
So immunosuppression, especially nephrotoxic immunosuppression, should not be given.
Okay. I think with the blood volumes also washed off several times and being replaced.
Yeah.
Patient is already immunosuppressed, I think so. So what happened was by day 3, the son had come forward for donation. Patient remained clinically the same, continued to be on NOR and vasopressin, ventilated, but the oxygenation was very good. PF ratio was good. He remained on CRRT, was anuric, continued to have high dextrose requirements. Lactates were around 6. The son had come forward for donation. Surgical challenges, what do you think would be a big in a patient who's had a DDLT and has come forward for a retransplant on day 3, having a PNF? Dr. Vich?
So surgical challenges are of any retransplant are same. More so with the retransplant of living donor liver transplant. It's just 3 days old. I think adhesions are not a problem at all. The only issue is because during DDLT, we implant the artery too low. So we have to retrieve the patch of artery because now we are moving for living donor liver transplant. So we have to keep the vessels long, and it will be a kind of mix of vessels of recipient, previous donor and new donor. So that's it. I think no major concerns as far as surgical thing goes, but artery has to be handled very carefully.
So addressing the concerns of Dr. Vora, with the current clinical condition of this recipient, are you happy to proceed with the retransplant?
So I think inotropes are very high, or
the doses have come down. I mean, he's had a session of...
So I can see that lactates are also 6 and doses have come down.
I think at 6, the doses have come down.
So
PF
any patient PNF or ALF with the inotropic doses coming down, I would be happy to take him rather than a patient who is having a static requirement or increasing requirement, I think that is no. But for this patient, of course, we should give him a chance.
Sure. Thank you. So he was scheduled for retransplant on day 3. Right, he had received a right lobe graft, the GRWR of 0.9. He had a straightforward course, intra-op, all supportive measures with CRRT were continued. Now the use of CRRT intra-op, any panelists can respond. What is your experience? I mean, there's been a lot of pros and cons that have been quoted for a use of intra-op CRRT. This patient we had used. How many of you? I mean, I think all of you would have used it, but any other different views on this use of CRRT in theatre?
Yeah, in this patient, definitely you have to use, because preoperatively before the retransplant, the patient was on CRRT. So you have to manage along the same, continue the same treatment in the intraoperative period. The problem with this is that all the complications of CRRT which are there, like generally we do heparin-free CRRT, and but there is chances of clotting in the circuit. Okay, disruption of the circuit might be there, and bleeding chances are more because all said and done, it's an extra-corporeal circulation, and it does absorb all the cold clotting factors and the platelets. So definitely the coagulopathy worsens and the patient is on CRRT. So routinely, if any patient is having some renal problem, we generally try to avoid the intraoperative CRRT. But this patient, definitely you will have to carry on the CRRT.
Dr. Lakshmi, your view?
Yeah, I come from a center where intraoperative CRRT was not practiced for a long time. But I think I take back my words. Having an intraoperative CRRT gives you so much of comfort with regard to the metabolic status, volume status, and electrolytes. I think it's a small concern of keeping the CRRT circuit without clotting. So in a patient, like for me, the first thing is at a MELD of 15, you've given a graft that had a long pooled ischemia, and this gentleman has had a PNF and a need for a super urgent transplant. So he becomes very precious in some ways. And I think I would do everything that would make the intraoperative course as safe as possible for this patient. And having started with no intraoperative CRRT, my vote is actually for intraoperative CRRT, particularly in cases of ALF and cases like this, where the preoperative metabolic milieu is actually, deranged.
Dr. Selva, any different opinion on this?
Yeah, actually, we also like to continue with intraop CRRT, or even sometimes rarely start, mostly like to continue. I think the main factor here is to handle the volume and the products. This is quite important in situations where there is, difficult surgery, long surgery, or borderline PF ratios, or increase in transfusions. So the unpredictability is what is a concern. So if it is going to be over in 4 or 5 hours and it's quick in and out, it's okay. But we can't predict that. So it's better to have this in hand and manage it. As far as the cons are considered, the anticoagulation is usually not a big deal. It doesn't usually clot. The hemodynamics are usually maintained well. The only major concern we might have is the hypothermia, which is because the circuit goes out of the cold operation theaters. But the warmers, inbuilt warmers, we can sort of manage that.
I think in centers where CRRTs are used all the time, they're not very worried about using them intra-op as well. Most of the concerns appear theoretical, like circuit disconnection, bleeding. Hypothermia, again, was a problem when we started. Now with use of inline warmers, it is not as big as a concern as it was in the past. So I think it should be okay. Dr. Vish, did you want to make a comment?
Yeah. Can I add something here?
Yeah, Shweta.
Yeah, in fact, CRRT comes in very handy to raise the patient's temperature.
Sometimes.
So in my experience, I would use CRRT because not only for the metabolic reasons, this patient is not going to reverse on table, is not going to be reversed on table, and everything is not going to be plumb normal just after reperfusion when the new liver kicks in. It's going to take time. So this patient definitely needs the CRRT to continue, and temperature and other things are going to be better managed, I feel, with CRRT.
I think we were looking forward for the inception studies results, but it was stopped even in the pilot stage because they were not able to recruit patients to studying the benefits and outcomes of patients with intra-op CRRT, but somehow they couldn't progress beyond the pilot stage. But again, they have shown that it's quite safe and feasible to use intra-op CRRT. So it's just the resource that needs to be available. So
actually, there was a meta-analysis in 2020 by Wang et al., and they had said that there is no definite criteria for use of intraoperative CRRT, but they commented that yes, in very severely ill patients with severe kidney dysfunction, definitely it is safe and feasible. Okay, rather than in patients not using CRRT. So definitely it can be used in, but there are no definite criteria when you should use intraop CRRT. I think you have to be.
There was also a comment that it has to be, I mean, if you started it electively, if it's a planned intra-op CRRT, the outcomes are far better than in a patient where you had to use as an emergency. I think it also signifies the severity of the disorder rather than use of CRRT per se. But if it used electively, it definitely offers superior outcomes compared to patients who have without CRRT.
Dr. Vivek, please.
Yeah, a small comment.
Yeah,
I fully agree that a center which has great experience about CRRT, they are very comfortable in using CRRT in operation theaters. No, but there are many centers in the world who don't use CRRT or don't have so much experience. Just for them, as our protocol also, we rarely use CRRT in operation theater. We do it before and after that because we know the timing of transplant. Coming to this patient specifically, this patient doesn't have a dissection phase, or everything is dissected out, right? And you can literally take out the liver in just 15 minutes in this case. And you can reperfuse back in next 30 minutes. 1 hour to 1.5 hours in this patient, and whole mingling of CRRT, taking everything together in operation theater. I agree, the centers who do it, they should do it. They should do it. I'm not against that, but it's not mandatory. That's what my point it is. Especially in such cases where we know that reperfusion will be very fast and temperatures will be maintained. Artery is a different, artery and bile duct can take time. But once the reperfusion happens, the metabolism starts getting reversing. That's my whole point. It should not be projected as a mandatory thing in operation theater rather than a kind of a supplementary thing.
I think Dr. Vivek used to say the new liver is the new CRRT machine when he used to open it.
So I think we'll have to conclude this very interesting discussion.
Yeah, we're done, Shweta. So basically, patient was extubated on day 2 and the renal function recovered. He was weaned off CRRT by day 3. Day 11, he was transferred to the ward and discharged home on day 25 after the first transplantation. Yeah.
We congratulate you for saving a life.
And I must thank Shweta for including a surgeon in the panel. It becomes very interesting.
It's easy to corner a surgeon, right?
All of us here did a good job. So, Sam, would you like to add something here?
No, I thought that was a very interesting case, and I agree with all of the discussions actually that many of the interventions discussed and suggestions are exactly what we would practice at King's. I think some of the comments that I might make would relate to, so in terms of the N-acetylcysteine, yes, agree, limited evidence. But we would start it in a PNF case. I think our feeling is, relatively there's very little side effects unless you have the anaphylaxis associated with it. But if you're not one of those patients, continuing high dose N-acetylcysteine whilst waiting may be beneficial, and therefore we would err on the side of giving it rather than not. In terms of plasma exchange, we would just utilize plasma exchange in 2 situations for this. If they had significant coagulopathy with vasoplegia and high dose pressors, just like in acute liver failure patients that we've discussed throughout the morning, I think plasma exchange may be useful in sort of bridging you whilst waiting for the next next sort of liver to become available. So using as a bridge to retransplantation. And we've also used it when there's been massive hepatic necrosis and the patient is extremely unstable. The surgeons will, on discussion with ICU, we will advocate on rare occasions to make the patient anapathic. And if we do that, to provide a bit of stability, we'll use plasma exchange to maintain them. But you would need to be confident that another liver was likely to become available in that situation. But those are the only main comments. But I think there's a very interesting case, and great to see such great work happening everywhere. You're on mute, Shweta.
You're muted.
Sorry. So we'll move on to the third session. Thank you so much, everyone.
Thank you all. Thank you.
Thank you. Thank you.
Thank you, Shweta, for inviting me.
Yeah, thank you, Dr. Shweta, for that excellent session. And we are running late, so we'll move on to the next section. Session 3 on early graft dysfunction in ICU. And for that, may I invite the chairpersons, Dr. Abhideep Chowdhury, who is the director, HBB and Neurotransplant at BLK Max Hospital, Delhi. Dr. Ashok Chowdhury, who is the director of hepatology at Narayana Health, Gurugram. Dr. Matthew Jacob, lead consultant liver transplant, M.I.C.E, Kochi. And Dr. Narendra Chowdhury, who is a senior consultant in hepatology at Medanta M.I.C.E, Gurugram. And for the first session, may I invite Dr. Neeraj Saraf, who is secretary of LTSI, and he is the director of hepatology at Medanta M.I.C.E, Gurugram. He'll be talking on therapeutic plasma exchange in the management of early graft dysfunction after liver transplant. Over to you, Dr. Neeraj.
Yeah, thank you, Charles. Can you hear me?
Yes.
Yeah, okay. So we've heard of therapeutic plasma exchange earlier in the day in acute liver failure and acute on chronic liver failure, and a little bit in PNF in the last discussion, in the case-based discussion. In the next few minutes, I'll be talking of the role of plasma exchange in early graft dysfunction after liver transplantation. So I'll talk a little bit about how do we define EGD, what's the mechanism of plasma exchange in early graft dysfunction, what's the current evidence based on literature, what probably should be the timing and indications for plasma exchange. I'll share a little bit of our experience, and then I'll end it with where do we place plasma exchange in clinical practice today. So I think we all know the definitions of early graft or early allograft dysfunction. And this is the most standard definition which is used. Bilirubin of more than 10 on day 7, INR of more than 1.6 on day 7, and ALT or AST more than 2000 within the first 7 days. In LDLT, it is a little modified. A lot of times it is small for size syndrome. And so within 2 weeks of LDLT, if the GRWR is less than 0.8, bilirubin more than 5, and or ascites more than 1 liter per day, and presence of coagulopathy. And of course, to call it EGD or EAD, we must exclude other causes like technical reasons for graft dysfunction, infective and immunological complications. So EGD is basically an extreme case of ischemia reperfusion injury. There's damage from reactive oxygen species and sinusoidal endothelial cell damage. There is acute inflammatory infiltrate of the graft, hepatocellular damage presenting as coagulative necrosis and balloon degeneration. Especially in LDLT, there is usually a low GRWR or a left lobe graft and higher portal perfusion pressures leading to graft injury and post-transplant sepsis. So how does plasma exchange help? So this diagram really doesn't pertain only to early graft dysfunction. This is to show how plasma exchange helps in liver failure. So when you have there is liver damage, there's increase in flow, pro-inflammatory macrophages, monocyte activation, pro-inflammatory monocytes, which are increased, and pro-inflammatory neutrophils, which are increased. So what plasmapheresis does is removal of the DAMPs, removal of other pro-inflammatory mediators, decreases pro-inflammatory monocytes and cytokines, and basically attenuates the monophytes and neutrophils to improve the liver immunology. Now, this is again a diagram not for EGD, but for plasma exchange in ACLF. And what the plasma exchange does is basically it improves the CRRT components and prevents multi-organ failure. So the basic concepts remain same in early graft dysfunction as well. And it's basically attenuation of innate immune activation and amelioration of multi-organ dysfunction syndrome. So what does plasma exchange do in early graft dysfunction? Well, we can remove the plasma containing free and protein-bound toxic substrates and infuse fresh plasma, as well as clotting factors and albumin, thus functioning as a liver support and creating a milieu conducive to liver regeneration. The beneficial role of plasma exchange is also clearance of ammonia, inflammatory cytokines, and markers of oxidative stress, as well as improvement of the dysregulated immune system. So it's similar to what it would do in a patient of acute and chronic liver failure, for example. Non-selective removal of substances from the blood, including antibiotics and immunosuppressive agents that are crucial for the management of post-transplant sepsis, also happens when you do a plasma exchange, and that is something which we need to be wary about. The amount of substance removed during plasma exchange is determined obviously by factors related to the procedure, such as volume of exchange, duration of procedure, and the frequency of the therapeutic plasma exchange. Now, this is one of the first studies published in 2012, which showed that there is some role of plasmapheresis as a liver support for early graft dysfunction in adult living donor liver transplantation. So this study had 50 patients who underwent 517 sessions of plasmapheresis, a mean of about 10 over a period of 3 to 4 weeks. The mean time from transplant to start of plasmapheresis was 11 plus minus 6.8 days. 34 patients required concurrent hemodiafiltration. So out of 50 patients, the mean bilirubin concentration before plasmapheresis was 16, and it decreased to 13 plus minus 5.4 1 week after completion of plasmapheresis with a significant p-value. There were no serious complications related to the procedure, and of the 50 patients, 17, that is 34%, died soon or in a few months after plasmapheresis. So in this study, the 6-month graft survival after completion of plasma exchange was 66%, and the overall 1-year patient survival was 64%. Now, if we look at the parameters which improved, so the bilirubin and prothrombin time were the only parameters which improved significantly. And so this paper basically conveyed that plasmapheresis may have a beneficial effect for LDLT recipients with early graft dysfunction, namely total bilirubin concentrations more than 10 mg/cent. This is another paper published in 2016 from the Seoul group, from S.G. Lee's group, effects of TPE on early allograft dysfunction after liver transplantation. And in this study, EAD was defined as a sustained hyperbilirubinemia of more than 10 within 30 days of transplant without concurrent biliary complications. So this is again a retrospective study. 107 patients underwent plasma exchange and 36 patients underwent no plasma exchange. And if you look at the graph here, there is significantly better survival in the group which underwent therapeutic plasma exchange compared to that which didn't. So the 1 month and 1 year survival rates in the TPE group were 82 and 53% versus 58 and 22% in the non-TPE group. So this is one of the studies, early studies, which showed that there is a beneficial effect of plasma exchange in early graft dysfunction. Now, if we look at the study in more detail, in the TPE group, there's a significant decrease in bilirubin, a significant decrease in INR, the significant improvement in the liver transaminases also. And if you look at the non-TPE group, the bilirubin actually goes up at 1 month after the final TPE with a clinically significant p-value. So they showed a benefit or improvement in bilirubin and INR as well as the liver enzymes. Now, what were the factors which affected survival? So this study showed that age of more than 51 had a poorer survival even after a plasma exchange as compared to age less than 51. Cutoff of bilirubin of 11.1 again had a poorer survival. Patients who had a bilirubin of more than 11.1, and similarly patients who had an INR of more than 1.5 had a poorer survival as compared to those who had a lesser INR. Plasma exchange, of course, comes with its own adverse effects. And in this study, the most common side effect was hypotension, probably because of fluid shifts. Chills, abdominal pain, itching, nausea, vomiting were again less common side effects. So the most common side effect, and this has been shown in other studies as well, is hypotension because of fluid shifts. Now, this is a recent study published from Professor Rela's group from Chennai. And this is again a retrospective study in which they looked at TPE for management of early graft dysfunction, and it was an unmatched cohort retrospective study. 465 adult transplants, 14.4% had EAD, and 43 had therapeutic plasma exchange, and 24 patients, that is 36%, did not. So this study, if you look at the biochemical parameters, before the first TPE versus after the last TPE, there was no improvement in bilirubin, INR, liver enzymes, creatinine, or albumin in the group which underwent therapeutic plasma exchange. Now, the therapeutic plasma exchange group had more preoperative acute kidney injury, lower graft recipient weight ratio, and slightly higher final portal pressure. So basically, the group which underwent TPE was a sicker group. They had more pre-op as well as post-op AKI. They had most patients had pre-operative sepsis, and so this was a group which was sicker, and there was a bias, and that is why probably the results of TPE in this study are not very positive. So there was no 90-day mortality in the group without TPE. In the patients who underwent plasma exchange, 45% died. And patients who received plasma exchange had more septic complications and needed more post-operative renal replacement. And if you look at this table again, the group with TPE had more pre and post-operative AKI, need for dialysis, and septic complications. So this study did not show any survival benefit with therapeutic plasma exchange, although the group which got the plasma exchange was probably a sicker group, and they had more renal dysfunction and sepsis, which caused a higher mortality in this group of patients. These are some more studies which have been published recently. The first two studies I've already talked of. Again, two more studies from Japan, small studies less than 50 patients, and clearly not showing any survival benefit of plasma exchange. But again, these were small studies. Probably the group who underwent plasma exchange were sicker, and again, no comparative arms and a retrospective analysis. So we've seen that acute kidney injury and sepsis probably hinder the role of plasma exchange when we do it for patients with early graft dysfunction. Now, does plasma exchange help in sepsis? Well, theoretically, yes, it has the potential to improve survival in sepsis by removal of inflammatory cytokines and restoration of deficient plasma proteins. But two studies, one meta-analysis of 194 patients and a Cochrane review, both refuted this, and they showed that the use of plasma exchange was not associated with a significant reduction of all-cause mortality. Now, these meta-analysis and the review, these are not of liver transplant recipients, but these are of patients who have undergone plasma exchange for sepsis. But what I'm trying to say is that plasma exchange is probably not very useful when a patient has sepsis, and that goes with early graft dysfunction as well. We've used plasma exchange over the last 3-4 years in patients with early graft dysfunction. We've had a total of 18 patients who underwent plasma exchange, 16 within 1 month, and 2 were after about a year. The mean CTP score was 10, mean MELD score was 21.5, and the median GRWR was 0.87. The median bilirubin was 22.5, and the mean INR was 1.7. So of the 18 patients, we did 12 of them for EGD, the rest for other reasons. And out of 12, 9 patients in our experience died and only 3 survived. And again, I think going back to Professor Rela's paper as well, I think this is also a retrospective analysis, and probably we've done the plasma exchange in patients who are probably sicker as compared to, obviously we didn't have a comparative arm, and this is unpublished data. So again, just to highlight this, we've done 12 patients plasma exchange for EGD, and 3 have survived. And again, I think it's probably partly because of it being done in sicker patients. So what do we do? Like most centers, for acute liver failure or for ACLF, a higher plasma volume is used. But for early graft dysfunction, we use a 1 to 1.5 volume, and this is being shown in other studies as well. And we keep a blood flow of 100 ml per minute and plasma flow of 500 to 1000 ml per hour. The duration is usually 6 to 10 hours, and we have done anywhere from 3 to 5 sessions for the patients we have done for early graft dysfunction. So based on our experience and literature available, I think it's very important to decide what are the indications for plasma exchange, and the timing has to be right. Of course, it should be done in patients who meet the standard criteria for early graft dysfunction. We should rule out other treatable causes of graft dysfunction. I think renal function and extrahepatic organ failure are very important when we decide to take up patients for plasma exchange. Patients with AKI and patients with multi-organ failure don't do well. And it has also been shown that patients with higher age don't do as well with plasma exchange. So where do we stand today? Should plasma exchange become standard of care? Well, I don't think so. I think it's early days. We need more data. And like I said, most studies which have been done are small studies, retrospective, no comparative arms. And most of the times, plasma exchange was done in the sicker group of patients. So we really need to understand how early it should be done, how long, what volumes. Can you do it in renal failure patients and sepsis? And does it improve survival? So I think this is where we stand. I think it is a promising a tool, but probably the timing has to be early rather than late, and more data is needed before we can really start using it as standard of care for early graft dysfunction. Thank you.
Thank you, Dr. Neeraj, for that excellent talk, and we can have a few questions.
Yeah, myself, Dr. Ashok. Dr. Neeraj, I want to ask one question. Do we go for biopsy, or have we established this only as per the criteria, this graft dysfunction?
Yes, so in the patients I showed, I think 83% of them did have a liver biopsy.
Yeah.
Yes, so because you, like I said, you have to rule out other causes of graft dysfunction. So that would be by imaging. And of course, for immunological causes and rejection, you need to do a biopsy. So most patients would have a liver biopsy.
Basically, in biopsy, what we get in most of the cases?
Most of the patients, I think we predominantly find a cholestatic pattern of liver disease. Yeah.
So that is what the biggest challenge.
So in which patient you will use plasmapheresis, sir?
So I think once you've ruled out other causes of graft dysfunction, a patient has a rising bilirubin, a rising INR, meets the criteria for EGD. Probably that is the time to use it before sepsis sets in. We know that all of these patients eventually they will get infected, they will have renal dysfunction, they will have multi-organ failure. So I think before the multi-organ failure sets in, that is where you probably need to use them. And I think you've been part of the team, and I think a lot of times we end up using it as a last-ditch effort, as a desperate measure, and use it too late. So probably used early enough, I think may have better benefits.
Neeraj, that's an excellent talk. Can I ask you a question? Sonal? Yeah, I mean, I think that as you correctly say, the cause and effect is not very clear in this particular group. We're not sure whether, the benefit is limited because you are dealing with a very, very sick group of patients. But equally, having that unmatched group is actually a bit of a problem. Because if you have a 75% mortality, then it's very difficult to say that the 25% survived only because of your therapeutic intervention. So it is a little bit of a tricky situation to be in. And I mean, given the rarity of the situation, I suspect that you can never get a matched control cohort to get the real answer.
Yes, absolutely. I think, and that's what most studies have shown actually, that there has been really no major survival benefit. But again, I think there are various reasons for that. And I think all I can say is probably that it has a potential in a selected group of patients.
I want to add to compliment Dr. Sonal in that when we should think of a retransplant, because in these groups being such a high mortality, and you have started plasma on day 12, and on day 12, if you starting plasma exchange, and likely response is 30%. So should we offer them retransplant option, or is there any criteria or any way forward algorithmic approach? What should be?
Yeah, I think yes. After a certain point, yes, you do have to offer them a retransplant. Transplant doesn't happen overnight anyway, and retransplant is not easy. Getting another donor finances, so I think the option definitely has to be given. And I would probably if the family is ready, then probably at least work up the donor, identify and work up a donor, because a lot of these patients would need a retransplant.
I don't think they will get any priority if the DDLT list is existing. Despite being post-LT graft dysfunction, yeah, they will get, because it is early allograft dysfunction.
I mean,
No priority.
No priority. In this part of the country, we don't have any donations anyway.
Cadaver is not there.
No, but EAD typically doesn't get priority.
Yeah.
Only primary non-function gets priority. So allograft dysfunction not typically. That's not a prioritization criteria for ALF.
Yeah.
Can I comment as well? Hello, Nirav?
You are not audible.
Yeah, can you hear me now?
Dr. Sonal, you have muted yourself.
Can I ask, can I comment?
Yeah.
Can you hear me?
Yes, sir.
Can you hear me?
Yes, sir, you are audible.
Yeah, Parmecha, we can hear you.
Okay, can you hear me now?
Yeah, you're audible, Virendra. Please carry on.
Okay, so nice talk, actually, Nirav, quite enjoyed it. So just the comment is, I think some of the problems are related to how we define EJD in LTSI setting. Because we all know that there is a good proportion who will actually make it out without actually needing any aggressive therapy. If we just manage them conservatively and prevent sepsis, there will be a good proportion who will actually recover from this. But there is a proportion who won't recover, and actually the ultimate option for them is retransplantation. And I think that's where the problem comes in, that who will actually go to that extent, and whether we can identify that group of patients early in the course and actually track them towards retransplantation rather than trying other things. And that's where actually we have tried to define the EJD in the context of LDLT. And that's the dynamic definition which starts at the end of the day, at the end of the day 7. And then you see the parameters for 5 days, which is bilirubin, INR, and urea. Surprisingly, urea actually came out as one of the factors. And when you combine these 3 factors for 5 days and see how it behaves, that actually has got a 95% predicting in terms of mortality from EJ. So that's where actually the crux comes in. If we define the entity properly, then we probably will be able to churn out those patients who will benefit from retransplantation by early identification.
Yeah, absolutely. I think you're absolutely right that, identifying this group of patients who will recover, with supportive treatment, who needs a plasma exchange, who needs a retransplant. I think that's pretty tricky, and it's not easy to do.
Yeah, nice talk. Enjoyed it.
Can I ask a question, Neeraj?
Yeah.
I think we have resorted, I would use the word resorted, to plasma exchange in early graft dysfunction when we've had to, and it has helped in many cases. But in our experience, and I want to know about yours, is there a flaring of sepsis? You feel that, because actually in your talk you said otherwise. But
so
in your
our
experience,
no, again, we haven't really analyzed it in great detail, and this is unpublished data, but I don't think there is a flare in sepsis with plasma exchange as compared to, like maybe other liver support systems. So with plasma exchange, we've had problems with fluid overload or, hemodynamic issues, but not really sepsis. But yes, patients who have sepsis and undergo plasma exchange, they do badly.
Yeah, but Neeraj rightly said, with sepsis, I think we prefer less to go for plasma exchange.
Absolutely.
I think it is a common practice.
Yeah,
because literature may be showing that plasma exchange is helpful.
No, even literature doesn't show. Like I said, the meta-analysis showed that it doesn't help actually.
so if you have a patient with graft dysfunction and he's having a bile leak, I don't think that this is a right candidate for plasma exchange.
No, definitely. I think you need to fix the bile leak first. Yeah.
No, but it's not possible sometimes to actually do much about it in the first 30, 45 days. You really can't do much. Intervention, I mean.
Yeah, but I think, obviously, I don't think plasma exchange would help in such a situation.
So can I make a comment on this if chair allows? Hello.
Yes,
sir.
Yes, sir, definitely.
So as we discussed about the plasma exchange, I would like to highlight 2-3 things here. Plasma exchange is not a therapy. We shouldn't take it as a therapy. It is a bridging thing. So we can bridge. Liver has to improve on its own. Plasma therapy, plasma exchange cannot
do that. Plasma exchange only can bridge the time. As far as the infection is there, we have to have certain protocol in place. After each plasma exchange, we should give the loading dose of all the antibiotics, because majority of the antibiotics which are plasma bound or this protein bound, they will go down the drain. So we should give immediately after plasma exchange the loading doses of all the antibiotics. That is one thing. Side by side, we should send the daily cultures after plasma exchange. The concept of infection after plasma exchange is because if there is no hand hygiene or poor hand hygiene, if we are playing with the blood, if there is any breach of the sepsis during the process, somebody has not cleaned the hubs, somebody has not cleaned the hands, touched any circuit, open circuit part, then of course the contamination will happen and infection will flare up like anything. So if all the things are being done aseptically and we are loading the patients with antibiotic after the plasma exchange, I don't see is there any possibility of flaring of infection.
Yeah, absolutely. And like you said, it's a bridge. So like you do it for ALF or ACLF, it's same thing for, post-transplant graft dysfunction. You hope that eventually the liver will kickstart. Yeah, and you just buy time.
I think that it's this discussion. Are we done? I'd like to ask the chairpersons if we can move on to the next talk. Yeah. So actually, I would like to modify the sequence a little bit. I'd like to invite Dr. Deepak Govil actually for the next talk. So is that all right, Dr. Neeraj?
Yeah, I think so. Is Dr. Soin probably stuck in the OT or something?
Yeah. So I would like to invite Dr. Deepak Govil, who is Director Intensive Care at Medanta Hospitals. And he will be speaking on role of cytokine absorption in sepsis in liver disease.
Thank you, Dr. Shweta and Dr. Sharaf, for giving me this opportunity. So I'll just share my slides. Give me a minute. Not minute, maybe few seconds. Today, I'm going to speak about the role of cytokine absorption and the endotoxin assay in sepsis in liver disease. So, first of all, I would like to give you a case scenario where a young man underwent liver transplant for ethanol-related CLD. He was having SBP prior to surgery 1 month back. He was treated. Intra-op, everything was fine. Received in ICU with low dose of norepinephrine on ventilator. Fast track weaning was performed, extubated within 12 hours, investigation showing favorable trend. Day 3, suddenly patient develops fever, trends of hypotension despite of fluid resuscitation. ABG started showing increase in base deficit and rising lactate. Other labs also deteriorating trends were there. CT chest and abdomen was done. Nothing significant was there. Norepinephrine, which was stopped, restarted again, and endotoxin assay was sent. So this was trend. It's a everyday story. Patients, everything is going fine. Everything is fine. Surgeons also start relaxing. And then suddenly patient has a dip. So at 72 hours, this was the situation. White count suddenly went high to 26. INR, which was getting better, deteriorated. And bilirubin also started going high. Base deficit was there. PF ratio was high. And vaso and everything was started. NORAD was started. His EA level came 0.79. Patient underwent first session of polymyxin B heme absorption cartridge for 8 hours. Vital parameters started stabilizing. And you can see, blah, blah. Ultimately, the patient went off very well. Discharged home. So coming back to the main topic. As you all know, sepsis is the primary cause of death in the intensive care unit, be it a liver patient, be it not a liver patient. Sepsis is having almost 40% mortality. More than 35% of the patients are admitted with sepsis or develop it during intensive care unit. So 35% is there. Hospital mortality rates varies from 27%. Those patients who are having less morbidity and younger age reaching up to 54%, like in liver patients where they develop septic shock. So coming back to the original topic, concept of blood purification. Systemic inflammatory states such as severe sepsis and septic shock result in immunological disturbances with the release of numerous inflammatory mediators. Two mechanisms are identified to explain the potential harmful effect of these host inflammatory response. One is cytokine surge and another is a prolonged release of inflammatory mediators. So blood purification therefore attenuates this overwhelming systemic expression of pro and anti-inflammatory mediators. It restores the immune homeostasis, and we feel that this homeostasis restoration will improve the outcome and survival. Although why I am saying we feel, because it is not well proven in the literature. Thus, over time, the blood purification concept and therapies have evolved towards the non-specific removal of a broad spectrum inflammatory mediators. Most of you must have seen this picture. This is the infective insult, and this is the infective insult, and this is the immune response. So immediately there is a pro-inflammatory arm is high, and this area is the critical area where the patient's own body responds. The pro-inflammatory mediators, they can cause the problems, and they can cause the multi-organ failure, specifically the shock and the lung problems. So this is the ideal time where there is a cytokine storm, likely maximum benefit with the extracorporeal therapy or extracorporeal removal of the cytokines. Whereas when the time elapses and patient goes into this C phase, which is the curative and anti-inflammatory arm, restoring immune behavior, at this point of time, if we give this therapies, extracorporeal therapies, they could be harmful. So timing again becomes very important. Coming back to endotoxins, they are the trigger of a sepsis. Biological substances causing sepsis release from the gram-negative bacteria cell wall when antibiotics are used to treat infection. So when the bacterial cell wall get disintegrated, this type of endotoxins are getting released. Presence of circulating endotoxin is linked with increased severity of illness and ARDS. Elevated level of endotoxin is associated with increased organ dysfunction and higher risk of death. So endotoxins are lipopolysaccharides and cell wall constituents of gram-negative bacilli. We have already discussed those things. Gram-negative bacterial endotoxin is a biological pyrogen that causes fever when introduced intravenously. Excessive inflammation causes multi-organ failure and death. Endotoxins, which are ubiquitous pathogenic molecules, are a bane to the pharmaceutical industry and healthcare community. Thus, early and sensitive detection of endotoxin is crucial to prevent endotoxemia. This is the collection of few literature where they have highlighted that newly developed endotoxin measurement method, the endotoxin assay, may reflect the severity of sepsis. Again, there are 3-4 citations here where they have said that this endotoxin assay can be an important marker to identify patients who are at risk of developing sepsis and septic shock. So what is the rationale for removing these endotoxins? In severe sepsis, patients with high concentration of endotoxin had higher mortality than those without measurable endotoxin. Thus, removal of endotoxin is hoped to improve outcome in gram-negative sepsis. Targeting endotoxin early in a sepsis clinical presentation could help reverse or limit this disease before the cascade reaction becomes overwhelming. So if you look at here, from cytotoxic model to cytokinetic model, so look at here, the blood before purification, there is an infected tissue in the abdomen, lung, where the source lies, and there are multiple cytokines, chemokines, concentration gradients, and these all are lying here in the blood. When we do this heme adsorption, certainly there is a number of these are going down in the plasma. So they are adsorbed, these cytokines, chemokines, they are getting adsorbed to the membrane of the filter. As you can see here, same thing. So the moment we use this blood purification devices in between, then the debulking is there, less bacteria, cytokines and leukocytes are passed through this. These are the different extracorporeal therapies which are available: hemodialysis, hemofiltration, heme adsorption, plasma filtration, cell-based therapy, and combination of these. So heme adsorption places sorbent in direct contact with the blood via extracorporeal circuit. So there is a membrane which is placed between the blood, and blood is passing through that membrane, and it adsorbs some cytokines and chemokines. The sorbent attracts solute through hydrophobic interaction, ionic attraction, and hydrogen bonding and Vandenberg-Wheels interaction. It has high molecular weight adsorption potential, allowing it to target large molecules exceeding the cutoff of conventional synthetic high flux hemofilters. So we have to have a right choice and selection of hemoperfusion therapies. These three we are using commonly: Cytosorb, Toremixin, and Oxaris. I'll talk about one by one. Cytosorb is an extracorporeal cytokine filter, prevents and limits the organ failure used with conventional CRRT or a normal SLED machine. The heart of the technology is the biocompatible, highly porous polymer leads that can remove a wide range of toxic substance from blood and fluid based on the pre-capture and the surface adsorption. If we talk about the surface area of this, it comes to around 40 football team grounds. The surface area becomes of these small beads. These are the cytokine sweet spots. As you can see, the size selectability, these are the IL-1 alpha, TNF alpha, TNF gamma, and IL-18, IL-6, TNF alpha trimer. So these are the different things which can be absorbed by the cytosorb. These are different case series are there where they have said that heme absorption using cytosorb resulted in rapid hemodynamic stabilization and increased survival. Coming to the another device is the Toremixin. It is a composed of polymyxin B covalent immobilized polystyrene derived fibers. Toremixin removes the endotoxin in the blood. So there are two distinct things. One is the endotoxin, one is the cytokines. Cytokines are the things which are secreted by our own body in the defense of the infection, whereas the endotoxin, as I discussed earlier, is being released from the cell wall of a bacteria, gram-negative bacteria. So if we talk about, there are certain studies which favors the PMX hemoperfusion in the sepsis septic shock. Although jury is not clear, jury is still out, the verdict is not very clear. But different papers are there which says that there is a potential survival benefit with these in the septic shock patients. So to whom we should use, where the endotoxemia is high or we are suspecting the gram-negative infection. As we have already discussed, we take the cutoff of 0.6 of the endotoxin assay to use this type of therapies. Euphrates trial failed to show a positive result. However, some positive signals were recognized. Therefore, we think it is too early to give up the use of PMX. The effect were most evident in the subgroup of the patient with abdominal infection with shock and MOD score of more than 9 and EA level between 0.6 and 0.9. So our majority of the transplant patients are having the intra-abdominal sepsis only. Third device which you use sometimes is the Oxaris. It's an endotoxin absorption. It causes the cytokine absorption. It is a hemocompatibility. So it can be used in both the conditions. It is a blood purification device that can remove endotoxin by adsorption, provide renal support by usual diffusive and convective therapies. The membrane is additionally grafted with heparin, which makes it even more suitable for patients with challenging coagulation parameters like septic patients. So as you can see, this is the heparin, this is the endotoxin, cytokine are being released, being absorbed by the surface. And heparin P coating remains active for inhibition of thrombin and by formation of thrombin, antithrombin complex. The surface treatment, it absorbs the endotoxin, and selective absorbed into the membrane bulk is the cytokines. So as you can see, this is the LPS absorption on the Oxaris membrane versus standard dialysis membrane. This is the endotoxin plasma concentration after the therapy. As you can see, it has gone down drastically. So the way we do it, cytosorb in the case expected to have cytokine storm, acute severe pancreatitis, alcoholic hepatitis, post-surgery, vasodilated state, trauma with cirrhosis, where we don't feel that the infection is there, sepsis is that predominant, or non-gram-negative sepsis is there. Auxeris in those patients where the cytokine storm is there, severe sepsis, along with the need of CRRT is there. Toremixin, it is expected gram-negative severe sepsis or septic shock. Again, this is a homemade thing. I cannot say that which one is very true. It is, things are overlapping. So finally, many studies have reported promising results showing that the blood purification therapies are well tolerated, effective in clearing inflammatory mediators and or endotoxins, and responsible for an improvement of different physiological parameters. The better understanding of how these therapies work by modulating the cytotoxic and cytokinetic effect of inflammatory mediators is essential. Considerable work remains in order to find out and optimize the best blood purification strategy for treatment of sepsis. Trials, open point, mode of action, optimal timing, length, intensity, frequency of treatment in the clinical setting are the still open points. They need a trial and closure. Thank you very much for your patient hearing.
Thank you, Dr. Govil, for this interesting talk on this sort of difficult topic, which is not commonly, covered, and these procedures are not usually standard of care. We're running late. Maybe we can have one or two questions from the chairpersons, or I don't think there's anything in the chat box. Any comments, questions?
Sir, what is cost of these filters?
The cost of these filters are varying from company to company. They are starting from 80,000 to 1.5 lakh rupees of one filter.
And how many sessions?
We usually don't go beyond 2, because what I feel that timing is key. So within first 48 hours, if we are able to use it, then only it works. As I've already shown in the few slides, that it works when the anti-inflammatory surge is there. So after 48 hours, I feel that it is useless to use it, because then the body's defense mechanism takes its own course, and these homeostasis of these markers, they may change. So we rarely go beyond 2. Generally, we get result in 1, otherwise no results.
Okay, I think we'll, thank you, Dr. Govil. I think we'll go back to the previous session on early graft dysfunction. And Dr. Soin, are you there now? Is Dr. Soin there?
No, sir. He's available, but he's not visible in the mic and video.
This was around 5:15.
Sir, he is logging in just spoken to.
The expert panel for this case discussion. Dr. Dinesh Jyotimani, who's a senior hepatologist at the Rela Institute in Chennai. Dr. Sonal Asthana, chief liver transplant surgeon at Aster Medicity, Bangalore. I think Ravi is not available. And Dr. Amit Rastogi, again, senior transplant surgeon at Medanta. Manav also, I think, has just logged off. I think had some other commitment and we were running late. Let me just try. Welcome, Dr. Soin. So I've just introduced the panel, and Dr. Soin needs no introduction. He's chairman and chief liver transplant and hepatobiliary surgeon at Medanta Medicity. And he will be moderating a case-based panel discussion on early graft dysfunction.
Thanks, Neeraj. Hello, everyone. Can you all hear me?
Yeah, we can hear you.
Yes, yes.
Okay, excellent. Thanks, first of all, the LTSI team, Neeraj and others who put this meeting together. It's a great topic because there's a lot of controversy, a lot of experience to be shared. Ideally, I would have liked to follow immediately after Neeraj's talk, but then, anyway. So we're going to talk about early graft dysfunction after liver transplantation, and I'm going to base it on a case capsule, but then we're going to step outside the bounds of the capsule itself and talk about other situations apart from the ones that were presented by this patient. So the case in discussion is a 46-year-old male.
Hello.
Yes.
We have Dr. Ravi and Manav missing, so maybe we include Neeraj in the panel so that ultimately it will be three of us, me, Neeraj, and Dr. Dinesh. So we.
So Sonal is there. Sonal is there.
Okay, hold on. Sorry. So there's Amit among the originals. There is Amit. There is Sonal. There is Dinesh. And
Dinesh Jyotimani.
Dinesh is there. I know.
Yeah.
And there is. I can see Sanjeev. Hi, Sanjeev.
We can add Sanjeev then. I think Sanjeev can on.
Yes, good. That's fine. More than welcome. So there's Dinesh, there's Neeraj, there's Sanjeev, there's Amit, and there is Sonal. I can't see Sonal. Sonal's there.
Yes, sir. He's there, sir.
I'm here, Dr. Soin. Please carry on. I can see you.
So then I will accordingly change the names that I'm going to ask the questions to, but that's not a problem. So 46-year-old male from Bangladesh who had NASH-related cirrhosis. He had type 2 diabetes, hypertension, a coronary artery disease, single vessel, non-occlusive, I think about 70% block. So we went on regardless. And he was obese at 118 kilos and a BMI of nearly 40. He had rapidly accumulating ascites with frequent need for large volume paracentesis. And he underwent TIPS prior to the transplant. So what happened was that in 2013, he was diagnosed with NASH CLD. At that time, he was compensated and he started decompensating a couple of years later with ascites and initially diuretic responsive. He also had large varices for which he had EVL. And then, of course, the ascites became recalcitrant to diuretics. So he had recurrent ascites and LVPs, which is why he underwent a TIPS in 2016. And then in 17, as usually happens, a few months later, he started having encephalopathy and he had GI bleed as well. So both happened. Anyway, so in a year later after TIPS, he was transplanted for decompensated NASH cirrhosis. So preoperatively, his counts are shown here, which are kind of the usual range for decompensated CLD with a platelet count of 48. INR was 1.6. Serum creatinine and sodium were as shown. Bilirubin was 2. Nothing else much remarkable. Albumin was 2.8. And he was negative for all viruses. And he had a coil placement for esophageal viruses. Right. So that's the recipient we had. And so that's the donor, 27-year-old cousin, no comorbidities, vital markers negative, LAI plus 21, GRWR 0.69, because the guy was like 118 kilos. So I don't think you'll get a single donor who was able to give more right lobe. His remnant was nearly 40%. His liver biopsy of the graft side was unremarkable. And the recipient, as you know, had all that. And then during surgery, he, of course, had a relatively uneventful surgery with a right lobe living donor liver transplant and a hemiportocaval shunt, as is our protocol for patients who have less than 0.7 to 0.75 GRWR, depending on what sort of pressures they have before. In this particular case, unfortunately, the graft weight was about 150 grams less. So the eventual GRWR was 0.54%. And the portal pressures after reperfusion were 17, once the HPCS was also in circulation. He had a longish cold ischemia time of nearly 3.5 hours and a warm ischemia time of 48 minutes. He had 5 PRBCs and 2 FFP and 1 STPC during surgery. He was extubated on day 1. And this is the chart of his post-operative liver function tests and kidney function. So from day 0 to day 4, he basically did okay. His bilirubin slowly fell from 7.8 to about 4. And AST/ALT fell as is usual. And his creatinine went up slightly from 1.1 to 1.3. And at this point, day 5, 6 onwards, his bilirubin started climbing. And over the next week or so, it went from 6 to 15. OTPT did not budge. Alkaline phosphatase was kind of normal. GGT was about 2 to 3 times normal. And the creatinine stayed at 1.3. So tell us, Dinesh, what do you think your next steps will be? And I'm going to ask this question to 3 people. Disregard the initials, because anyway. So Dinesh, what do you think the next step should be?
Yeah. So this gentleman has features of small for size syndrome because his GRWR has been low, and because he has high BMI as well as high portal pressure post reperfusion. So he has a high portal flow and pressure into a smaller graft. So that's why his enzymes are a bit higher. In terms of the bilirubin is higher, and the INR is also going up. So this is small for size. So basically, we need to make sure the graft recovers, without any sort of further hit. So obviously, we need to first reduce the inflow. What we generally do is give them some terlipressin and make sure they're on good antibiotics and make sure they don't develop any rejection on top of this. And so this is the steps we follow. And if things are still worsening, then, as what Neeraj had a talk about, plasma exchange will be something to consider. But that's not the immediate one, but we just have to wait to see how he goes for the next few days.
So for the benefit of our younger colleagues, maybe Sanjeev, you could add something to what Dinesh has already said. What else would you like to do if it was a MCH exam or a fellowship exam and they said steps 1, 2, 3, 4, what would you do? So what else would you like to do?
I think we have to just prevent further hit, and that will be upgrading all the antibiotics. I would want antifungals and full upgradation of this patient, and then optimize him as much as possible and keep him ventilated if he's,
he's been extubated. He's
been extubated.
Yeah.
Okay. So I think the plasmapheresis is the next step. If we have to keep the bilirubin down. And there's some role of oxyuris, maybe, to keep the bilirubin down. All cartridges which we can use just for the sake.
Oxyuris, I'm not aware of the literature that says that it helps in post-liver transplant cholestasis, but anyway, Amit, do you want to say something? And then we'll finally ask the expert of plasmapheresis, Neeraj.
The most likely scenario which is developing is small for size. The other things look okay. By definition, the bilirubin is less than 10 at day 7, day 8. But still, so my initial impression would be small for size, which is developing. Patient is relatively stable. The things which I would keep in mind is prevention of infection. So if there is a scope to upgrade antibiotic, I would do that. If there is any collection apart from which has been drained by the drain, I would probably insert a PCD if there is a collection, and I would focus on nutrition. So these are the three things. And right now, I would keep some form of plasmapheresis in mind, but not opt for it right now. Bilirubin is 8, 10, 12, and patient is clinically, give it some time, and maybe some patients might not need it. So my focus would be on prevention of infection and good nutrition.
Neeraj, you come in. Actually, you come in first, but then I thought, let's see what the surgeons have to say.
I think the other thing, I mean, we are I agree that it's probably heading towards small for size, but I would still probably do imaging, rule out biliary, maybe do a liver biopsy. I think we should do those, that's stepwise before we really come to the conclusion that this is small for size syndrome. And of course, when we have ruled out everything else, yes, I agree, probably conservative for the moment, and plasma exchange would be the next step.
So obviously, because we are in a session of early graft dysfunction, so everybody has a huge hint to start with. But I completely agree with Neeraj that you have to do the first things first. So you do an ultrasound Doppler, you make sure all your vessels are good, you make sure there is no dilatation. Some would argue that within the first 10 days, you may not even have dilatation. But still, you have to perhaps do, I would even go to the extent of doing an MRCP. I would obviously send cultures and procalcitonin and whatever else you'd like to do, chest X-ray, urine routine, etc., to rule out infection. And once you've done that, I would then, move on to a liver biopsy. So I kind of agree with everything that you guys have said. Doppler was okay. Sepsis, as you know, the TLC has been okay in the table that you just saw. Procalcitonin was okay. CT abdomen did not show any collection, Amit. And the viral serology was negative. MRCP did not show a stricture. CMV, a bit early for that, but we did it on day 11 or 12, and that was negative. And then we did a liver biopsy. And just to say that, yes, there was a drain output of about 1,200 mils a day, which was benign in terms of cell count. So next question. Manav's not there. So do you want to tell us, Neeraj, what do you think the biopsy will show?
I think biopsy will probably show, a cholestatic liver. That's what it probably will show. And I don't think, obviously there is no rejection and no, so maybe, some inflammation, some evidence of infection, some neutrophilic inflammation, but predominantly a cholestatic pattern.
Right.
There can be some element of, sorry, I just add.
So Dinesh, yes, I was going to come to you. So what do you think, apart from what he has said, anything else?
First thing is obviously cholestasis, but because the shear flow, there can be some hemorrhage, and sometimes there can be necrosis if the small for size is quite severe in terms of.
So what sort of hemorrhage are we looking at? Where?
It usually it will be around the portal tract. That's what.
In a small for size syndrome.
Yeah, I think so. Yeah, portal tract hemorrhage.
Okay, so let's see how right the hepatologists are. So there were 8 portal tracts. There was moderate, mixed, predominantly neutrophilic infiltrate, mild ductular proliferation. There was no ductulitis or endothelialitis. There was cholestasis, feathery degeneration, and extensive bile plaques. So kind of what you guys have just said, but there was no hemorrhage anywhere.
Mitotic figures are also visible sometimes in SFS. If many mitotic figures are there, it supports SFS.
Yes, absolutely agree with that, but we did not find any. So now you have the picture of all the investigations. Now, I think in order, Sonal, you haven't spoken, so what would you do?
Broadly speaking, agree with what Neeraj just said. A stepwise approach is more important here. We have ruled out, most of the other potential causes, and we're sort of down to small for size. So small for size, typically what we've seen is that, there is some amount of liver growth, and we do see some improvement. There is an improvement potential up to 2 weeks or so. So certainly, conservative treatment is the first thing that comes to mind. That is, make sure that the patient is adequately filled, intravascular volume is maintained in terms of drain output. Make sure that the patient is free of sepsis. Nutrition is a good point that Amit had made that often gets neglected. That's something that we should actually take care of. The one point I'd like to make is probably about the role of cross-sectional imaging as well, because we have found in certain situations that this is either set off by, if you have anterior sectoral penetration because of loss of, say, the graft, the middle hepatic vein neograft, sometimes that's a little difficult to make out on a Doppler. And if one finds a sudden increase in ascitic drainage, then that's probably worth checking by cross-sectional imaging as well. So, at this point, what I would say is that we should just sort of manage conservatively, fill up the patient, manage sepsis.
So how long will you continue? How long will you continue conservative management? He's already on day 12 and his bilirubin is 15. He's otherwise stable. What's your cutoff? What's your endpoint? You're saying conservative management. We all agree. Where are you going to start doing something?
So, at this point, so normally we have seen small for size, pure small for size improve within the 2nd to 3rd week. We normally see numbers turn around after day 15 to day 21. So that's the time when I would expect some improvement. If we did not see a significant improvement at that time, that would be the point where we would look at, perhaps intervention of some sort.
So I take your point. You would do a cross-sectional imaging, make sure there's no outflow obstruction, and you would conserve him with all the good stuff for 3 weeks. Okay. Yeah. Now, Sanjeev, anything else different from what Sonal said?
I think I would look at the phosphate and all, give more supplements, add phos, magnesium, potassium, all those things should be optimized, and that is one. And secondly, we have to do all the cultures, and but basically nutrition is what we are looking at. And I would do a plasmapheresis if the INR is going.
At what point?
I think we are slowly approaching it. I would go for, if it goes beyond 20, I would try to keep it below around somewhere around 10, 12. So beyond 20 for sure, 15 to 20, there is plus minus. So I would rather do a plasmapheresis.
Interesting set of guidelines developing now, because Sonal will do it at 3 weeks. You will do it at bilirubin of 20. Okay. And you made your point about phosphates for the uninitiated. Basically, it's been shown that in FLR after hepatectomy and donor or otherwise, in inadequate FLR, low phosphates have a worse outcome. That's not being shown very clearly in the post-liver transplant situation, post-living donor liver transplant situation, but we take your point. Let's move on to Dinesh. What would you do? And
in addition to that, we should try and reduce the portal pressure, probably add some beta blocker and some diuretics without compromising on the kidney. Make sure we maintain adequate tacrolimus levels, not too low, not too high at this stage, so that he doesn't go into rejection. And yes, so that is very important.
So would you consider plasmapheresis and when?
Yes, so plasmapheresis, the bilirubin continues to go up. So our threshold is 10 and it's increasing. Definitely we'll consider plasmapheresis in this setting.
So you want to do plasmapheresis now.
Yes.
So that's 3 opinions. Very nice. And Neeraj, what do you think?
Yeah, so I think if the trend is towards worsening, and then I think, yes, probably, although in my talk I just showed that we don't really have great data on plasma exchange either. But since there's nothing else to do, if the bilirubin and INR are increasing, I would do it now rather than before, organ failure sets in and patient becomes septic.
Amit, Neeraj and Dinesh want to do it now. What about you?
I would slightly hold on because patient is clinically okay. I would just not go by numbers. I would continue with the earlier thing which I said about nutrition and sepsis. And if the patient is holding on, maybe 2 weeks, we can hold on, and maybe the beginning of 3rd week, if the bilirubin is rising up, the INR is relatively stable. It's been 1.3 right through. So maybe for this, as I said last time, we'll keep it in mind, but will not go by numbers. If the patient is looking okay, I would hold on because there are problems with plasmapheresis. And as Neeraj said, we did not have a great result with the plasmapheresis. So I would just hold on maybe another 3, 4, 5 days. And if there is any doubt, maybe go for it. The only thing different from Dinesh is I would not want to add any thing to reduce the portal pressure because we've already made the shunt. And especially if there is any damage, it's already been 2 weeks. So reducing the pressure might not help now. Plus we already have a shunt. So I would not go into extra medicine.
So that's very interesting. Okay, so let's tell you what we actually did. We did plasmapheresis. We did therapeutic plasma exchange. And we started this on day 13. And then as you see, we did 5 sessions. And this is what happened to the bilirubin. And then after the 5th session, on POD 18, 19 onwards, he showed a good recovery. So the bilirubin decreased nicely, and the INR also interestingly came down, but then I guess you're giving plasma, so it comes down anyway. But then, as you can see, a week after the plasma therapy finished, the INR continued to plummet. So obviously the graft function got better. Sanjeev, can you just mute, please? So the INR continued to improve as well. So this is what happened to the patient. The platelets were kind of continuously around the 40-50 mark. The bilirubin fell down to 6. AST, ALT were reasonable to about 2.5 times normal. SAP and GGT were elevated, but that was just because of graft dysfunction. And creatinine was constant around 1 to 1.3. So this patient actually did well. Guys, can you please mute yourselves if you're talking elsewhere? So, so this patient did well, and it's been like, obviously it was in 2017, he's still doing fine 5 years later. So now let's have another scenario. If ascites increases, as you know, this patient had a liter of drainage on day 10, 12, 1.2 liters. So if ascites increases on day 8 to 12, with the Doppler showing triphasic RHV, but absence of MHV flow. You know the scenario that Sonal alluded to briefly. What would you do, Amit?
So if it is within a week, MHV is closed and the GRWR is borderline, we have had cases where we have went in and declotted the MHV and it has worked. But if it is beyond 2nd week or maybe more than 10 days and we have a margin on GRWR, we would just leave it like that.
So this particular case, you would go and declot it, or perhaps ask your IR colleagues to declot it, right?
In this case, I would be on a high thing to declot it because already the GRWR is very low and we would want to drain as much as the liver is possible. So even if it is day 10 or 12, it's better to declot in this situation. And IR is a better option, as you said.
Sonal, you agree?
Yes, I would err towards interventional radiology because, as Amit said, there's probably merit in going in the first week if you have an early clotting. In the second week, it might be related to flow as well as a technical problem. So I think that it's probably getting your IR guys in the loop is probably great if we can actually get declotting done.
Great. Okay. So now let's have another scenario. Ultrasound of the abdomen day 8 shows no IHBR. Serum alkaline phosphatase and GGT are in the 1000-1200 range. MRCP shows mildly dilated central ducts and intrahepatic biliary radicals being seen up to the periphery. And there is absence of perianastomotic continuity for about 1 centimeter. Sanjeev, what would you do?
We are in day 8, is it?
Yes, this is day 8.
Day 8.
Same patient. Because obviously this patient started showing bilirubin rising on day 6.
I think there is a serious issue with the anastomosis, biliary anastomosis. I'll recheck the MRCP if it definitely showing there is some absence of anastomotic continuity. I will go in maybe.
Right. So on day 8, you would write to. So let's say this is biliary stricture or narrowing. You would go in surgically. Right?
Yeah.
Right. Amit?
So the suspicion in such a situation would be very high for a partial narrowing of biliary stricture. If I'm not forced to go no sepsis, I would want to hold on at day 8, not go in for ERCP so early. But if there is a evidence of sepsis with cholangitis, I think then surgically going in the first week is a better option. But if we can avoid going in surgically or IR for at least 2 weeks, it will be fine. So if there is no cholangitis, I would hold on, but definitely biliary problem is on the cards.
What do you think, Dinesh?
First thing, I would like to make sure the hepatic artery, everything is okay, vascular. Obviously, there is some sort of central duct dilatation.
In this particular scenario, yes, it's okay.
Yeah, perianastomotic continuity is missing. Probably I wouldn't intervene at this stage. Make sure the bilirubin is okay. Only if the bilirubin is going up, there is associated bile leak. Probably I would intervene.
This is the same patient, but this is the scenario. Same patient. This scenario, yes.
Same patient, probably is going to develop sepsis with small fur size. Probably it's better to do a ERCP and put a stent. 7 French stent across the anastomotic stricture.
So, Amit has conveyed some reservation about going in with ERCP on day 7, 8. And I must confess that's what we practice in this hospital because we are worried about early intervention because sometimes what happens is the micro leaks get converted to big leaks and they can develop cholangitis. So what we normally do is we hold off. If there is a leak, we drain the leak, but we just hold off interventions for a while. You are not worried?
Definitely. I mean, but given the small fur size and if he's going to develop, bilirubin is sort of not settling down. We just have to make sure there are no other insult to the regenerating liver. And we don't want this biliary issues to hamper the liver regeneration, particularly if they develop cholangitis. Probably I'll just wait for a couple of days. And if things are not settling, maybe you should think about intervention.
So now let's move on to the real question. Is there a role for therapeutic plasma exchange if there's EAD after LDLT, like in this situation? And it seems that all 5 of you have already given us the answer, right? Is anybody does anybody differ? Everybody said they'll do it.
No, I did not, sir. I'm sorry.
Oh, you did not say. Okay, fine.
Yeah.
So you will not do
it. I'm not sold on it to be honest, because the data that's been presented by Neeraj and what's also been published so far, it's been unmatched controls with a fairly high rate of failure. So I'm not completely convinced that this is not spontaneous liver recovery as opposed to the benefit of exchange.
That's very interesting because yes, I totally agree that there is huge controversy about that, and there is no clear evidence that it actually helps. Of course, the Korean group published this 5 years ago, in which they showed that there was a survival difference about 30%, from 50 to 80% among patients if they actually had TPE versus if they did not have TPE in the same EAD situation. But no other centers actually published a large number of cases showing the same thing. So it's up there in the air. We're not sure yet. So Neeraj and Dinesh wanted to do plasma exchange or TPE. Amit, you said you'll wait for some time, but would you like to do it?
Yeah, I think, see, the thing is, it's easy to say that there is no benefit, but in this situation, there is no clear-cut biliary reason, biopsy is okay, there is no sepsis, and you can't let the patient go from bad to worse, you have to intervene. And in occasional, some patients, it can help because, so there is not hard evidence, but instead of waiting and not doing anything, and then you reach a point where you're not able to do it, I would do it, but obviously at a slightly later date as was done in the case.
Okay, so now Sanjeev, what is your view? Remind us. Sorry, you're on mute, I think. Sanjeev Rodgi, you're on mute. You're on mute.
Oh, sorry. So what I was saying was that beyond 20, so I would definitely do. At this point, when the bilirubin is 15 and patient is deteriorating, I will err towards doing a plasmapheresis rather than not doing.
So Sonal, despite lack of clear scientific evidence, and I know you're a scientist of the highest order, and I'm saying it like seriously, 4 out of the 5 panelists feel that we should go ahead and do it.
If I may, in this particular case, apart from cholestasis, what is the other indication that one would consider? Because Amit has already pointed out that this patient was not coagulopathic. The INR was all well within normal. All we really were facing with, we were dealing with was a rising bilirubin and a slightly high drainage, according to the time. So at this point, I can't see the urgency of jumping into plasma exchange at this point.
So that's a very important point. So what you're saying is, unless pushed with the back against the wall, you would hold it. There is a counter view which would say that if you delay it too much, it's not going to be useful. So obviously there is controversy.
Yes.
So now the obvious question, which is waiting to be asked, is should there be a multi-center randomized control trial for therapeutic plasma exchange and early allograft dysfunction? Do you guys agree, disagree? Sanjeev?
Yes, definitely.
Neeraj? You're on mute.
Yeah, obviously we need more data, and a multi-center trial would be the right thing, but it's probably not easy to do a randomized trial in these group of patients.
So Amit, you agree?
All the talks today and generally also we have discussed, we really need data and should not be in a situation like us and Susan saying clearly no benefit versus some benefit. So we have trial, but problem is how do we have it? The patients are so heterogeneous. The hospitals are heterogeneous. The protocols differ. So we obviously everybody would want it, but it will be very difficult. But yeah, it should be done so that we have some answers.
Dinesh and Sonal. Yeah.
I would agree with Neeraj because yes, it definitely needs to be done. But doing it as an RCT may be difficult because how on what basis we can randomize and how do we if we have to, that's going to be the technical glitch if these are trials. But
so Sonal, you want data, or you're convinced that it's not?
I mean, I completely agree that it would be impossible to randomize this kind of cohort. What would be very interesting to do or possible to do would be a matched control cohort, and that would be possible within centers, like a center like ours that sort of leans away from, say, plasma exchange versus a center that prefers to do it. If we can compare data, of comparable patients and see whether there's a difference in outcome, then we can at least say that there is, benefit to, there may be at least the first baby step towards getting some data. Probably not an RCT, probably, but a matched control cohort compared between centers would probably be the way forward.
Why not an RCT? If there is zero evidence and agreement on an issue, whether you should leave them alone or take them through a plasmapheresis, why not an RCT?
No, I mean, RCT, in the ideal world, yes. I think it's probably primarily to do with the difficulties in trial design, as have been alluded to. Matching patients and stratifying, comparable subgroups is probably the biggest challenge of an RCT of this kind. It's a practical problem. It's not because
I totally see your point. Neeraj, given the choice and option, how would you just tell us quickly? You and perhaps Sonal should tell us how you would design such a trial, specifically related to inclusion, exclusion, and timing and number of sessions. And then we'll go on for some questions from the audience.
Yeah, so I think, like we all said, the randomized trial would be ideal, but probably very difficult. And I think what Sonal suggested, maybe a matched cohort might be more practical. I think exclusion criteria. Exclusion criteria obviously has, you have to, first of all, you have to have a standard definition for EGD. I think that's another problem with a lot of trials which have been done, that there's no standard, bilirubin cutoff or standard definition. So I think we have to agree on one standard definition, obviously rule out all other causes of graft dysfunction at that point. And yes, our RCT would be ideal. Yeah.
And what about timing, Dinesh? Sorry, Sonal. I was asking Sonal.
Yeah.
What do you think the timing should be? Like 2 weeks? Yeah. Should it depend on bilirubin or what?
Okay, so basically how I would design this study would be a matched control cohort comparing centers that did plasma exchange versus centers that did not. We would probably include people with a standard definition of early allograft dysfunction after excluding the usual causes of dysfunction such as arterial vascular problems, biliary problems, and so on and so forth. The ideal time to do this probably would be after day 8 to at least after the first post-operative week, because it would tell us whether the trend would become sort of established by that time. We would know whether there was a problem or not. The study would probably be done as an intention to treat. If we are looking at a difference of 30%, then we would probably be okay randomizing or comparing just 50 people, because we'll be able to do that with sufficient power, because we are looking at a very big difference in impact, 30%.
So, the whole story is not to do it too late and not to do it too early. And that's the question. So, I mean, there is, if you read the paper by Sungyu Lee's group, who published, I think about 80 odd patients, where some of them, I think 2/3 of them had it and 1/3 of them didn't have it, TPE, they said that there is data to show that if the bilirubin is more than 24, these guys are not going to do well anyway. So you're too late if you're TPing them after a bilirubin rise of more than 24, wherever this figure came from. I mean, the point is that, if it's too late, then it may be not much use.
So maybe after,
if you wait for too long, you may have sepsis, renal dysfunction, etc. supervene. So, you can't wait too long. On the other hand, people would argue that if you do it too early, then maybe they would have recovered anyway. So it's a difficult question, but I would do it in the second week at some point, maybe 10 days or 15 days or 14 days with a bilirubin value of 15 or 18, but certainly not more than 20, because then you're probably too late. Okay, let's. That's been a very interesting discussion, and it just goes to show that EAD is still a very controversial topic, and people kind of do some things which are very similar and some things which are different. Now, I'd be very happy to take questions. The panel and I would be very happy to take questions from the audience. Do we have any in the chat? I'll stop sharing and let's look at chat messages.
There's nothing, I think. Yeah.
Okay, there's nothing. Okay, then I'll save the organizers 2 minutes. And thank you very much, all the panelists, for joining in. And thank you for the, thank you, audience, for listening in, those who were logged in. Over to you, Neeraj.
Yeah. Thank you, Dr. Soin, and thank you, everyone on the panel. I think we'll move on to the next session now, which is post-transplant sepsis. We've already had one of the talks by Dr. Deepa Govil, so we'll continue with the rest of the session. Can I invite the chairpersons for this session, Dr. Charles Panicle, who's a transplant hepatologist at Aster Medicity, Kochi, Dr. Sanjeev Rohatgi, Dr. Anand Vijay, and Dr. Kesar Raja. Kesar, are you there?
Yeah, Neeraj, can you hear me? I'm there.
Yeah. Okay, so the first talk, we have one talk and one case-based discussion in this session. And the talk is on managing renal dysfunction in ICU after liver transplantation. And this talk will be given by a good friend of mine, Sanjay Satpathy, who's medical director, liver transplant at North Shore. Is that right, Sanjay? In New York. Sanjay, over to you.
All right, Neeraj, thank you so much. And thank you. I would like to thank you, the organizers, especially the Liver Transplant Society of India, for this opportunity. Let me share my screen. Give me a moment. All right. So, as Neeraj said, I'm here at Northwell Health, which is a large, one of the largest network of hospitals in New York City. I am based in the Northwell University Hospital. I'm currently the division chief and also the medical director for the liver transplant program. So I was given this, the assignment that I had is to talk about managing renal dysfunction in ICU after liver transplantation. But I would say the management starts before their transplantation, because the window of opportunity to make any difference actually starts before the transplant. So my talk will overlap between starting before the transplant, intraoperative and postoperative. So the questions that we need to answer today is threefold. First, who will recover renal function? Who will develop new acute kidney injury? And how to prevent new AKI and future CKD? I think these are the key questions that we need to understand. And it depends on the recipient factors, the donor factors, and the intraoperative factors. Now, who will recover renal function after transplant? This will depend on, let's say, talk about the recipient factors, the health of the kidney and the health of the liver. These are two important factors that determine the outcomes. Determining the health of the kidney before the transplant is a little arduous task, especially because of the coagulopathy, the risk from kidney biopsy, and there is no gold standard biomarkers that can predict who will recover and whether the patient has HRS versus ATN, and this is somewhat way always have a controversy. And there is a very short window of opportunity prior to liver transplantation. So simply, the patients are too sick as well, and management primarily depends on the clinical judgment most of the time. We need to know that chronic kidney disease occurs after acute kidney injury in patients with decompensated cirrhosis. 25% of the patients with acute kidney injury actually develop chronic kidney disease versus 1% of those without. So with that in mind, we know that a proportion of these patients, they're going into the transplant, are potentially going to develop chronic kidney disease and may not recover their renal function. And the rate of the chronic kidney disease after one episode of acute kidney injury is as high as 8 per 100 patient years. And the risk for chronic kidney disease is higher with the repeated acute kidney injuries. And the central predisposing factor for the acute kidney injury is a predisposing CKD as well. And patients with CKD are 10 times higher risk of AKI compared to those without. So these we need to keep in mind when we talk about managing these patients after the liver transplantations. Now, looking into the AKI recovery pattern and the subsequent risk of chronic kidney disease, this particular paper that looked into this, and what we can see that the AKI recovery patterns, when they compare patients with no AKI, and the recovery occurs within the 2 days versus 3 to 10 days versus they're still elevated at 10 days, the risk of developing, irrespective of their stage of CKD, stage 1, stage 2, or stage 3 AKI, there is an incremental risk of developing chronic kidney disease subsequently at within 1 year after their first episodes or the episode that we're talking about, the index episode. So the impact of the pre-liver transplant AKI and the post-transplant mortality beyond 1 year is presented in this particular slide. As we can notice, AKI that did not require dialysis fared similar to those without AKI. But patients with severe AKI that require dialysis during the pre-LT period have a very inferior survival. What are the risk factors for early acute renal failure and late acute renal failure after liver transplantation? One study, actually a little older study, that looked into this, and they found few variables. If the patient's serum albumin is less than 3.2, preoperative AKI, and the treatment with dopamine for more than 6 days, and graft dysfunctions, those are the factors they found are more likely to predict early ARF. And the late ARF, if patient underwent a surgical reoperations or if there is bacterial infection in these patients. Impact of post-reperfusion syndrome and the hepatic ischemia reperfusion injury also had an impact on the development of AKI. Now you look into the mean arterial pressure. The decrease in the mean arterial pressure after the reperfusion and the severity of acute kidney injury is presented on the left side here, and the hepatic ischemia reperfusion injury on the right side. So certainly IRI plays a big, is quite correlating with the development of AKI as well. Also, we need to be cognizant of the underlying reason for the patient undergoing a transplant, particularly NAFLD. There are multitude of studies showing a link to development of chronic kidney disease. Now, we did a study which we published in liver transplantation, and what we have shown that NAS patients with severe renal dysfunction during their pre-LT period probably need special attention during their post-LT period to prevent any early decline in renal function. The reason for that is you can see here. We divided the group of patients before their transplant into 3 groups. Those who have severe AKI, that is GFR less than 30, those who have more than 30, and those who underwent a combined liver and kidney transplantations. Now, what we saw that the patients who had the GFR less than 30 and did not underwent a simultaneous liver kidney transplantation had their kidney transplant-free survival after transplant is significantly lower. But if I just look into their overall survival, their SLK and those who had the eGFR less than 30 had similar survival, and they're lower than those who had high GFR that is more than 30. So, but the kidney transplant-free survival is lower in those patients who had a low GFR without receiving an SLK. Now, the next question is, who will recover renal function after transplant? Now, this is a difficult question always, and if you look into, and we go to the basics of it, the AKI, we need to find out what's the etiology. Now, the intrinsic renal disease, it could be tubular damage related to either ischemia or nephrotoxic injury, glomerular damage, the interstitial damage, or vascular damage. Now, how to differentiate this? And particularly that we are concerned about these 2 groups, pre-renal versus intrinsic renal. And the best way to diagnose this is by a biopsy, but it is not easy because there is coagulopathy before their transplantation, and also after transplant as well. It is always the coagulopathy and early transplants is always a risk to do a biopsy in this group of patients. So does biomarker help us guide this? Whenever there is an AKI, so we have different biomarkers that has been tested. Now, tubular proteins, they are released due to cell damage. There are markers released by recruited inflammatory cells, and there are diminished tubular reabsorption of plasma proteins, tubular protein that are upregulated by injury, and induction of cell cycle arrest. So there are various biomarkers that has been investigated. Now, looking into these biomarkers, and if you look into the different spectrum of the AKI, let's talk about the baseline kidney function. Let's say a patient has a chronic kidney disease. Biomarkers for underlying chronic kidney disease or markers of fibrosis will always be elevated. But patient who has pre-renal failure versus HRS, and we're looking at the ATN, you are looking into two groups of biomarkers. The functional damage, you're measuring with the serum creatinine or serum cystatin, and these levels are severely increased in ATN. Ultimately, in HRS patient, they do also start increasing, right? But in the structural damage protein, the markers of tubular dysfunction and intrarenal inflammation, those also towards when the HRS goes more severe, you also start seeing their numbers being higher. But in ATN, they're increased significantly. Now, this has helped in studies to identify patients who are ATN who may more than likely not going to recover. So this biomarker, particularly NGAL, has been very well studied, and a cutoff level of more than 194 has been useful to define who is going to progress to ATN from HRS. And those patients potentially may not recover well even after transplantation, and most likely will benefit with an SLK. Also, the MEL score. There has been clear correlation of the MEL score severity and the development of AKI. And this is to just mention about that, the AKI severity and the development of severity of AKI here. Now, I want to point that out just because the recovery patterns that particularly patients with acute and chronic liver failure after liver transplantations. And you can see this particular study that we published. Here, we looked into patients with ACLF or acute and chronic liver failure using EASL-CLIP software definitions. Patients with a non-ACLF group is the left side. This is individual EGFR, their spaghetti plot that we are showing here with the median values. And the acute and ACLF with high GFR group at the baseline, and ACLF with the low GFR. The low GFR is less than 30 and more than 30. That's the cutoff we use. And what we see here, the slopes of these patients' GFR are different in all the three groups up to the 3 months. And after the 3 months, that's how we call it the reset point, where you can now see that there is significant recovery in those patients with ACLF with a high GFR group, and ACLF with a low GFR group. Also, they significantly recovered, and they almost have a similar pattern after their after 3 months. So these patients with ACLF with AKI, they will recover significantly at you are expecting of by 3 months of these patients. The probability of kidney composite outcome-free survival, we looked into this paper, and we have compared these three groups, and you can see the ACLF with a low GFR group, the composite outcome, which we define as need for RRT, or the GFR is below 15, that is a stage 5 CKD. So those outcomes we looked into it, and what we see that the group with the ACL with a low GFR has the worse kidney composite outcome-free survival as compared to those who had a high GFR. They also has a lower kidney composite outcome-free survival compared to those who has no ACLF. So ACLF does impact their outcomes as well in terms of their kidney recovery. Outcomes of hepatorenal syndrome type 1 that is treated with the liver transplantation has been quite favorable, but a certain group of patients still the survival benefit in this group of patients has been shown to be poor as compared to those without. This is the renal recovery based on ATN versus HRS, and patients, as you can see, the HRS has a significantly better recovery as compared to those who has ATN. Now, renal dysfunction after liver transplant, what's the effect of donor type? Now, this is three groups of patients that's been compared. There's a DCD, and this is with a donation after brain death, and the living donor liver transplantations. The DCD patients, this particular group of patients, they have a poor recovery of renal function after their transplantation or their progression to chronic kidney disease. Now, intraoperative factors are also important that impacts the outcome following the liver transplantations. And this particular study that looked into the various factors, they looked into the anesthesia time, the surgical time, crystalloid infusion, colloid infusion, hypotension, blood loss, blood transfusion, and blood components that was transfused. And the three things that actually stood out is the hypotension that is mapped below 70, and the blood loss about in the non-ARF group as much higher, and the blood transfusion requirement was much higher in the groups with those who received ARF. Now, the intraoperative variables also has been, again, looking into this intraoperative hemodynamic variable that were collected at the following 8 time points was looked into, like after anesthesia induction, 1 hour after anesthesia induction, 10 minutes after beginning of the anhepatic phase, 5 minutes before, and after the graft reperfusion, 20 minutes after reperfusion, and then 5 minutes after completion of the biliary constructions. And what again is important was the central venous pressure. The central venous pressures, CVP has been in the lower in those who actually had an AKI, and the versus those who didn't have AKI, and also the right ventricular end diastolic pressure was lower in those who become those who develop AKI after their transplantation. Can we do something about it? There is one study that looked by using octreotide on the urine output during OLT and early postoperative renal function. This was a randomized double-blind placebo-controlled trial, and although they didn't find any significant difference in overall outcome, they found by using octreotide modulating modulating the hemodynamics, they were able to increase the urine output in these patients, those who received octreotide. This is a control group of 39 patients and octreotide group of 40 patients. And the urine output in the hepatectomy phase, urine output in the anhepatic phase, and urine output in the neo-hepatic phase, there was a significant improvement in those with the octreotide group. Again, this is only a small study, and I do not think based on this we can make a conclusion, but certainly makes the point that potentially modulation potentially can be done during the intrahepatic phase to help improve the outcome of these patients. Now, temporary intraoperative portocaval shunts in a piggyback liver transplantation also has been shown to reduce the risk of renal dysfunction. This is possibly related to the improved central venous filling and thus enhanced renal perfusion. Venovenous bypass is also associated with a lower incidence of AKI after liver transplant with compromised pre-transplant renal function. And this has been very clearly shown here. Patients with normal pre-transplant renal function, patients with the compromised pre-transplant renal function, and those who receive venovenous bypass has a significantly, almost close to 13% improvement, 13% lower risk of developing AKI. This is a study actually looking into conventional versus piggyback liver function, piggyback transplantation, and they looked at the liver function and AKI, and they found that the AKI occurred equally in both these groups. And transient renal replacement therapy was recorded 22.6% and 22.4% comparing the piggyback and the CR technique. So this is a study where included 378 transplantations, patients, of which 46.8% were performed as piggyback and 201 with a conventional technique. The conventional piggyback, the graft, and the patient survival, they looked into it. They found both liver implantation techniques are equal in terms of kidney function and overall complications following liver transplantations. And their long-term outcomes were also favorable. Now, optimal timing of initiating CRRT in patients with AKI after liver transplantation has been looked into this study. And again, this study favors that early initiation of CRRT after liver transplantation favors a better outcome of the recovery of AKI. And you can see here the factors that actually predicted the worst outcome was the severe infection, particularly, and the length of hospital stay in those who received early versus those who late. The early initiation of CRRT had a favorable outcome. The study actually looked into the predictors of renal function recovery among patients undergoing renal replacement therapy following liver transplantations. And I just again point out here what are the things they looked into. They found that the patients who had a fulminant hepatic failure, they have a most likely recovery of AKI. And the other 2 points they looked was patients with pre-transplant hypertension and patients who received intermittent hemodialysis. They had if the patient didn't receive intermittent hemodialysis, they have increased risk of having AKI non-recovery after their transplantation. Modifying the immunosuppression is also important, especially those who are having AKI, which is, of course, in most centers we do practice this way, delaying starting CM after the transplantation and modifying their immunosuppression, particularly lower program and using cells set early on this early on their post-transplant time during recovery also helps. There are multiple studies in the later phase after the patients recover from the ICU from the AKI. Modulating their immunosuppression helps prevent these patients potentially not progressing to CKD, and there are various studies as outlined in this chart. So, another important measures that can be done potentially is using basiliximab induction and delaying the calcineurin inhibitor initiation in liver transplant recipients with renal insufficiency. And this earlier study has shown potential low risk of developing AKI when they looked into the day 7, day 30, day 60, 90, or 120 days. They found by using early induction, patients who had AKI, they have almost similar survival as well as the recovery of the similar creatinine levels over time. We also need to be cognizant of the etiology of the patient's liver disease, and those may potentially impact that is going to be in the pre-transplant period. In the peri-transplant period, obviously we talked about the intraoperative hemodynamics, the blood loss and hypertension, and ischemic and hypovolemic AKI, and the ischemic reperforating injury that might impact their recovery patterns. And post-transplant, we obviously talked about calcineurin inhibitor induced vasoconstriction causing post-operative renal dysfunction and the long-term CNI toxicity. And this needs to be modulated to have a better outcome with these patients. Finally, I'll summarize. Pre-liver transplant renal dysfunction remains the leading cause of post-transplant renal dysfunction and mortality. The development of AKI after liver transplantation is influenced by a combination of recipient, graft, and perioperative factors. Novel biomarkers might be helpful to identify patients at risk and guide therapeutic interventions. Strategies to minimize perioperative hemodynamic alterations could help in reducing AKI following liver transplantation. Early initiation of CRRT could be a potential strategy in patients with severe AKI, as opposed to intermittent hemodialysis. Tacrolimus elimination strategy might help in reducing the decline in lung function. And currently, there is no evidence-based recommendation that can be made to prevent or treat AKI after transplantation. But these are these findings that I summarized that potentially would help to have a better outcome. Thank you very much for your attention.
Thank you, Sanjay, for a very exhaustive talk on managing renal dysfunction after liver transplantation. I think we're running quite late, so we'll probably, any quick comment from the chairpersons or questions? Okay, so I think we'll move on. Thanks. Thanks once again, Sanjay.
No problem.
So the next session is a case-based panel discussion on post-transplant sepsis. And to moderate this, I invite Dr. Srinivas Reddy, who's Chief Transplant Surgeon at Global Hospitals in Chennai. And we have a very distinguished panel for this case. Dr. Subramaniam Swaminathan, who's Director of Infectious Diseases, again at Global Hospital. And when you see him, you would probably realize you would have seen him on TV many times during the COVID months. He was a regular feature on television. Dr. Prashant Bhangi, Senior Transplant Surgeon at Medanta Hospital. Dr. Akash Shukla, Professor and Head, KEM Hospital. Dr. Namish Mehta, Senior Consultant Transplant Surgeon at Sir Gangaram Hospital. And Dr. Zubair Mohammed, anesthesiologist at Amrita Institute. So Srinivas, I guess take over, please.
Am I audible now?
Yeah.
Okay. Thank you, Neeraj. And we'll start the session. I hope all the panelists are there online.
Yeah, they are there. Yeah.
Okay. So I'm going to share my screen. Okay, thank you. So I think post-transplant sepsis is something that all of us are worried about in our patients. And that's probably one of the main reasons why patients need ICU care, prolonged ICU care in the post-operative period. There are lots of reasons why liver transplant recipients are at high risk of infections, whether it's cirrhosis-related immune dysfunction, multiple invasive procedures, multiple hospital admissions, and malnutrition and sarcopenia associated with cirrhosis. So we're going to start off with one case. Just going to go through the patient with from the preoperative period through the operative and postoperative periods, and we'll have it as a discussion. So it will be a bit of theory and a bit of practical experience of all the panelists. I think somebody's microphone is. Thank you. So start off. So the patient is a 35-year-old lady. She's a patient with autoimmune liver disease, diagnosed as cirrhotic in 2019, and has been on azathioprine since then, and it's been reasonably stable. But recently, she had acute decompensation with jaundice, gross ascites, and coagulopathy. She was admitted for stabilization and for transplant evaluation, and at admission, her bilirubin was 34 milligrams, INR was 2.3, and serum creatinine was 1.2. While she was admitted, 48 hours later into the admission, she had an episode of fever and some hypotension. Blood pressure was around 94 by 45 millimeters mercury. So this is a typical patient, sick patient who comes in with ACLF, and we are looking at trying to evaluate the patient and trying to get her to a transplant as soon as possible, actually. Diagnosing sepsis in the preoperative patient. I think first, let's go through some definitions. Dr. Subra is there?
Yeah.
And Dr. Subra, can you, I think in the setting of a cirrhotic patient, what is the current definition of sepsis, severe sepsis septic shock that's being used now? Can you?
It's a bit of a controversy, actually speaking. The problem is, if you look at the new Sepsis 3 guidelines, which the critical care guys have put out, they have defined it as anything where sepsis could be a possibility, in other words. Basically, the problem is that in patients who are debilitated, which cirrhosis would be, the manifestations of sepsis are protean, and they can very easily present it with encephalopathy as a presenting feature of a sepsis. Yes, if we look at the older guidelines, which make a lot more sense to most of us because we can easily slot them into different baskets, we look at them into SIRS, sepsis, and severe sepsis. SIRS, the inflammatory response with a possible focus, good enough for sepsis, with the organ dysfunction or with hypotension is severe sepsis and organ dysfunction is septic shock. That's easy to understand. But we need to understand that that definition would miss a couple of patients who present with unusual manifestations of sepsis, like encephalopathy. And therefore, the index of suspicion, especially in a cirrhotic patients, needs to be a little broad, that any patient who comes in with a change in their usual status, sepsis is a possibility, although need not be the only diagnosis.
Thank you. Now, obviously, this is the problem with most of these patients. So, patient comes in with ACLF and develops a bit of hypertension. We're wondering, is it just a progression of the ACLF, or is it sepsis? Are we looking at an infection, or are we looking at just deteriorating ACLF? Dr. Zubair, in the ICU, when you see a patient who's developed new onset organ failure on a background of ACLF, what is your method? What are you thinking? How are you going to try and see what is the cause of the deterioration? Is it just ACLF or is it sepsis?
Thanks. Am I audible?
Yeah. Thank you.
Brilliant. Okay. Thank you for the question. Now, as Dr. Subramanian has mentioned, there is a theory and there is a practical side of things. Now, if you go by the definition, so we'll go through the definition first of all. If you go by the apostle definition of ACLF, that is someone with a diagnosed or undiagnosed CLD who presents for the first time with a bilirubin more than 5 and INR more than 1.5, with or without ascites and encephalopathy, that has got a high mortality. So that is the definition of ACLF as per apostle. And they define that the sepsis is a complication or a consequence of ACLF. However, if you go by the Easel-Cliff guideline, the sepsis is a precipitant or a cause. Now, having said both of that, we all know that there is a ongoing inflammatory response in the ACLF patients because of the immune dysfunction, and there is the ongoing endotoxemia secondary to the portal hypertension, gut microbiota alteration, and the gut translocation of bacteria. So we know that there's an ongoing inflammation, which is what the SIRS definition sort of tried to convey earlier. Now, if you go now to define sepsis as by the Sepsis 3 guidelines, you need to have life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, that's where the catch lies. Now, how do you define organ dysfunction and what is an infection? Now, organ dysfunction as defined by Cliff-SOFA criteria and by SOFA, the standard SOFA, which is what the sepsis guidelines used, are slightly different. Now, we all know that they've divided the body into 6 organ systems. You've got the brain, you've got the lungs, you've got circulatory system, you've got your blood, your liver, and the kidney. However, the original SOFA score used Glasgow Coma Scale, and the Cliff-SOFA used encephalopathy, hepatic encephalopathy. Similarly, the original SOFA score used platelets, and the Cliff-SOFA used INR. But then, having said that, the rest of the numbers are pretty much the same. Now, if this patient, by definition, has got any situation where the organ dysfunction as defined by more than increase in score by more than 2 points, then that comes under possible sepsis. But having said that, infection is a clinical diagnosis in this situation. You do not need a microbiological or a radiological diagnosis to define infection by definition. So these are the definition side of things. In real life, we all know that these patients are prone to get infection, and it is an ACLF that is decompensated. Most likely it's got an infection given by the fact that there's a rising temperature, which by, just to mention, doesn't come in any of these definitions as the marker of infection. And plus there is a hypotension, which I believe is a new onset one. If it's a new onset, you get points for that, but we need to know the rest of the labs and the vital parameters to actually define by definition whether there's sepsis or not. Hope that's a bit, it's a bit complicated, but I hope I have made it I've tried medicine.
Thank you. Thank you. Now, I think we'll just take a step backwards. So, I mean, this is a question. A patient comes in, is like we saw some bloods, she is quite sick. What is the general protocol that's used? I mean, we do send routine cultures, but do we routinely give prophylactic antibiotics and antifungals for these patients? Dr. Naimish, what do you do in your practice?
So, now, if sepsis, already my preceding speakers have already spoken what exactly sepsis, what are the causes of sepsis and bacteremia. Am I audible?
Yeah. No, before, I mean, even if the patient didn't have fever, would you, a patient like this is admitted, what would you be a normal protocol in your unit in terms of antibiotics and stuff?
So again, routine workup is very much necessary because most of these patients who are suffering from chronic liver disease, they as such would have a higher chance, about 20% chances of having infection, much more than the normal patients who would present to you in the hospital. And if the patient has got ACLF, now these patients have 20% chance higher of developing infections compared to those chronic disease patients. So in these cases, it is always better first screen them, send serum procalcitonin, send the basic blood cultures, urine cultures, and obviously X-ray chest and to find out if there is any existing focus. If these patients have got ascites, you would like to tap it and see if they have got developed SBP or not. Yes, prophylactic antibiotics, we would like to definitely start them on some broad spectrum antibiotics at the onset. In case they do have signs of sepsis, like in this patient, there is already a fever. I'm sure you would have sent for blood for the procalcitonin levels. And based on the culture, if you find that the antibiotics which you have started, you would want to add something else to it, or you would like to change your antibiotics, then it would be all guided based on the culture report. So that is how we would like to continue in our scenario. Coming to antifungals, again, these patients who are suffering from liver disease are to develop super added infection, and fungal infection is a very well-known entity which exists in these patients. So as a prophylaxis, usually fluconazole is what we start in our unit. But in case the cultures do come back and show that it has got any other candida or any other organism like aspergillus, then based on that, you would want to increase your antifungals as well and upgrade it. So that is how what we would routinely go about in our institute.
So thank you. So you do a complete septic screen. You start them on some broad spectrum antibiotics, and fluconazole is an antifungal, is it? Is it for all
absolutely, that's the prophylactic.
Okay,
correct.
Thank
so
you.
That's for
Thank
prophylaxis. Yeah.
Perfect. So going on with this case, so we sent off stabilized her, sent her cultures, we escalated the antibiotics, did a chest x-ray, showed some right effusion, atelectasis, nothing major there. We did an LVP, I think around 8 liters of fluid was drained. And the cell count is 2000 cells, so 90% neutrophil. So that's she's got SBP, and that's probably the cause of hypotension. But she also grew gram-positive cocci in her blood culture. We'll come back to the significance of that later. Coming to timing of liver transplant, so this is always a problem. Patient needs transplant quickly, and this patient has an episode of sepsis. How long are we going to wait after an episode of sepsis before we do a transplant? Dr. Prashant. Prashant, are you there?
Yeah, I'm here.
Prashant, hi. So, I mean, obviously there are various types of infections. It can be a simple UTI, it can be a chest infection, or a bacteremia. So what is the protocol in your center? Is there a waiting time that you wait for before we go ahead to transplant, or what do we do?
So I think, Sri, as you already have put it, I think this waiting time before the transplant will depend upon two things. Number one, I think, is the site of the infection. And number two would be the organism, if at all it grows. So number one, as far as site of infection is concerned, such an ACLF patient would come to you with a chest infection. I think that a minimum waiting period of 1 week is what you would take. And in the case of a chest infection, I think once we know that there is a chest infection, we would usually do a baseline CT, HRCT of the chest. and then compare it at 7 days or maybe a day before the 7-day deadline actually, and see how the thing has progressed. So if there is an improvement, if there is signs that with your antibiotic therapy, there is an improvement, and clinically also you find that the patient is improved as compared to before in terms of the chest, I would tend to go ahead. Number two, if we come to the urine, I would say if you have a positive culture, you give 3 days of antibiotics according to that particular culture. I would send off a repeat urine culture 3 days after I have given the antibiotics, and then wait for the report to come back. And if I have a negative culture at the end of it, I would go ahead. Having said that, again in the urine, if it is an E. coli, which is sensitive to multiple organisms, and I've given a good M.I.C.E. antibiotic, at the end of 3 days, I would compare probably initially the urine routine microscopy showed me a large number of pus cells, and now that has decreased. I would probably tend to go ahead in the case of a urine culture. In the case of blood, again, I would wait for a negative culture. Having said that, again, in this situation, ACLF, you treat with 5 days of sensitive antibiotics, send off a culture at the end of 5 days. And if you have maybe 3 days culture, so that makes a total of 8 days after you have initiated antibiotics. If it is negative, nothing is growing on that 3-day culture, I would still go ahead. The second aspect that I said was about in SBP, as in this particular case, I would wait for a minimum period of 5 days after the SBP, repeat an ascitic tap, make sure that there is a improving trend on the ascitic tap, and then I would go ahead. The second aspect that I pointed out to was the type of the organism. And what we are seeing today is from 7 or 8 years back to now, there is a huge change in the strains that are growing. So initially we used to have E. coli in the bacteria, which has now changed to Klebsiella and Enterobacter. In the fungus, we had Candida albicans before, and now there are more and more of Candida non-albicans strains. And when you have beta-lactamase producing, say, Enterobacteriaceae or carbapenem-resistant Enterobacteriaceae or VRE, vancomycin-resistant Enterococci, or you have those Candida which are resistant to fluconazole, I would be wary of going ahead. And therefore, I would actually treat them completely and make sure I have negative cultures before I actually go ahead for a transplant. So I think broadly putting it, that would be the way in terms of site and in terms of organisms.
Thank you. That's you explained quite elaborately. I think we pretty much do the same. I think the only thing with the UTI, I'm not really sure whether we wait for 3 days or 4 days after for a UTI, unless obviously it's symptomatic, and because we send a urine culture the day before or 48 hours before the transplant. If that grows bacteria, we don't really have to delay the transplant, do we? I mean, Dr. Akash, what do you feel?
Yeah, thanks, Dr. Srinivas. I think I agree with you completely. We would not delay for a asymptomatic bacteriuria. Yes, a symptomatic UTI, definitely yes, we would delay, but not for a asymptomatic bacteriuria.
Okay, thank you. I think what Dr. Prashant meant was symptomatic, I think. So, Dr. Akash, about this patient. So, this patient has had an episode of SBP. So, Dr. Prashant was saying that we'll wait for 7 days and we do a tap. Do we always need to do a tap, or is just clinical improvement sufficient? Do we need to do a tap and confirm that cell count is coming down? What is your protocol?
So, I would, in a usual case of ACLF, we would not routinely repeat ascitic fluid analysis to diagnose a response to therapy if there is a clinical improvement or a clinical response. However, if I'm contemplating a transplant in the near future or immediate future, then at 48 hours after the treatment has been started, I would definitely do an ascitic fluid test, repeat, to ensure that there's a 80% reduction in the polymorphs. And that is what is going to define response. In these cases, we would wait for 5 days, and once 5 days of antibiotics are completed, we can go ahead for the transplant. That is the policy that we follow. By definition, SBP is a paucivascular disease, and therefore the response to therapy is much quicker as compared to most other infections, and therefore usually 5 days of antibiotic is sufficient.
Thank you. So
for me also was 5 days, not 7 days. It was
sorry.
Just like Akash said, so 5 days for SBP. Yeah.
No, I just wanted so when do you decide whether you want to do anyway, if you're going to give antibiotics for 5 days before transplant, do we need to really tap if the patient, is it when the patient is not showing clinical improvement, you tap to see what's happening, or you tap and if it's coming down, then you go ahead with an early transplant? How do you decide when to tap and when not to tap, a second tap?
Yeah, so I think very valid question. So if the patient is clinically not improved, definitely that is an indication for retapping. If we are contemplating a transplant in the next 3 days, I would definitely repeat a tap and send this fluid for culture as well. Before I go ahead with the transplant, there should have been a neutrophilic response as well as the culture should be negative. So that is why 5 days. So 48 hours you repeat, because you can get both the culture report as well as the neutrophil report. So before you can actually go ahead with the transplant. So that is something which I'm comfortable with, and it has worked over a period of years.
Okay, thank you.
And if you look at Bruce Runyon study, actually 2004, there they have showed 5 days of antibiotics versus 10 days of antibiotics. The results are the same if you have response at 48 hours.
Thank you. So, I think the next, I think we already discussed the role of repeat ascitic tap. I think the next question is for Dr. Subra. I think there's been a question on the chat also. What is the role of procalcitonin in these patients, procalcitonin in CRP, in diagnosing infection, both before and after transplant? Can you just tell us a bit about procalcitonin, what it is, why it goes up, and how relevant it is in patients with liver disease? Dr. Subra.
The reason why we use biomarkers is 2 reasons. One for diagnosis, and the second is for prognosis. So that is, we want to study how they are doing, whether they're improving or whether there's a possibility of worsening. So the first question is about diagnosis. When we look at diagnosis, a lot of biomarkers have been tried out, more than 160, but the common ones are procal and CRP. Problem is CRP being a very long half-life compound protein, it does not really correlate very well with inflammation, and it takes time to take off. Procal is faster. So generally we use procal. But for liver disease, there's a problem. You're talking about a patient with acute and chronic liver failure, maybe some amount of cell necrosis. And studies have shown that in patients where there is overwhelming cell necrosis, liver included, the procal can be high even in the absence of sepsis. Here's the point. It's a continuous variable, whereas we use 0.25 as the cutoff in normal people. In cirrhotics, the recommended cutoff is probably 0.5, with the understanding that it even up to 2 or even higher in the setting of severe cell necrosis of the liver. Therefore, the immediate cutoff for procal is very difficult to find. On the other hand, follow-up numbers are very useful. The dynamics don't change. If you're thinking of sepsis and you start treating for sepsis, in 24 hours, if you start to see the procal, 2 measures 24 hours apart, they start falling or they stabilize, you know you're doing the right thing in terms of sepsis control. So those parameters don't change. But the initial number is very, very difficult to interpret in the setting of a unstable cirrhosis or a cell necrosis. In the post-liver transplant setting, the problem is, again, surgery itself increases your procal number. And the rise in procal can last up to 5 days after any immediate surgery. So therefore, interpreting procal in that setting can also be a little tricky. And here again, the dynamics will still hold true. So if a person has had a surgery and you do a procal now, 24 hours later, a procal repeated should actually fall. But if the procal is rising and you were thinking of sepsis, you were probably on the right lines. And if the number is rising, it probably also means that you're not treating it adequately, or there is a focus that's being missed. With the understanding that the sensitivity and specificity are such that you can end up over-treating on rare occasions. To summarize it very simply, procal is a nice number to have. All of us like numbers. But having said that, be aware that high numbers need not always mean sepsis. But if you have a patient with sepsis, following procal at time 0, day 1, and maybe even day 5 could give you very valuable information on where you're going as far as therapy is concerned.
Thank you. That's very useful. Thank you. So I think this is just a table talking about what Dr. Prashant very clearly told us. I'll go to the next slide. So coming back to the patient. So the patient was evaluated, a donor was evaluated, and waiting for a donor optimization, and then a patient got readmitted to the ICU with worsening sensorium, needed elective ventilation, and had to be started noradrenaline. Urine output remained good. Noradrenaline was not very high, I think 5 or 6 ml. At this point, so obviously we just treated the SBP nearly a week ago, and patient has deteriorated over the last 12 hours. What is it thinking? I mean, what are the options? Do we just go ahead and transplant because we finished 1 week of antibiotics and there's no active sepsis, or do we wait and see what happens, or do we wait until it stabilizes? Dr. Nemish, can you tell us what would you be thinking? How would you actually process this kind of a patient to decide what to do?
So, since we have already treated the sepsis, the SBP, for almost 7 days now, and this patient had to be shifted to intensive care unit with elective ventilation, that is one organ which is now being affected. Second, had to be started on noradrenaline. So that's the circulatory organ. There's a second organ being affected now. Fortunately, the kidneys are functioning well. Now, in these cases, even if you look at the ARC scoring and the ACLF score grades, the points would have increased here if you actually go and give the scoring system. Now, in such cases, if you actually offer transplant early, then there are various studies which say that they tend to have a good outcome when transplanted at the right time. So, in my opinion, if the calculation, the scoring system has moved up by 1 or 2 points, and you still have a good urine output, no obvious infection lingering at present, your X-ray does not show pneumonia. That is one of the major factor I would like to clear out. X-ray or a CT. If you have suspicion of pneumonia, then you need to check with the HRCT chest. And if you are sure that there is no developing any other infection, I would like to go ahead and transplant this patient and give full chance as much as possible, rather than waiting, because during the third option which you have said is hold until stabilization. Now the question will here come is, what is stabilization? And during this episode of stabilization or the time period taken, suppose this patient develops a VAP, that is ventilatory associated pneumonia, then probably this patient will go out of transplant completely. So I would prefer going ahead early transplant in these cases, and explain the family similarly.
Thank you. So, I mean, I think for me, I fully agree with you. I think we cannot really wait until patient recovers. And there was a time when we say should come out of the ICU, go back to the ward, only then we'll transplant. But I don't think that's fair anymore. But the question here is, would you say, I always feel, let's see what happens in the next 24 hours. If he's really crashing, then maybe we shouldn't really transplant, or should we say no? It's better to transplant right away and then see how it goes. I mean, that's always a difficult question for me. And Dr. Prashant, what do you feel? I mean,
sorry, but I'll just absolutely. So it's a double-edged weapon, where that waiting for 24 hours can actually be detrimental as well. So the encephalopathy can worsen, and you may lose a crucial time period in this case. Sorry, Prashant, please go ahead.
So I would take a slightly middle path, Srini. I actually would wait for 48 hours. I would, because someone who's gone home after treatment of infection comes back to you and now is requiring NORAD, is requiring elective ventilation because of worsening HE. We know that there are 2 reasons why these people go into HE. Most commonly, it is sepsis. Second, it is either a bleed or they are further decompensating. Given that it's an ACLF patient, but still someone goes home well and comes back to ICU, I would give it a 48-hour waiting period. And especially, as Dr. Nemish also put it, I think at this stage, chest is a contraindication for me, because we have seen in ACLF patients, if you were to transplant them with 2 organ dysfunction, if you have a score of 2 organ failures, if that third organ is the chest, then definitely they do worse. Even if one of the 2 organs is the chest, then they do worse. So if you are sometimes able to bring down a 3 organ, here it's a 2 organ failure, I think that 2 and 3 are variably different. So 2 is good without the chest. If you have 3, sometimes it helps to bring that 3 down to 2. And then you have a better outcome. Don't delay the transplant, but give it some time to get that down to maybe 2 system disorder, not having chest involved, and then you probably would get a good response. So a short answer to you, I would see how things go over 48 hours before going ahead with the transplant.
So can I pitch in here as well? Sorry,
Yes.
I don't think this patient would have gone home, Prashant.
No, that's it.
This
I'm
is
sorry,
an
I won't tell
ACLF
you.
on SBF, on SBP. So she probably got shifted from the ward while she was being treated and then got admitted to the ICU. So I think that's what the impression I would carry it, because ACLF
I'm
would
sorry,
not go back
Prashant. I think that's true. Yeah, the patient was in the hospital as an inpatient, but I think still that what Prashant says is I think
enough.
To an extent it holds.
Absolutely.
Yes, and I fully agree. Chest is the most problematic organ actually to deal with in the post-transplant period. In fact, this patient, we decided to go ahead with transplant, and the morning of the transplant had started developing hypoxia, and both lungs had basal collapse. So we did a bronchoscopy and evacuated secretions, and then the oxygenation improved only. Then we took the patient, and so we did undergo an LDLT, did a left lobe graft. It was fairly straightforward, and the patient was shifted back to the ICU. So the next question, I think this is something that Dr. Nemish, what is the standard antifungal prophylaxis used in your unit, and how would you deal with in this kind of a patient who's had ACLF and who's been in hospital for a while?
So again, your pre-op cultures would have brought out if there is any fungal infection in the culture, either urine or the blood. If we have not found anything in the pre-op cultures or the immediate cultures, we would continue with the same prophylactic antifungal of fluconazole, unless it is we find that the total leukocyte count is increasing and your procalcitonin is still low. That is the only scenario, or you would grow a fungal culture. These are the two scenarios where we would upgrade the antifungal. Otherwise, we'll just continue with fluconazole as our prophylaxis, even in post-transplant period.
So all ACLF patients also, you just give fluconazole as a prophylaxis?
We would still continue unless you have suspicion of either a patch coming up in the lung, either urine showing infection, which is culture, which will be eventually culture-based, or blood showing fungus growing. We would still maintain them on prophylactic fluconazole.
Okay. Thank you. Dr. Akash, what is your unit's protocol in terms of antifungal prophylaxis post-transplant for ACLF patients? Is it just fluconazole, or do you higher end antifungals?
For patients with ACLF, we would almost always have an echinocandin as a prophylaxis. And we would, but unlike the Western recommendations, which talk of 21 days, we usually would give it for around 7 days. And by the time the patient has stabilized, is out of the TICU, is in the wards, we would stop the echinocandin.
Do any of the centers use amphotericin B as prophylaxis in this kind of high-risk patients? Prashant, Dr. Zubair.
Yeah, so I just wanted to say, I actually had raised my hand. So I would agree with Dr. Akash. So actually we've classified our patients for, or risk stratified our patients for antibiotic and antifungal prophylaxis. And we've classified them into normal risk and usually the high risk for infective complications. And I think acute liver failure, recent episode of sepsis or SBP in the last 2 weeks, a retransplant, renal dysfunction, hospital admission more than 2 weeks in pre-transplant 1 month, admitted to ICU in the recent 2 weeks, previous antibiotic exposure within high-grade antibiotic exposure within a month. So I think these are the category of patients where we would tend to have a lower threshold to put them on echinocandins for a period of 7 days post-transplant, and then switch over to fluconazole for another 1 week to 2 weeks. So usually our protocol for antifungal prophylaxis stops at 2 weeks. So if I was to put them on echinocandins for the first week post-transplant, I would normally give them about 2 weeks of fluconazole after that, 10 days to 14 days of fluconazole after that. But my threshold to give echinocandins for first 7 days is, very low in these patients with ACLF.
I sort of agree with what Dr. Prashant has said. Normally for ACLFs, we don't give echinocandins. For a person with a similar history, we would go for echinocandins to start off.
Thank you. Dr. Subra, I mean, just wanted your inputs here. Obviously, post-op we have fluconazole, we have echinocandin, fungin, we have amphotericin B, we have mica fungin. Which is the best for which setting? I mean, is there anything like that, or just unit?
The answer was that easy. So very good question. So obviously, the answer has to be center specific. It has to be based on the risks appreciated at that center, and it is also dependent on the mycology which is seen. So while the beautiful, the talks before this, everybody has mentioned all the interesting risks. Obviously, I'd add on things like operative time, blood use, and the CRRT after transplant, and re-exploration biliary injury also in the mix to that. Please keep in mind that the risk is separate for mold and the risk is separate for candida. While there is considerable overlap, they are not necessarily the same. Also, I would add on in this current scenario, as a post-COVID status or somebody who's recently recovered from COVID also has a high risk factor for mold infection. And please, let's not forget that. We've seen lots of it. And it's only a question of time before we all start seeing things like that in our transplant recipients also. So that's also a concern. Now, question is, what is the right antifungal? That's a bit of a problem, isn't it? Because in the Western world, they're primarily talking of candida. And if things get really bad, they talk about aspergillus. They really don't talk much about mold. And in answer to your question about whether people have used amphotericin, the answer is yes. In the Western world, where they do see mold infections, non-aspergillus, there are centers which have looked at use of amphotericin. But obviously, it's a question of working on certain HIC areas and also risk stratification for most of your patients to reduce the risk, to try and see if that can be mitigated. But if that is, obviously, once in a while, you get this very high-risk patient who's already had a fungal infection in the past. Patients with chronic liver disease are at high risk for mold infections as well. If that were so, then you'd have to go back to whatever is appropriate for that problem. So long story short, in low-risk patients, you may not need an antifungal prophylaxis. If you want to use fluconazole, I'm not going to fight that because it saves on TAC costs. In intermediate-risk patients, you can think of an echinocandin, but with the understanding that you can have breakthroughs with mold, aspergillus should be covered. And in extremely high-risk patients, especially if there is a concern in the center about mold based on your own mycology, on a case-to-case basis, you could even think about enhancing the prophylaxis. And this is not something that's not been done in the Western world. So again, it has to be center-specific. It has to be covering the challenges that you have and appropriate for the patient population.
Thank you. Just staying on fungal infections for a little bit. When do you start thinking of a fungal infection in a patient, and then if you think it might be a possibility, how do you go ahead? What are the tests that you would like to do, and what tests are relevant for which fungus?
Very, very simply, let's divide it into two halves. One is the yeast infection, the other is the mold infection. When I talk about yeast, I'm primarily talking about candida, although there are other non-candida yeast as well. So if you're talking of candidemia or tissue candidiasis is rarely a big problem, but candidemia can be catastrophic. So it usually presents as a sepsis-like syndrome, and where you have negative cultures, your procal may not be elevated, counts may go up. So if you have that kind of setting, the current recommendation would be to use an echinocandin upfront, especially in a very vulnerable host, and then based on cultures and culture negativity, repeat culture being negative, you step it down. As far as mold syndromes are concerned, it's usually tissue invasive. You're looking for either sinopulmonary or tissue invasive in the operated area or something like that. When you see that, you need to have a low threshold for getting tissue and making the diagnosis. And here's the problem. Radiological picture or markers need not necessarily tell you what it is, because there's a lot of overlap in all of these things, and none of this is foolproof. The only foolproof answer is tissue for histopathology and the cultures. Please understand that histopathology may also misidentify the fungus in up to 20% of the time.
Okay, thank you. I think we'll need to rush a bit. I've got a message from Dr. Neeraj that we are running out of time. So I think the second most important thing in terms of sepsis is balancing the immunosuppression in these patients who are at high risk of sepsis. Dr. Akash, what do you have a patient who's like this ACLF patient who just recovered from SPP, transplanted? How would you look at immunosuppression for this lady?
Yeah. So we have, in general, reduced the immunosuppression that we have been using traditionally. And perioperatively, now we have come out, intraoperatively, we have come down to 5 mg per kg to that level. And after the surgery, we start at 1 mg per kg. Methylprednisolone, that's right. And post-operatively, we start with 1 mg per kg, but not more than 50 mg, and bring it down to 20 mg very quickly before the end of the week, and then keep them on 20 mg. And we would start tacrolimus, but delay the introduction of mycophenolate in these patients. So that is what we have been doing. And I think it has worked well for us. We have gone through the whole cycle. We have tried multiple other regimens, and this is finally what we thought works best for us.
So this is for your standard recipient, or and do you make any modifications in somebody who's at a high risk of sepsis?
This is for a patient who is at risk for sepsis.
Okay, and what do you do for your standard recipient?
So we would give 10 mg per kg of methylprednisolone intraoperatively. So we would reduce the dose to half.
Okay. Thank you. Dr. Prashant, what about your center? Do you have any modification of your immunosuppression protocol for patients at high risk for sepsis?
So very similar, 10 milligram per kg body weight for a normal individual, methylpred intraoperative, and reduce it to 5 milligram, that is half the dose intraoperatively of methylprednisolone. Keep the pan graft starting at usually 24 hours post transplant, and you normally start with 1 milligram unless and until you've got a patient who is really low body weight, like 40 kgs. You would initially probably start with 0.5, and it also depends upon pre-operatively what was the renal function. So in a patient who had a creatinine which was slightly on the higher side, maybe 1.5, we do some things intraoperatively as well, like no clamping, total clamping of the cava in order to protect the kidneys. We do a side clamp. But in the post-operative period, I think starting off of 0.5 versus 1 would probably also depend upon pre-operatively how good your renal function was, and also intraoperatively how the patient behaves. CellSept, as Dr. Akash also said, I would delay probably for a period of about 48 hours in a patient who's at a high risk for sepsis. Otherwise, I would introduce CellSept also at about 24 to say 36 hours after the transplant in a routine recipient.
Thank you. Thank you.
I think one quick comment, if
yes, please. Yeah.
So when we are deciding about whether you'll wait for this patient to be transplanted or you would do the transplant immediately, one of the things to look at is the rapidity of increase of the inotropes. And when the inotrope requirement is increasing very rapidly and the urine output is decreasing rapidly, those are the patients where I would definitely differ, because that is usually an indication of sepsis. So I think that is also a factor which we should keep in mind, other than what Dr. Prashant and the other speakers had said, which I completely agree with.
Thank you. I think the last thing is about the extracorporeal therapies for severe sepsis. Dr. Zubair, can you tell us very briefly about what are the options available in the Indian market now, and what is your experience with using them?
Yeah, sure. Yeah, so it is so for the benefit of the junior doctors here, just briefly what we mean with extracorporeal therapy is that you take the blood out, put it through a pump, purify the blood, and put it back in. Now, when you mean the crux of the therapy lies in what is meant by purification and what do you actually purify. So to understand that, there are two things. One is the cytokines, which is what the body produces in response to an infection, and the second one is the endotoxin, which is what the bacteria produces, the bacterial cell wall. Now, one option is to take the whole blood out and take the plasma out and replace it with the plasma. So, which is the plasma exchange. So you can replace it with whole volume plasma, or you could partially replace it with half of plasma and the rest half as albumin or saline, depending upon what you prefer. So you take the whole plasma out and put in a new set of plasma, so that you take out all the cytokines, the endotoxins, and with that you actually take out the albumin, the micronutrients, the antibiotics, etc. Which is, as what Dr. Deepak Govil said, that is where you may have problems. So that is plasma exchange. Now, the other option is to selectively take out one of these two. So you can either take out the cytokines or you could take out the endotoxins. Now, the taking of the endotoxins is what is meant by the heme absorption, the toramycin or polymyxin B. So basically, they have got this, you take the blood out, run it through a filter, and the filter absorbs the endotoxins. So that is what that particular filter does. It doesn't take out the cytokines. The third one is when you take the blood out and you just remove the cytokines. Again, for that you can have multiple different type of filters. You can run it as a high volume hemofiltration, which is basically you use a normal CRRT filter, but the effluent rate is quite high. Or you could use the fancy filters that comes in the name of, what do you call, Oxaris, which, the cytosorb, which actually takes the cytokines out. Or, and then you could also use the Oxaris, which actually takes the cytokines out as well as endotoxins. So these are the various combinations that we've got in the market. Plasma exchange, again, most hospitals are able to do that. Most liver transplant centers are able to do that. But, the evidence for plasma exchange in sepsis is borderline. As far as the other three conditions, the cytosorb, the toramycin or the polymyxin B, and the Oxaris are concerned, there are different filters marketed by different companies. We have used polymyxin B filter, the toramycin, as well as a cytosorb as well. Our experience is similar to what is available in the published literature. So the outcomes have been variable, and we do not use it routinely. If you don't have any other options, then we might consider it on a case-to-case basis, but it's not something that we do routinely, because there is no level 1 evidence to say that really makes a difference in this set of patients. The best evidence that we've got is case series, and the RCTs have universally not shown a positive effect of using extracorporeal therapies for severe sepsis.
Thank you, Dr. Zubair. I think we'll finish. Can I just quickly go around with the panelists about their use of extracorporeal therapies? Because we've used it in a few cases. It does help in stabilizing the patient, but I don't know how much it improves the outcomes. Naimish, Dr. Akash, Dr. Prashant?
So we haven't really have got good response in these type of cases, though it tries to remove the toxins, and but honestly our personal experience is not that great. So we would not really go behind this therapies just to say bridge to the transplant. So these would be done only when we have said that this patient probably is not going for transplant, do not have an option of a living donor suitable in the near future. Then these cases would be put on such therapies.
I'm talking about its use in the post-operative period in someone with severe
sorry. So again, post-operatively, we have used in 1 or 2 cases, but again, the situation is same. I don't think that changes the scenario that much.
Thank you. Prashant?
So I think we have experience with toramycin. I think we have experience of, we've been collecting this data in about 60 patients now where we've used this. And ballpark, I would say, when it is used correctly in the right patient, and what is our definition or what is our criteria for using it? Number one, I think you have the patient already on high-end antibiotics. He has features of gram-negative septicemia. He has features of endotoxemia, which basically sometimes can be seen by an endotoxin assay. They are the EA endotoxin assays that are available. And if you have a level more than 0.6, that is an indication for use of these particular therapies. And you have, as I said, endotoxemia, gram-negative septicemia. You already have the patients on high-end antibiotics, and now he's requiring inotropes. Before it goes to a very high dose of inotropes, if you are sure about these, or a high level of suspicion of this particular situation, with a corroboration with the endotoxin assay, if you use it, we found that it helps in about 50% of patients to stabilize the patients. So in a series of about 60, I would say that it has helped us to stabilize patients in about, say, 30 patients, and they have had a good outcome. And especially if they're used early at the right time. When there is a delay and there is a high anti-inotropic usage, that's where it is already too late. And when there is multi-organ involvement, that is somewhere where it is already too late, especially if the kidneys are involved. Again, last point, if the chest is the source, doesn't help. So it's usually the metabolic, your abdominal source, your SSIs, your the liver itself. Those are the conditions probably where it may help. That's our experience.
Okay, thank you. Thank you. I think we'll finish now. Thank you very much to all the panelists, and thanks, Neeraj, for patiently waiting for us to finish. Thanks.
Thank you, Srini, and thank you all the panelists for this wonderful discussion. I think it was a very real life discussion on what actually happens in the wards, and not just discussing literature. Over to Shweta to conduct the next session.
Thank you, Neeraj. Thank you for the excellent session. I think we can move on to session 5, the final session on acute liver failure. And for that, I would like to invite our chairpersons, Dr. Sanjeev Sehgal, Principal Director and Head of Hepatology at our very M.I.C.E Institute. Welcome, sir. Dr. Ramdeep, Chief Transplant Surgeon at Apollo Gleneagles, Kolkata.
Thank you.
Dr. Naveen Ganju, Consultant Hepatology at Sparsh Hospital, Bangalore. And Dr. Murugan, Senior Consultant Surgical Gastroenterology, Apollo Hospitals, Chennai. I would like to invite Dr. Dharmesh Kapoor. Sir.
Thank you, Shweta. So,
Dr. Dharmesh Kapoor, Senior Consultant, Yashoda Hospital, Hyderabad. Sir, I would like to invite you to moderate the case discussion and start it, please. Can we invite the panelists as well?
Yes, please go ahead.
Okay. I'd like to invite Dr. Kaushal Madan. Sir, are you there? Dr. Kaushal Madan is Principal Director and Head Hepatology at M.I.C.E Hospital, Delhi.
I'm here. Thank you.
Okay. Dr. Joy, Gleneagles. Dr. Joy, are you here? I'd like to invite Dr. Joy Varghese, yes, Director Hepatology at Gleneagles, Chennai, to be a part of the panel. Dr. Neerav Goyal.
Yeah. Hi.
Hi. Senior Consultant and Transplant Surgeon at Apollo Hospital, New Delhi. Dr. Vaishali, Senior Consultant, Critical Care at Global Hospital, Mumbai. And Dr. Pamecha, Chief Transplant Surgeon at ILBS, New Delhi. So your panel is complete.
Sure. Need to see Vaishali because.
Yes, sir. I'm here. I'm just on audio, right?
That's fine. All right. Thank you so much for this opportunity, Shweta and Neeraj. Without much ado, I think this is something that the panelists are going to do. I have a very small role to play in this. Are the slides visible?
Yes,
sir.
Your slides are visible.
Slideshow mode.
I think I did it early. We have to do again because the slides are not moving.
So kindly put the slides in the slideshow mode, please.
Yes, just give me a moment. Can you see the slides?
So we can see your slides. Can you put them in slideshow mode?
Is it slideshow mode now? with the history
Dr.
of.
Dharmesh, we're still on the first slide, so we haven't moved to the second one.
So can you see this? This is just the case study ALF.
Yeah, we can see that.
We can just see that.
Yeah, can you see the text on this slide now? The next one?
No.
No, it's not moving, sir.
History of recent travel to her native district 4 weeks ago, and she presents to the ER with a history of fever without any localizing symptoms of 2 weeks duration, nausea and recurrent vomiting of 10 days duration, scleral tinge, high colored urine of 10 days duration, drowsiness intervening with marked irritability of 1 day duration. She had not passed any urine for the last many hours prior to presentation, and there is no history of any prescription drugs, over-the-counter medication, or complementary alternative medicines. She did not have any cutaneous or mucosal bleeding, abdominal distension, or swelling of the legs or feet. She had had poor oral intake and pruritus for the last 3 to 4 days. She was not on any chronic medication or recreational drugs. No history of seizures, rash, joint pains. No, the travel history is as I described a little while ago. No history of diabetes, hypertension, tuberculosis, thyroid disorder, or surgery in the past, and her family history was not contributory. So the way we planned this panel discussion was that each one of the panelists will be taking a specific issue. And this patient, I'm starting with what we saw in the ER, and then Dr. Kaushal is going to take over the triage and initial set of investigations by sharing his own slide set. So even if I don't share my slides, it's not a big deal. So specifically for you, Dr. Kaushal, when this lady was seen by us in the ER, her pulse rate was 130. It was a regular pulse. The blood pressure was 100/60, respiratory rate of 32, temperature of 100.6. She had deep jaundice, no rash. There was no palpable lymphadenopathy or pallor or edema. Her GCS was E2, V2, M2. She had flaps, hypertonia, hyperreflexia, ill-sustained ankle clonus. The cardiovascular system in the chest examination was normal. Abdominal examination, the abdomen was soft with no clinically detectable free fluid, no hepatosplenomegaly. The blood glucose recorded by the ER nurse was 65 milligrams per deciliter, and the blood gas which was done in the ER showed a lactate of 6.5, a pH of 7.5, PO2 of 95, PCO2 of 28, a bicarb of 22 with a base excess of plus 0.5. So what do you think we are dealing with over here, Kaushal? And you could now take over, please.
So I'll need to be given rights to share my slides.
Yes, please go ahead.
Yeah. You will have to unshare your slides.
Yes. In any case, mine are not shared.
Sorry. Just give me a second. So can you see my slides at least?
I can see only the Yahoo mailbox.
Yeah.
Now can you see my slides?
Sir, we can only see your inbox.
Okay. I don't want that to be seen.
No, it's blurred. We can't read it.
So I think something is wrong with the platform, because
now we can see some snapshot of an article, drug-induced acute liver failure.
My God. Okay, let me try once more. So now is it better?
Yes, we have your slides now.
And they're moving, right?
Yes.
So I think, thank you, Dr. Dharmesh. Thank you, LTSI, for making me part of this meeting. So initial workup, I think Dr. Dharmesh has covered everything. I'll just take you through the important points which he has made, which can be missed if not taken care of. So I think in history, the first thing to decide whether patient has ALI or ALF or ACLF. So, so as you can see, if a patient who has jaundice and coagulopathy develops encephalopathy, then it is called acute called acute liver failure if the patient does not have underlying liver disease. And this encephalopathy has to develop up to 28 days from onset of jaundice. However, in drug-induced liver injury, this duration, the timing of development of encephalopathy can extend beyond 4 weeks. So remember that. So if along with that, this person also develops ascites and has features of underlying CLD, then that becomes ACLF. So Dr. Dharmesh talked about drugs twice. So it is important that these patients, you have to exclude the history of significant drug intake, which can be hepatotoxic. And this is a study from India, where 14% of DILI led to acute liver failure, most common DILI being ATT-induced hepatitis. Workup, he has already talked about most of the workup, but remember, these are important. That will help you in triaging as well as in further management of these patients, especially lactates, arterial ammonia, and sodium and potassium levels. Tropical fevers have to be ruled out. He talked about the history of travel. Remember to rule out dengue, malaria, scrub typhus, enteric. Patient did present with fever at the onset. He gave history of travel. I should have also mentioned leptospirosis here. And finally, when a patient comes to a patient of fever with jaundice comes to ER, remember he may be having or he or she may be having sepsis secondary to an obstructive jaundice. So rule out obstruction with imaging, and that will also rule out underlying presence of chronic liver disease. Triaging. Remember, all these patients have to be managed in ICU mandatorily if they have any grades of hepatic encephalopathy, even if it is grade 1. Elevated arterial ammonia, elevated lactates, presence of hypotension or hypertension, even in the absence of encephalopathy, should be managed in ICU. Just talking about ammonia, this is important both for static as well as dynamic monitoring of these patients, because persistently high ammonia are associated with poor outcomes, and decreasing ammonia over the next 3 days is associated with improved survival. Talking about lactates, this patient had a lactate of 6. This is a study which looked at it, 103 patients with paracetamol-induced ALF, 2-time measurement of serum lactate at admission and after resuscitation Both times it was higher in patients who were non-survivors. They even gave cutoffs of lactate 3.5 at admission and 3 after resuscitation, differentiating between survivors and non-survivors. And finally, any high INR, bilirubin level or enzyme level alone should not be an indication for shifting these patients to ICU if they are fully conscious. Thank you. Dr. Dharmesh.
So I think the Kaushal has dwelt on most of the points, except that it would be worthwhile reiterating that this patient has got the SIRS phenomena. So this patient had a pulse of 130, a respiratory rate of 32, and a temperature of 100.6. So we don't have access to white cell count. So it's well recognized that those patients who present like this, and it's very important in our part of the country to rule out the ALF mimics, which Kaushal alluded to, that this patient has got SIRS, and therefore whatever management this patient has to undergo subsequently should all be guided by this particular fact. In this patient's initial lab data, and because my slides are not projecting, I would just read that out. His platelet count, her platelet count was 1.6 lakh. The INR was 4.5. Her bilirubin was 19.5. ALT was 3,500. AST was 2,700. Urea was 9. Creatinine was 1.1. Sodium was 130. Potassium was 4.5. And lactates I had already mentioned, but mind you, they were the lactates at admission, and they should be always checked up again after fluid resuscitation. And as regards the imaging, it was suggestive of acute liver injury. So it was a hypoechoic liver with gallbladder wall edema, no evidence of portal hypertension or free fluid, no other obvious positive findings on an ultrasound scan, which was done in the ER itself before the patient was shifted to the liver intensive care. And amongst the other workup which was done, she tested positive for IgM anti-HEV. So it does not mean that we should not be doing the other tests that you should be doing in any such patient who presents like this. But in this particular patient, all other viral markers were negative. We normally do not do exotic viruses except in some select situations, and one can talk about that. And then maybe if time permits, we can talk about the autoimmune and metabolic workup. The other important thing to remember when we classify these patients is the jaundice to encephalopathy interval, because that is a key determinant of how these patients are likely to respond to medical care, or they might be the candidates for the next step, which we will be talking about in subsequent sessions. So through the other panelists. So this patient's jaundice to encephalopathy interval was about 8 days. And like I mentioned, that she fulfilled the criteria of bad prognostic signs. And maybe Dr. So I think we can pass the baton on to Dr. Vaishali. So Dr. Vaishali, Dr. Kaushal has suggested that this patient should be shifted to the ICU. Can I request you to just run us through with the ICU bundle of care for a patient like this?
So can the organizers show my slides since you have it? Or should I? Neeraj?
Yeah, ma'am.
I suggest you share your screen.
Yeah, I think it is not working well.
It's working. Just try.
Can you see my screen? Can you see my screen now?
Yes.
Yes.
Okay.
Full screen, please.
Full screen, Carlo.
I'm trying that. I am not so good at all this. That's why I was very happy that the organizers had
the green button. First press the green button, I think. Yeah, the green one. That was yellow.
Yeah, now I can.
Green button, yeah.
Sure. So it was not.
And now full screen.
Moving?
Yes, it is.
Okay. Yeah. So just one thing on admission, I would send a blood culture to be, have a baseline status, because sometimes we have found that these patients have come with a blood culture positivity already. So, and in fact, at times we have found Candida already present in the blood, especially considering she has come with such a high grade encephalopathy. I would definitely insist on pan culture blood and urine. Obviously, the pregnancy has been ruled out here because the ultrasound was done. And but yes, I would still send a beta HCG also in a 26-year-old. Now, once she comes to the ICU, Well, this is, I had made these slides for a general perspective, but obviously this lady is with a GCS of 6. This is very high grade of encephalopathy. She also has clonus. So there is high likelihood that there is cerebral edema. There is no question of thinking about protecting the airway. She has to be straight away. I mean, in the ER itself, I would probably intubate, ventilate. While intubation, I would use drugs like propofol, fentanyl, and a paralytic agent. Which paralytic agent? Well, rocuronium, but in liver failure, rocuronium remains in the system extremely long. So I would use cisatracurium. Once the airway is protected, I'm just going to go by the normal way I go in the ICU, A, B, C, D, E, F, G. Breathing, I would ventilate her to normocapnia, low tidal volume ventilation, minimal PEEP of around 5. By low tidal volume, I mean around 6 to 8 ml per kg. Because mind you, here carbon dioxide is the target. So it's very important to give adequate minute ventilation also. And I would also use a volume control rather than pressure control so that there's no compromise on the PaCO2. Circulation wise, she is already in CRRT, but luckily not, her blood pressure is 100/60. So I don't see a need for advanced hemodynamic monitoring, but I would need a line just for access, an art line for monitoring, because she's likely to go into hypotension also. And so many ABGs would have to be repeated sequentially. So art line and a central line minimum at this stage. But if she goes into hypotension, then I would add some advanced monitoring like either a flow track or a PICO, but flow track should suffice. Now, CRRT versus sepsis, as I said, is difficult, but she already is showing signs of CRRT. Then in terms of delirium, sedate and give analgesia also. Endotracheal tube is a painful stimulus. You don't want the patient with a raised ICP, that is cerebral edema, in pain. So I would start her on propofol plus fentanyl. If you start propofol and there is some hypotension, not a problem, support with noradrenaline, but give adequate propofol and give adequate dose analgesia also. Monitor ammonia, arterial ammonia. It depends on the frequency. You can monitor it 8-hourly, 12-hourly. But yes, I would do sequential ammonia readings. Neuromonitoring, considering she's already in GCS of 6, and once we put her on propofol and fentanyl, we'd have to do neuromonitoring closely, either with a transcranial Doppler, ONSD. Pupils is a very crude, and you would catch it at a very late stage. So either a TCD or ONSD. I'm more comfortable with TCD. ONSD has a lot of inter-observer variations. Then E is exposure. Some variably it can be taken as electrolytes also, but I took it as exposure here because it's extremely important to control the temperature, core temperature. Hopefully I'll put an esophageal probe, keep the core temperature 35 to 36. Monitor the electrolytes, sodium. She's come with 130, not so good for her brain. Then monitor potassium, phosphates, and acid base, extremely important. Avoid high degree of positive balance. Mind you, in the first 24 hours, there is going to be a positive balance, but I'm talking this in terms of the first 4 to 5 days, not to have extreme positive balance. And of course, depending upon the degree of encephalopathy, presence of ammonia, and presence of CRRT, a decision to do early CRRT also would help maintain the fluid balance to nearly equal. When it comes to G, nutrition, she's already grade 3. We've intubated her, so we can feed her. In the initial phase, she's extremely hypercatabolic and in CRRT, so I would give on the side of 20 to 25 kilocalories per kilo, and proteins of 1 to 1.5 grams per kilo in the beginning for the first 24 to 48 hours. Mind you, if the patient is in grade 1 and 2 encephalopathy, I am not too averse to delaying the feeding for 48 to 72 hours. These are very young, healthy individuals. They can tolerate not getting fed for the first 4 to 5 days. Lactulose can be given, but mind you, that is only for establishing peristalsis. It has no role in the encephalopathy. When it comes to hemat, there will be no prophylactic transfusions for any kind of procedures. Bleeding risk is low despite the raised INR. The only risk of bleeding is when there is severe thrombocytopenia, and that is also when you should suspect some sepsis already present in the patient. Infection, well, this remains my major role in managing of a ALF patient in the ICU. One is preventing infections. She's going to have multiple lines and tubes. So that remains the biggest focus, is preventing infections using all the care bundles, CLAPC, WAP, COUTI. In also, diagnosing infection can be a bit difficult. And as I said, CRP is hopeless. Procalcitonin can be misguiding. Only cultures can give you some guidance, but you have to have high index of suspicion. And I would have a low threshold for broad spectrum antibiotics and antifungals. This patient, in the beginning, I would probably start a BLI with echinocandin. But if she goes on inotropes, I would quickly escalate to carbapenem, also Targocid with a echinocandin. A word about NAC, very important here. We all of us use NAC. There is no doubt about it in acute. In non-paracetamol etiology also, and it is very well proven that it does have advantage, survival advantage. This is a recent meta-analysis published as recent as last year. And if you can see, around 883 patients were analyzed in 7 different studies. And the overall survival was better, and the transplant-free survival was also better. Normally, I just use this dose, that is 100 milligram per kg, as infusion over 24 hours. But reading the data, I'm more convinced that we should give the bolus on the first 24 hours, like we give in the paracetamol, and then continue with 100 milligrams per day. Now, how? Let me skip this. How long to? So this was the this is the forest plot for overall survival, and this is the forest plot for transplant-free survival in the 7 studies, and more or less they are favoring survival. Now, duration of N-acetylcysteine is the next question. Normally, I would use it for 3 to 5 days. Usually, within sometimes within 3 days the patient gets transplanted, but like in this patient, she's high likely to recover also. So I have not extended ever beyond 5 days because it tends to be immunosuppressive, and it is yet not proven whether it has advantage after the first 72 hours. But this is a study which showed that there may be virtue, but it needs, this was retrospective. And in a pediatric study, it was actually proven that longer NAC durations actually give rise to worse outcomes. So I think beyond 3 days, maximum 5 days, I would really not encourage to extend the NAC because the sepsis might go up. So in short, as the last point about cerebral edema, I think it's a very, sort of simple list. Keep the sodium between 140 to 145 by giving hypertonic saline. Use early CRRT, try to keep the ammonia below 100, I would say, milligrams per deciliter. Mind you, it is not the peak of the ammonia which decides the cerebral edema, it is the time spent above 200. So the one peak of 200 versus patient having more than 200 for 12 hours, 24 hours, that is very injurious. So you should not allow them to spend time on high ammonias very long. Maintain normothermia, hypothermia is really not encouraged, and maintain normocapnia. There are other parts, maintaining lines and all that. I think that is that's just a pure critical care, and I would stop here. And I think that's what I have to say about what I would do in the ICU in the next 48 to 72 hours. Thank you.
Right. So I think your points on the cultures being sent right at the outset, and I specifically mentioned this because this is something that I see all the time in ER, and I made it a point to mention in the history that she had not passed urine for a number of hours. So many a times you will see that the moment you catheterize the patient, the heart rate comes down, and it's not unusual to drain huge volumes of urine from patients with acute liver failure who present with high grades of coma. So Vaishali, just for the sake of people who are logged in, what would be your fluid orders? So you've already mentioned about hypertonic saline. So what would be your fluid orders for a patient like this?
With a 130 sodium, I would still give her normal saline.
Mm-hmm. Right. So no, what I'm trying to ask is how would you give the fluids to this patient? So do you have a set formula based on the body weight of the patient, or
she's going to need some resuscitation in the beginning, considering a heart rate of 130. So maybe she's I don't know what weight is there.
She's 60 kilos. She's 60 kilos and she's 5'6". She's not on the overweight side. And of course, at the same breath, if you could also talk about CVP, because again, many people swear by it. So What are your thoughts on that?
So considering that the lactate is 6.5, yes, she needs fluid resuscitation because this lactate might come down after fluid resuscitation. I'll give her a bolus of around 20 ml per kilo in the first half an hour to 1 hour. So maybe a liter over the first 1 hour. And CVP, now again, this could be blasphemy. I can't say that I rely on the number, but I do use it. Yes, I use the trend. Extremely low CVPs will tell me that yes, there is sort of definitely room for fluid, but I will not say that that's the only reason, that's the only number that indicates to me that the fluid should be given. If this patient develops hypotension, I'll definitely put her onto a flow track monitor, and then based on the PPV and the SVV, I can keep giving more boluses to achieve a decent level of acceptable PPV and SVV. So initially, a liter to 1.5 liters, 1.2 liters in the first 1 hour to 1.5 hours. And then depending upon the response, I may give some more bolus or just put her on a maintenance of 1.5 to 2 ml per kilo per hour.
Right. Any thoughts on colloids versus crystalloids?
The only colloid is of worth any salt, in all these trials are in sepsis, of course. Is albumin, right? And currently with the cerebral edema, no, I would just rely on crystalloids here, because in the presence of, in the SAFE trial, the Australian trial about 5% albumin in resuscitation, the TBI patients did not do well when they were given albumin. So where there is already cerebral edema, I would be cautious about albumin, so I would rely predominantly on crystalloids here.
Would you want to use normal saline, or would you want to use a balanced salt solution along with the hypertonic saline?
So apart from ALF, if any other situation I would use, but in ALF, I would use normal saline only.
Right. And
there will be some hyperchloremia, but I think the priority is sodium here and some degree of AKI because of hyperchloremia. That's the philosophy behind using too much chloride. Maybe a price to pay for keeping the sodium in the right range.
And what would be that for a patient who presents with a sodium of 130 to the ER?
I would still aim for 140. This is an acute situation. So this is not a chronic hyponatremia where I should be worried that it should not quickly go up. I would aim for 140.
And what about the hypertonic salines that are available to us in our country?
Yeah, so I will put her on hypertonic saline and monitor her sodium every 6 to 8 hourly and try and get the sodium in the range of 140 above.
So what sodium solution are we talking of here?
3%, obviously.
Right.
Yeah.
So
the volume we require to give is more as compared to the Western, which is 7.5%. So they give hardly 2 ml and 3 ml. So we need to give higher volumes to maintain the sodium and get the sodium up.
Right. So I think we're trying to pick Vaishali's brain, and she's come out with all the facts. So we would give this patient a hypertonic saline. When we give the patients hypertonic saline, we do not, keep checking the osmolarity, unlike what we do when we use mannitol, and maybe we can come back to the mannitol a little bit later. And it would be a mix of a normal saline or a balanced salt solution with hypertonic saline. You normally need to give a lot of volume, at least 1 ml per kg of 3 normal saline. We do not have the higher percentages of saline available to us in this country. And of course, managing the fluid balance in these patients can be very challenging, because on one hand, you don't want them to be underfilled, and at the same time, you don't want them to be overloaded, because this lady already has got a very high grade of HE. I think Dr. Kaushal put a question in the chat box about the poor man's guide to fluid balance. What are your thoughts on the IVC diameter and collapsibility in a patient like this?
So in a ventilated patient, one can use, so it depends on what stage of resuscitation you are in. If the patient is in shock and requiring inotropes, I would just put in a flow track and go for a more advanced monitoring. If not in shock and not requiring, then yes, I would rely, mind you, the area under the curve for IVC collapsibility on a ventilated patient is just 0.75. So it's not so great in ventilated patients. And when it really matters, I would rather go for a flow track monitor and PPV and SVV. But right. Yes, in a poor man situation, Yes, more than IVC, I would go for 2D echo guided LVOT, BTI, and cardiac output response. That is much more. That machine is the same machine which you use to measure the IVC also. So I'll do the LVOT, BTI, cardiac output, and response to the cardiac output.
Right. So I think there is very little data on this, but few published studies which have shown that both the IVC diameter and the aortic outflow tract velocity time integral, they are poor markers in patients with acute liver failure. The best marker for fluid sufficiency, of course, is the pulse pressure variation. Anyhow, and you mentioned about TCD, again, something that does not find favor in many centers. So what has been your experience and what exactly do you do?
So considering she has come with clonus, I would definitely do a baseline TCD. We were lucky enough. So TCD also is experience based, and you can't allow your ICU fellows to do a TCD. So we got a radiologist always, and we tried to keep constancy in the two radiologists that we had assigned to do a TCD, so that there is not inter-observer variation. And I have much faith in TCD, especially when the diastolic flows start getting a bit slower. And we have been more than ONSD. I do rely on TCDs. Of course, at the same time, they do the ONSD also, because it's a same machine and different probes. But TCD definitely, resistance index has helped us to know whether the brain is getting tighter or not, because there is no other way of monitoring. Luckily, though, now over the last 10 years, my first ALF patient had come to us in a decerebrating posture. Now, I think the general awareness, thanks to all the transplant programs everywhere, we don't see very high grade 4 encephalopathies and decerebrating patients. But we've had major trouble with raised ICP and pupillary dilatations in the first phase of, so I'm talking about 10 years back. But I think now we are going through that same curve which Kings underwent. Is now the grade of encephalopathy is not so bad when they come to us.
Right. So what are your views on, you've already mentioned that we use cis heterocurium. So Shweta, I think Vaishali already mentioned that. So I think in the interest of time, we quickly go on to Dr. Joy. So Dr. Joy, this lady's course in the ICU is that her ammonia, even after resuscitation, is more than 130. And some centers would have that threshold. Of course, Dr. Vaishali suggested a much higher threshold. And 24 hours down the line, in spite of fluid resuscitation, she's come on inotropes and she's on 0.1 mics per kg per minute of noradrenaline. She's passing about 0.5 mils urine per kg body weight every hour. And my question to you is, when do you want the transplant surgeons to come on board? And what would you do in the interim while you are preparing this patient for transplant?
Thank you, Dr. Dharmesh and Dr. Neeraj for organizing a good meeting. So regarding this case, so that ER itself as a clinician, as it fulfills the criteria for the acute liver failure and the King's College criteria for the liver transplant, because that time itself, we will inform our surgical colleagues, but to assess. Of course, we are going to stabilize the patient, shifting the patient and trying to find out the etiology maximum, our level best, and to rule out the associated infection or not, and any other organ failure. Because ALF, even though it says ALF, but it's like a multi-organ failure. Over the period of time, this severe acute liver failure will cause all other organ failure. So we have to seriously look into that multi-organ assessment also. Dr. Vaishali explained the things, and regarding the TCD, actually in our center, we are routinely using that TCD, the middle cerebral artery. We will assess this is the dynamic. So once the patient gets admission, apart from the routine analysis, if the patient got intubated, so after the intubations, only the pupillary reflex and the TCD measurement and the optic nerve sheath diameter, this is the only tool dynamically we can do it. And before to take the case for liver transplant, we can take a CT brain, but while evaluation, the donor evaluation, it will take its own time getting the approval from the government. So even though if there is no donor cadaver, we have to wait. So that time, the TCD's pulsatility index is a cutoff is 1.2. If it is the less than 1.2, it is the good. That also we have seen quite a number. the patient's middle cerebral artery facility index will be the 1.8, 1.9. So over the period of time, due to the anticerebral measures and other things, we can bring down to close to 1.2, but spontaneous recovery of the patient due to the good ICU care, even in ALF settings, we have seen it will come to less than 1.2. And the optic nerve sheath diameter, normally we know it's a 3 millimeter. Whenever it's more than 4 millimeter, so that is the high intracranial pressure. The third one, reverse jugular, that oximetry also. So we will check the reverse jugular raise oxygen saturation, the PaO2. If it is a high, these are the few steps we are routinely practicing in our ICU. And in case if the patients need a donor evaluation, it's taking more time, means normally we will put the ALF patient on CRRT. So irrespective of, even though renal functions are normal, because particularly if you take this case, the high lactate, even at the time of emergency time and the emergency, the admission and all the things, if you look at that, the patient might require the CRRT. Dr. Vaisal already explained that CRRT and other thing. Apart from that, the TEG, usually we will look into the TEG, even the INR is the marker, and we will look into the TEG and we will subject the patient the waiting period, the plasma exchange to stabilize. If we have the donor and we are planning to operate between the 24 to 48 hours, we won't subject the patient for therapeutic plasma exchange. But sometimes after the registering in the cadaver registration for emergency approval or the donor evaluation is taking time, first donor is not fit, suitable that time, to keep the patient stable, we will, irrespective of the etiology of the acute liver failure, normally we will subject the patient for the therapeutic plasma exchange. And so we all know, so when not to do therapeutic plasma exchange also, if you're suspecting this patient has come with a fever, so first of all, we have to look into that. We have to send the culture, we have to see whether the patient has the associated sepsis, procalcitonin, all the things, because already the earlier talk, they discussed about a CRP, procal role in ALF. So we have to look into that, all the markers. If it is patients a suitable candidate, there is no underlying sepsis, lungs are, there is no much lung, sometimes leak will be there, the acute lung injury. There is no much leak in the thing, and at that time we can subject the patient for the therapeutic plasma exchange. And I wish to share few slides only. Okay, so this is just to show the high volume plasma exchange. So this already published in the NEGM, so by the King's College group, but we are not doing in practice high volume plasma exchange. We are normally doing the plasma volume of 1 to 1.5. Some of the center will do 1.5. Our center sometimes will do 1.3 plasma volume exchange. So of course, this high volume plasma exchange, because there is RCT trial, it showed its access a bridge to the liver transplantation. That time also, the irrespective of the whatever the etiology, the plasma exchange it is helping. In southern India, so this is slightly different. In the rat poison, we have done the acute liver failure due to the rat killer poison, so that zinc phosphide. So that time the plasma exchange, our side, it shows the very good bridging tool, or sometimes it's helped to recovery of the patients also. That's the publication. And there are so many the artificial the liver supportive measures are available in market. And but in India, if you look into that, whatever they said, it's earlier the M.I.C.E, Dr. Dharmesh has used in Hyderabad. That time it's almost close to more than 10 years ago. So that time we shifted the M.I.C.E therapy to our patient. But in practice, we have a very limited experience in the usage of M.I.C.E, and we are not seeing much benefit that time. But if you see the literatures, so mostly the M.I.C.E is better. That kind of the literature shows the multi-center trial shows. This is my comment about the therapeutic plasma.
So how many sessions of M.I.C.E and how do you time? How many sessions of Plex and how do you time it? Do you do it back to back on the same day or on successive days?
The plex we will do because it will take 3 to 4 hours. If the patient is hemodynamically stable, and if the patient is not hemodynamically stable, that time you will take more hours. Like it will go for even 6 hours also. So one time if we're done, we'll wait for 24 hours. We won't subject the patient again within the day. And before doing the second plex, so we will check the patients, all the liver function test, INR and ammonia level. There are the papers, our retal patient, that study also showed if there is no much response with plex, the survival is very poor without liver transplant because it's a particular retal. Because if there is a very good response with plex, so the patient, there's a chance to come out without liver transplant, even though they fulfill the criteria for King's College. This is the exception for the retal. It's not for other etiology-related liver transplant. So normally we'll do once in 24 hours. And at that time, we will look into that, what is the pre and the post also.
Right. So
and
I think
what routinely we are seeing is the hypokalemia and hypocalcemia. So that is the very important thing. So they have to frequently, because whenever we are checking the ABG, so we have to look into that hypokalemia, and while doing the procedure, that is commonly, some of the patients, they won't tolerate the flux, that time you have to stop it immediately.
And you use the replacement only fresh frozen plasma, I suspect.
No, it's not like that. Actually, if the patient is acute liver failure setting, even though all the 1.3 or 1.5 plasma volume is not the FOP, so it will come around the 50% with the FOP. Remaining will be the 2/3 will be the normal saline, and 1/3 will be the albumin. But if you are going to use the plex in the cholestatic jaundice and other indication where there is no severe coagulopathy, that time you will use the plasma much less. So mostly will be albumin and plus normal saline.
And you did not have any mishaps with trolley in the patients that you treated?
So that's why before to go ahead for the plex, we have to thoroughly assess the lung function. And if we know patient, most of the patient, this kind of ALF will be on ventilator settings. We know what is the FiO2, what is the PaO2, so how the lungs and the X-ray we have taken. And most of the patient will put on the PICO monitoring. So the PICO monitoring is we can assess the whatever the lung congested and the fluid management, everything. So that all will help to manage the patients while doing the plex.
Right. So this patient, in spite of being on CRRT, the ICU intensivist tells the surgeon that the inotropes are going up. This patient underwent, because this patient's ammonia was not settling in spite of being on CRRT, a bedside EEG was done, which did not show any epileptiform activity. The patient's ammonia fell only marginally from 135 to 120. The patient continues to remain febrile, but the cultures are negative. She had a brief period of anisocoria, but again, the pupils became reactive. And by this time, the family has been able to sort out the logistics, and as well as a donor evaluation has been done fast-tracked by the surgical colleagues. And now I invite Dr. Pamecha. So Dr. Pamecha, what would be your take in a patient like this? So what would you be expecting from the ICU team and the physicians by way of optimization? And when do you think would be the right time to take this patient up for surgery?
Dharmesh, she needs transplant. The way she has presented and she has satisfied the criteria on presentation itself. She's got a high INR grade 3/4 encephalopathy, and her bilirubin is high as well. And she has not shown any signs of improvement with the liver transplant. So that in terms of, I think criteria-wise, she's okay to go ahead with the transplant. And in terms of timing, I think if we wait long, in the ALF, there is no point in waiting long. You should just, once you've got this one that the patient is within the criteria, we should just go ahead and transfer. I know you said SIRS is an important thing here. When she came, she was very tachycardic. But SIRS will have an impact on her post-transplant outcome and perioperative management as well. But this may, without transplant, the survival is negligible at the way she has presented and the way she's going. So shall I just share some slide as well?
Yeah, please go ahead.
So can you see my slides? Can you see my slides?
Yes, yes, we can.
Yes, we can see your slides.
And you can hear you. So in terms of selection and outcome, obviously it depends on the severity of cerebral edema, other organ dysfunction, especially kidney and respiratory failure. Then sepsis comes in as a very major thing in ALF patient. This will determine their perioperative course and post-operative outcome as well, and whether they are hemodynamically stable or not. I know you said that the patient has a rising NORAD, but still in her chance without transplant is very less actually. So if she's otherwise okay, I will be tempted to transplant her. In terms of selecting criteria which have been there, I know KCH has been globally used for selecting patient for liver transplantation. But we need to remember that although KCH is very specific, but it has got a very low sensitivity. Even patient who doesn't satisfy criteria in best centers actually, there will be only 50 to 60% survival. So 40% will still die. Still 40% of patients will still die even if they don't satisfy criteria. So people should remember this, and they should use a dynamicity rather than just one-off KCH to decide about transplantation. That's very crux of the thing, because you should not write off patient because they're not satisfying criteria, or just by one reading you should not be going. Then obviously KCH is derived from West, and the presentation in etiology for us is very different from West. And it doesn't take four most important factors in account, that is the grade of encephalopathy, degree of cerebral edema, sepsis, and other organ dysfunction. And these are the most important parameters which will determine the outcome with and without liver transplantation. And also KCH actually doesn't predict outcome after liver transplantation. So KCH it has been used globally, but there are limitations of KCH which everybody should be aware of. Then this is an important slide. This is patient who had grade 3-4 encephalopathy, irrespective of other criteria, irrespective of their bilirubin level or INR level. And I just try to summarize that the mortality actually in this group of patients is still high. When you have grade 3-4 encephalopathy with cerebral edema, the survival is very poor actually in this group of patients. So you can see even King's College, when they published in 2013, it did improve from 5% to 48%. So still 50% die with grade 3-4 encephalopathy, irrespective of other criteria. And this applies to our Indian data as well, from Chandigarh and from AIIMS as well. And the other US center is also published on this as well. Then this is our own data actually on 131 patients with who were satisfying King's College criteria. And these are all comers during the study period. And basically, you can see the mortality even when in the presence of grade 3-4 encephalopathy, even when they are not satisfying any of the criteria, is 25%. And as the number of criteria actually increases, the mortality actually keeps going up. And when you have INR associated with grade 3-4 encephalopathy, then the mortality is almost 80%, more than 80%. And when the combined criteria are meeting, then the mortality goes up to 70% as well. This is again an interesting thing because I keep hearing that the hyperacute do well and they probably don't need transplant. This keep coming up again and again. So this is ILBS data and this is PGI Chandigarh data as well. Even in the presence of hyperacute, there were 34% patients actually who died, and in PGI Chandigarh, 43% died. When you have acute presentation, obviously the mortality is much higher than hyperacute presentation. So all hyperacute actually doesn't mean they don't need transplant. There will be a group of hyperacute patients who will need transplant, and you need to stratify them as well. This is again very interesting, which is based on etiology. So we keep hearing that hepatitis A is associated with a better prognosis, or hepatitis E is associated with better prognosis. But if you look at that hepatitis E with hyperacute presentation, still the mortality is 31%, and acute presentation 50% mortality. And even when we come to hepatitis A, 40% mortality, 86% with acute presentation compared to hyperacute presentation. So this is how it is about selecting patients. So this is our Indian data, and that is what people need to keep in mind when they're deciding transplantation or in acute liver failure. And then coming to transplanting, why people didn't get transplants, or so this is our own data which actually we presented, we published in 2019. At the time, this was 188 patients who met ACH criteria. Out of the 60 and 61 underwent live donor liver transplantation, and the rest actually didn't get a transplant. So the reason for not having transplantation was irreversible complications of ALF in 24%, so which is basically increasing cerebral edema, decerebrating, or ICH, or sepsis, and so they were not considered for transplant, overwhelming sepsis. No suitable donor in the family, which is a big problem because we are relying on live donor liver transplantation, cadaveric transplant still need to pick up more. Then financial constant, and then family not willing. Again, that is a major reason for the patient actually not getting transplanted as well. So these are the limitations of liver transplantation in acute liver failure. You have to work up the donor very quickly in order to survive, in order to save the patient life. But these are things which are there, the logistic and other hurdles which are there, which you need to overcome as well. This is the etiology you already emphasized. Drug-induced and undeterminate actually plays a major part in India rather than viral etiology. And this is what we see more commonly. Although in pediatric group, we see more of viral etiology, but adult it is drug-induced and undeterminate, which is the norm. Then I won't go into this, but just a message from this slide is majority of the patient who comes to us are in grade 3, 4 encephalopathy. There will be very few actually who will be in grade 1 or 2 encephalopathy. That's common with Indian population. They come late to the center. When they come, they are really sick for even for transplant as well. And you can see in this data, which is with the 91 patient which were done the liver transplant. Most of this are live donor liver transplantation. So 15% of them were in shock, nearly 60% of them were in SERVs, 43% of them had cerebral edema on CT scan, and 40% were culture positive as well. And they were on, nearly 20% were on vasopressor support, and 13% actually were on CRRT before transplant, and 16% of them had plasma exchange, and nearly 70% of them were on mechanical ventilation. The median ammonia was more than 250 as well. And these are the outcome. So ALF, we have 70%, more than 70%, which is inferior to the CLD, obviously because of the sickness of the patient. And you can see that the most of these mortalities are in the early post-transplant period as well. And when we look at the reason for dying after the transplant, most of them were because of sepsis and multi-organ dysfunction, but quite a lot died because of diffuse cerebral edema with brain stem death as well. So cerebral edema continues to play a major part after transplantation in this group of patients. And within the multivariate analysis, the persistence of cerebral edema, anapathetic phases, and culture positivity are the major factors which plays an important part in outcome after transplantation. Just a word, last thing about plasmapheresis, because this has been coming again and again, plasmapheresis. So we were looking into how does it impact perioperative course for patient who had perioperative plasmapheresis. So what we have found that the hemodynamics does improve. So the requirement of blood transfusion decreases, requirement of the blood product decreases, and the requirement of inotropic support actually intraoperatively decreases in patients who had preoperative plasmapheresis. And this is pediatric group. This is not adult. This is all pediatric data actually. It is a small number of data, and obviously we need to build upon this data to see whether there is an impact on this. And the day to extubation was better with the patient who had plasmapheresis, and ICU stay was lesser as well in patient who had plasmapheresis. And just one important word, lactulose. Please don't give lactulose to this patient. This becomes a mess. You have massive bowel distension. There is no evidence for using lactulose in ALF patient, and then the abdomen doesn't get closed. You have to put in bagotas, and then the post-operative course actually becomes very, very difficult. And the surgeons who are sitting and listening to this, so obviously aim for a good GRW. Correct the numbers in ALF. Normally, we don't correct the numbers before transplantation in other transplants. But in ALF, it is sensible to correct the numbers before you make a start. Do the hilar dissection first and do the shunt, and then gently handle the liver so that you don't actually release the cytoplasm cytokines and cause more damage, which will lead to cerebral edema, which will actually precipitate cerebral edema intraoperatively. And obviously, you need to avoid the crossing. Thank you very much. Thanks a lot. So this is my brief.
Thanks so much, Dr. Pamecha. And I think because we are terribly short of time, Dr. Nirav, you need to do the last bit. When would you not want the patient to be shifted from the liver intensive care to the OR? So what are your thoughts on not considering a patient for transplant who spent, say, 3-4 days in the ICU? So what would be your take on not taking a patient to the OR?
Well, as a contraindication, I would say to transplant would be obviously who's highlighted pupils or 5.5. You have a situation where patient is celebrating or there are general contraindications like active substance abuse if the patient had, and otherwise one has active sepsis going on. Only few things which I would like to add to what already has been discussed is one is like in this particular patient, I think CRRT should be initiated without waiting for an ammonia. You already have a patient who has come in grade 3, grade 4 encephalopathy. Clinically, there is full evidence of severe brain edema, and this patient one should. And what we are seeing is that if we do not have a ammonia falling in 12 hours, these are the patients who don't do well, and they have to be taken up for an urgent transplant. And if we wait for the dynamic criteria for 3 days, wait and see how the criteria are behaving, I think it will already be too late in such a patient. Another point, just addition, which I would like to make is that one needs to sort out the donor right at the beginning, and there are situations when you do not have in North India at least, you don't get a cadaver, and there are situations you do not have a ABO compatible donor in the family. So you need to use your plasma exchanges judiciously. If you have an ABO incompatible donor, you should, right from the word go, your plasma exchanges should be as per the ABO incompatible donor. And so that by the time the patient is prepared for the transplant, all those things have been factored in. It's very important because later on one would be in a fix when if we do not have a compatible donor.
Right. So thank you very much. And I think there is a message from Shweta that we need to wind up. So just to conclude, I really think that this is a topic which can be discussed for a whole day or even longer because there are so many nuances to this. But just on a parting note, I think this dynamic criteria which have been given from our country only, they probably need a revisit because everybody swears by them. And as was also shown in Dr. Pamecha's paper, there are many patients who die before you can reach that 72 hours of checking whether things are getting better or not. So I think that is something that one needs to bear in mind. And thank you so much for all the panelists. And thanks again, Shweta and Neeraj, for this opportunity. And apologies for overshooting. Thank you so much.
Thank you.
Thank you, Dr. Dharmesh. That was an excellent session and we all enjoyed it. But we have Dean waiting to speak on the current evidence on CRRT and ALF. So I'd like to invite Constantine. Hi there, you're muted.
Can you hear me?
Yeah, we can. So Constantine is Professor of Medicine at Department of Critical Care and Medicine and Gastroenterology at Alberta, Edmonton. So over to you, Dean.
Thank you very much. And I hope everybody can see my slides.
Yes, we can see you and you're loud and clear.
Perfect. Okay. So thanks again for this invitation. And kind of over the next 20 minutes, I hope to build on some of the discussions that you've had over the last couple of sessions. So we'll talk about CRRT and probably a little bit more broadly about extracorporeal therapy in acute liver failure. So as kind of objectives for this, we know that we've discussed kind of extensively the definitions and the different subtypes of acute liver failure. Go over again and kind of emphasize the role of ammonia and intracranial hypertension in ALF. talk briefly about neuroprotection as you've gone over this at length, and then go over the rationale and evidence for continuous renal replacement therapy and step-ups to other forms of extracorporeal therapy. So as you've discussed previously, that acute liver failure can be broadly divided into 3 different subclasses. So at one end of the spectrum, you get hyperacute liver failure, where the timeline between jaundice and the development of hepatic encephalopathy is very short. In Asia, obviously the most common causes of this is acute viral hepatitis, where in North America and Europe, we tend to see more acetaminophen paracetamol toxicities. And classically, these are patients at the highest risk of developing intracranial hypertension, but paradoxically also specifically for acetaminophen, these are patients potentially that have a good survival rate without emergency liver transplant. At the other end of the spectrum, you have subacute liver failure, where these are patients that tend to grumble along for several weeks before becoming encephalopathic and cholestatic. And classically, this is idiosyncratic drug reactions. These patients aren't as likely to develop intracranial hypertension, but also have a lower transplant-free survival. And in general, the decisions regarding to listing these patients tend to be similar with some of the decisions you'll make with patients with cirrhosis. So kind of saying that again, one of the highlights is that etiology of acute liver failure has a significant impact on outcome. And as you can see with acetaminophen or paracetamol toxicity, you've got high rates of transplant-free survival and very low rates of liver transplantation. And in contrast to that, you've got, for example, hepatitis B, and this is data from the US ALFSG, where transplant-free survival is in drug-induced liver injury, where transplant-free survival is significantly lower, and a larger proportion of patients will go on to get transplanted. So, and as mentioned previously, we know that kind of irrespective of the etiology of acute liver failure, that one of the important prognostic factors besides etiology is coma grade. So patients that have a coma grade of West Haven 3 or 4, and these are generally patients with a GCS of 8 or less and often require intubation, have a worse prognosis than those patients with low-grade coma that are still talking to you. And taking that a step further, it's generally unlikely a patient with either grade 1 or 2 hepatic encephalopathy that is able to communicate will have significant intracranial hypertension. So once again, looking at kind of the pathophysiology of cerebral edema and acute liver failure, one of the important things is due to advances, particularly in ICU care, is that the overall prevalence of intracranial hypertension has gone down significantly over the past several decades, and this has been demonstrated in data from different parts of the world. And the reason why we obviously focus on ammonia is that ammonia is a neurotoxin, but also it's implicated in the development of cytotoxic edema or astrocyte swelling with the production of glutamine, and the fact that why we see intracranial hypertension more commonly in hyperacute liver failure is just the rapid accumulation of glutamine, where there isn't the ability for compensatory mechanisms to expel other active osmoles to take place. And we also know that there is a component of vasogenic edema with loss of autoregulation and a disruption in the blood-brain barrier. And really the second hit to this is the pro-inflammatory state of acute liver failure. So building on what's been previously discussed, the concept of cutoffs of ammonia partly date back to this paper from Will Burnell and the King's group, which demonstrated that certainly at a level of an arterial ammonia of 150, rates of intracranial hypertension go up, and particularly at a level of greater than 200. And when you look at this multivariable analysis, looking at independent associations with the development of ICH, it really goes with a lot of the factors that kind of reflect this pro-inflammatory state, including vasoplegia, AKI requiring renal replacement therapy, and once again, high-grade coma, meaning that patients with high-grade encephalopathy are more likely to have intracranial hypertension. So this was kind of discussed at some length in the previous session. So just to highlight again, we've got basic neuroprotective strategies, which are very similar all over the world, that we tend to intubate early for airway protection using drugs like propofol, which are short-acting, don't exacerbate hepatic encephalopathy, and we can do frequent neurologic assessments. We maintain low normal CO2. We know that hyperthermia is bad, but prophylactic therapeutic hypothermia, certainly at levels of 34, have not borne out to be advantageous per se, except in the salvage or rescue setting. So what I really want to focus on now is renal replacement therapy, and particularly continuous renal replacement therapy as kind of the next thing in your armamentarium. So we know that while acute kidney injury is common in acute liver failure, really the role that we see of things like CRRT, it's really as a blood purification technique and not as a renal replacement technique. And we use it for a variety of indications, including volume overload, lactic acidosis, and I'll kind of discuss at length hyperammonemia. And the idea that a continuous low efficiency mode may be advantageous is that you minimize solute shifts that might lead to dialysis disequilibrium or exacerbate intracranial hypertension. You can deal with hemodynamic instability and minimize spikes in ICP. So while I won't go through this at length, you generally have a couple of different options with the use of continuous renal replacement therapy. And often this depends also on the expertise of bedside nursing staff and comfort of the unit. So in its simplest form, you can use something like continuous vena-venous hemofiltration, which really kind of relies on the movement of water across a membrane carrying solutes, which tends to be quite effective with middle molecules. And one of the advantages of this is, or two, I should say, is that you have to give a replacement fluid, which is shown here, which if you turn off the heater on your CRRT machine and you don't warm this to body temperature, often it's easy to keep a patient between 35 and 36 degrees Celsius and maintaining kind of low normal temperature. The other thing is that this tends to be advantageous with removal of middle molecules. As you mentioned before, the other kind of common setup that's used is continuous vena-venous hemodiafiltration, which takes advantage of both dialysis or diffusion of molecules, which is beneficial for small molecules on top of convective clearance with hemofiltration. And I can say, generally, for example, in our unit, often our nursing staff, even though this is a more complex modality, tend to use this quite frequently in other patient populations. And this may just be a quality assurance issue that the technique you use, if there is a lower risk of error, depending on the one that you use. I will say that the one benefit of CVVH is because it is a simpler setup, in many cases, you can get away without giving any kind of anticoagulation to maintain circuit length and circuit life. So in terms of data on the evidence of ammonia clearance with hemofiltration or with CRRT, this dates back to this study from Andrew Slack and the King's group, which back in 2013 demonstrated an overall reduction in about 22% in median arterial ammonia concentration. And I will say that I get a lot of questions from my nephrology colleagues where they'll say, well, with intermittent hemodialysis, you'll get increased clearance of ammonia than you will in a continuous low efficiency mode. But obviously the answer is that in somebody with a tight brain, which may be in a patient that may be hemodynamically unstable, if you exacerbate these other factors that may exacerbate intracranial hypertension, it really trumps getting higher efficiency clearance of ammonia because an ischemic hit to the brain may exacerbate cerebral herniation. So in terms of ammonia clearance, is there any particular benefit to either using CVVH or CVVHDF? And there isn't a lot of data, but this is just a small study from Ronaldo Bellomo's group in Australia, where really the bottom line here, even though this is a small study, is that there really isn't a big difference whether you use CVVH, CVVHD, or CVVHDF. So really, as mentioned kind of before, it really comes down to unit preference. And as mentioned before, you can often run CVVH without any anticoagulation. So, in terms of larger population data, I highlight this study from that we published in collaboration with the US Acute Liver Failure Study Group, which really kind of highlighted one of the practices of the use of CRRT in acute liver failure, which likely actually been going on for some time, that in comparison with patients without the use of CRRT, patients had significant rapid ammonia clearance over the first 72 hours. And probably furthermore, highlighting this awareness that we had that there were significant concerns that intermittent modes of dialysis might exacerbate intracranial hypertension. This multivariable analysis of 1,186 patients with ALF that did not necessarily have AKI after adjusting for markers of severity of illness, it was demonstrated that the use of intermittent dialysis actually increased mortality by almost 70%, where in contrast, CRRT decreased your mortality by almost 50%. So since then, there have been a couple of other studies that have kind of looked at some of the more kind of practice-based techniques of the use of CRRT in acute liver failure. And this is another study from Stephen Warrilow and Belomo in Australia, where they kind of highlight a couple of things that really this gets to the idea that the overall dose of CRRT is important. And what they demonstrated here, that kind of in contrast to the standard uses of CRRT, for example, in septic shock patients, where it's kind of 25 mils per kilo per hour, they were using higher hourly dosages and higher hourly rates of almost 43 mils per kilo per hour. As you can see here, the vast majority of patients they ran without any anticoagulation. And generally, they were keeping lower blood flow rates to minimize dialysis disequilibrium. And what they found in this study was that by early implementation, in particular of CRRT, that they were rapidly able to decrease median arterial ammonia levels in these patients. And furthermore, the number of patients that they were able to get below that 150 cutoff, which was discussed in the previous session, was quite high by day 2. And once again, really what they found in this data was the effect of CRRT on the reduction in ammonia really is significantly related to the greater cumulative dose. So then, and generally similar to what you've discussed before in our center, that's really our initiation, and we often do this as critical care providers. So what are the next steps if somebody is not improving despite CRRT therapy? This was touched on a little bit, the use of the molecular absorbent recirculating system or albumin dialysis. And this was the FULMAR study, which looked at ALF patients in France. One of the things to mention that the median time to getting a graft in France was actually quite short because of their high cadaveric donation rates. And 14 of the 53 patients in this study that were randomized to the MARS arm actually got a graft before they finished their first run. So while this study didn't show a significant mortality benefit, one of the significant confounders is actually transplant. To kind of put that in context, we did a propensity match study of the kind of North American experience through the US Acute Liver Failure Study Group. And MARS was used to a significant degree in about 4 centers out of the 16 centers in our group. We were able to identify 104 patients that, besides CRRT, were then put on MARS therapy compared to 460 propensity matched controls. And it's interesting in this study that after adjusting for severity of illness, including the use of CRRT, that MARS was actually associated with a mortality benefit. So why is there a difference between the two studies? Well, it probably comes down to liver transplant and a competing risk, where a large number of patients in the FULMAR study got transplanted very early, where in this study from North America, the rates of transplant were actually significantly lower. To probably look at what group benefited the most, it's once again most likely the hyperacute liver failure or the acetaminophen patients. And once again, these are patients potentially with a higher probability of spontaneous recovery. This was alluded previously as well, the use of plasma exchange. And as context, our own center has kind of shifted from the use of MARS to plasma exchange, primarily because of cost. As well, we're not necessarily believers in using the greater than 2 blood volumes of FFP. So as you mentioned before, we were using kind of 1 to 1.5 plasma volumes, or for example, a similar protocol for what you would use for a TTP patient. And just to highlight again, really the benefit of plasma exchange is primarily in transplant-free survival. And if you look in this study in particular, it was primarily in acetaminophen patients that have the highest potential for recovery, where if you look in the population that went on to get liver transplant, where a significant proportion of these patients had subacute liver failure, there wasn't as significant a difference. So really one considers plasma exchange, particularly in hyperacute liver failure patients that don't demonstrate improvement on CRRT. And we will mention where you don't necessarily get the blood volumes with plasma exchange. It's not necessarily just ammonia clearance, but it's clearance of pro-inflammatory cytokines exacerbating, for example, vasoplegia. Finally, I just want to say that our outcomes getting better. And I think this interesting study that my graduate student, Andrew McDonald, published last year kind of highlights that over the last kind of 2 decades, when looking at this large US registry, transplant-free survival, particularly in acetaminophen-induced acute liver failure, is getting better. And this is kind of paralleled with decreasing rates of intracranial hypertension and cerebral edema. So we are generally getting better at this. And one of the biggest things that's probably changed over the last 2 decades is more widespread use of CRRT, which in itself was independently associated with improved transplant-free survival. So if we're specifically looking at what has changed in practice over the last 2 decades, it's been the more widespread use of CRRT. So just to summarize, in patients with acute liver failure, rates of ICH and death from cerebral edema have decreased with improved early neuroprotective strategies and improved ICU care. Hyperammonemia and ALF is treated with extra-corporeal therapies and, as mentioned previously, not with drugs like lactulose and rifaximin. CRRT has been associated with ammonia clearance reduction and improved transplant-free survival in ALF. Improvements in hyperammonemia correlates with early use and higher cumulative dose of CRRT, and consider other extracorporeal therapies such as plasma exchange after initial trial of CRRT first. And I'll stop there.
Right. Thank you, Dean, for that excellent presentation. It's always a pleasure listening to you and your talks on CRRT. I can see a question in the chat box. I think if you have time, this is from Dr. Pratik Parekh, Ahmedabad. He asks, what CRRT settings do we need to prefer for ammonia clearance? May I also add on to this, among all the modalities which you have mentioned, what would be your top modality for ammonia clearance in ALF patient?
Yeah, and that's a very good question. So in theory, because ammonia is a small molecule, you could argue that you want some dialysis component. But we find that the bigger challenge actually in ALF patients, because some of them are actually hypercoagulable, that probably the first treatment of choice is actually CVVH, just with hemofiltration. But as an anecdote in our center, even because of nursing preference, we've gone to CVVH-DF. So we're running both half dialysis and half hemofiltration. And if you look at this overall dose of mils per kilo per hour, we would start at 30 mils per kilo per hour, and you would probably run half dialysis and half hemofiltration.
Right. Thank you. Any of my co-chairpersons, would you like to make any comment or ask any question to Dean at this time?
Sanjeev, I'll just ask a question. This is Murugan. You mentioned about using MARS as an add-on to CRRT if there's not good clearance. So do you think plasma exchange will play the same role in the future as add-on, or can you combine it from day one to get better clearance of ammonia?
I don't think you're going to get more ammonia clearance per se with plasma exchange. Really, the bang for buck with plasma exchange, it's the other cytokines and the damage-associated molecular patterns that are probably considered, kind of exacerbating, number one, the pro-inflammatory state and vasoplegia, and then the second thing is kind of the changes in the blood-brain barrier. So, one example how we'll do it is, out of a 24-hour day, 21 hours, the patients will be on CRRT. And then we would take them off for 3 hours and do a 1 to 1.5 blood volume plasma exchange run, which generally you can do in about 3 hours. We do centrifugal plasma exchange with our nephro and hematology colleagues. If you were to do a MARS treatment, generally it's an 8-hour run, which can actually be run on a CRRT machine. And generally, because often after about 8 hours, the filters get saturated, and then the other 16 hours will be regular CRRT.
Thank you.
Thank you. It was an excellent talk, and really thank you very much for being online and at this hour. I'll now hand it over to the organizers. Neeraj, over to you.
Thank you. Thanks, Dean, for a wonderful talk, and thank you, chairpersons, for chairing this session. I think we're extremely late, and that brings us to the end of this meeting. And on behalf of the Liver Transplant Society of India, I would like to thank all the faculty, for joining in and sharing their experience, and all the delegates for registering and being with us this evening. Thank you once again, and good night.
Good night.
Good night.